Good morning, everyone. It's really exciting to be back in person and online with our hybrid format after being online only for the last couple of years. Exciting to see some familiar faces in the audience. Welcome to this year's Northwest Melanoma Patient Symposium, Patient Caregiver Symposium, Science to Survivorship. It's really a privilege to have you here. We do this event for patients and caregivers and families. And so whenever we get the updates of how many people have registered, it's really exciting to see we have a really robust registration this year. I hope you enjoyed the program. So I'm going to start out by introducing my co-chair for this event, Dr. David Bird, who many of you know probably or have seen at prior symposia. What you may not know is that Dr. Bird's history at University of Washington, Fred Hutch, dates back to 1982 when he started as an intern in general surgery. And after some time away volunteering internationally in the late 80s, he did surgical oncology fellowship at MD Anderson in the late 80s and early 90s, but has been on faculty at the University of Washington since 1992. He points out it's not quite 31 years, it's still 30 plus. He wanted me to make that clear. So currently he's a physician at Fred Hutch and a professor of surgery at the University of Washington. He's also the section chief of surgical oncology for University of Washington Medicine. So my privilege to introduce Dr. Bird.
Thank you, Evan. And I'm seeing several familiar faces out in this audience. Just a real quick show of hands. And I know we virtually, you may be able to look virtually at the people on for show of hands. How many people have been to one of these symposia here before? Okay, looking at half to 2/3 faces that look very familiar. Many of you have been to many of these. Has anybody been back to the first one in 2006? Wow. So this is an event for patients and families, as I think you all know. We have some providers who show occasionally. I'm amazed that more of them don't show because they would learn a ton, and they would learn a ton from you all, but it's for you all, and it always has been. The Science to Survivorship theme is one that science has always changed. We have to have that as a theme, but to leave out survivorship leaves out many things that are as important or sometimes more important to those of you out here that providers know a lot less about or address much less frequently than they do the science part. So that's why we kept the same theme. We've got a collection of speakers today. Most are in person. We have our two keynote speakers are virtual. One of them was in New York and already had a Memorial Sloan Kettering and already had another commitment. The other one was going to be in person, who's going to talk about the adverse events, and had an arm fracture, right? So appropriately is not flying here from that. But everyone else, I think, is going to be here in person. And to have this be in person again, at least for those of you who are here, and those of you virtual, welcome to come next year in person. We're just delighted to see that. I'm glad the room is not full because this way you can space yourselves in a way that you're comfortable. I have a mask on. There's some immunocompromised situations in my own household, and I'm going to try to have this on when I'm sitting or around, but off when I'm speaking. You are welcome to wear a mask if you want. You're not required by Fred Hutch or others to wear a mask, depending on your comfort level. And please respect both those who want to wear masks and those who don't. We feel very strongly about that. The start of this was 2006. The reason why I can remember that is because my co-chair, and you may remember this, who were there at the first one, was Katie Bunker at age 16. Those of you who've been here before heard about Katie. She was my co-chair, a 3-year survivor at that time of node-positive melanoma. And here she was, a high school senior with no evidence of recurrent melanoma. She went on to become a nurse at Children's Hospital and came up here 10 years later. So that was my co-chair. She took down the room. So anybody who followed Katie Bunker was at a major disadvantage. I just want to mention another thing, which is the co-chair of having Evan Hall is important for 2 reasons. Number one, one of the best medical oncologists I've worked with, and really a thoughtful medical oncologist and a great colleague in terms of communication and working through what's right for a patient. But most importantly, this world is changing from a surgical world to a systemic treatment world. I would love to know that there is no role for surgery in the management of melanoma. With reduction in side effects and potential complications of systemic treatment, but that is clearly the shift. So to have Evan as my co-chair and will be chairing in the next couple of years is very appropriate to have the systemic view of this front and center. So I think with that, we're going to want you to fill out your evaluations, and you want to go through the slides here and then introduce the first speaker. Thank you all for coming.
So this is a what's in store for us today. I think it's a great program. We've thought long and hard and taken feedback from prior symposia about what topics would be useful to have. So several of today's topics were actually suggestions in the last year or two by those who'd attended about topics they'd like to see. So to echo what Dr. Bird said, please fill out the evaluations. We look at those closely and we use them when we're designing next year's program. So this morning, we're going to hear from the Melanoma Research Foundation, a very influential patient advocacy organization in the land of melanoma, who's also our co-partner for the event. I'd like to take this opportunity to thank them for their sponsorship and also providing the catering for today's lunch. So many thanks to the Melanoma Research Foundation for their ongoing partnership. We will then have our first keynote speaker with Dr. Sharif, an endocrinologist from Duke, talking about some of the long-term side effects of immunotherapy in terms of the endocrine system. We'll then hear about sleep with Dr. Phipps from our own Fred Hutchinson Cancer Center. We'll have a break, our second keynote speaker with Dr. Arian from Memorial Sloan Kettering, and then talks on lymphedema and rehabilitation, as well as a medical oncology talk on mucosal melanoma, a rare subtype. Then we'll break for lunch and have two more lectures after lunch. One about fear of cancer recurrence and progression with Dr. Bates, and one about surgery focused on patients with head and neck melanoma with Dr. Marciano. Then we'll have our patient stories, and I think for those who've attended in the past, this tends to be really the highlight, I think, of the event. That's why we save it for the end, to end on a high note. So we have two patient stories, and then we'll wrap up shortly after 3 o'clock and try to get everyone out to enjoy some of what looks like a beautiful day out there. So a few notes. This event will be recorded. So if you're asking a question in the chat or online and you want to include personal details about yourself, that's fine, but just be aware that this will be recorded and people will have access to the recordings. Those who've registered for the event will have access to the recording. So just to be thoughtful about what you don't mind sharing in that forum and venue. For those that are online, using the chat function in Zoom, that will be how the best way to ask questions. We will try to get to as many of those as we can at the end of each session. You can rejoin the webinar if you accidentally disconnect. We'll try to do the question and answer at the end of each talk. So for those that are in person, we'll have some microphones circulating. Raise your hand and we'll make sure we get your questions answered as best as we can. And then one more call to fill out the feedback form at the end of the event. We'd love to know what worked. We also want to improve and make each symposia better than the last one. So this is a great way to make sure that we achieve those goals. So with that, I will turn things over to our first presentation from the Melanoma Research Foundation. I'd like to introduce Amanda Cisco, who is the Partnerships and Clinical Engagement Manager for MRF. Thank you.
Oh, no, I'm the other Amanda. Perfect. Hi, everybody. My name is Amanda. I'm the Partnership and Clinical Engagement Manager with the MRF. We're so happy to be here. Thank you so much to Evan and Dr. Bird for having us. This is one of our longer running and most favorited partnerships that we have. So the MRF was founded in 1996 by Diana Ashby, who is diagnosed with melanoma. Oh, why is it going so? There we go. Who is diagnosed with melanoma and after a 3-year battle found that there were no options for clinical, not sure what's going on.
You probably need to, yeah, stop the slideshow. Yeah. Do the slide transitions.
There we go. Okay, so I'm gonna catch up again here. Okay, so we came into the research arena and we're very strong, and we felt that there was also a need for more education and advocacy. From that birthed our mission to eradicate melanoma by accelerating all medical research while educating to and advocating for the melanoma community. Hey, I got through one. So here's our footprint today. So we have events all over the country, over 19 5Ks in different cities. We have 2 signature galas each year. We have about 7 patient symposia a year. We bring patients and caregivers to DC to talk with congressional leaders about what's needed and why more funding is required for melanoma. We also have a pediatric and adolescent young adult conferences that we are focusing on the entire community rather than just a specific subset. We also host patient symposia for the rare subtypes of melanoma, which are pediatric, mucosal, ocular, and then there's acrolentigen. So some of the research that we're funding right now, we have team awards, established investigator awards. We do peer-reviewed research grants. We funded over $23 million in research thus far. For education, so this is something we take very seriously. Our education is not just directed toward the patient themselves, it's directed at the patient's caregivers, their family, friends, their providers, anyone really. We want to make sure all of the information about what your options are, what you might experience, and what the process is for you. So we have some great animated patient videos, some guides for your process, all the things. We also host Ask the Expert webinars monthly, where we bring in, key opinion leaders from across the spectrum, clinical research, like Evan, medical oncology, radiologic oncology, all the different subsets. We want to make sure everybody's opinion is brought in and we're getting all of the information to the right community. Advocacy, like I talked about, we bring patients and caregivers to the Hill every year to meet with congressional leaders. We also sit down with the FDA and talk to them about access to clinical trial drugs for rare cancer patients. We're also working on the Cancer Moonshot to increase funding for cancer research. We did the virtual advocacy days last year, and now we are back in person. We have our prevention and awareness campaign. So this year, this month is Melanoma Awareness Month, MAM for a lot. Our spokesperson for our Get Naked campaign is Teddy Mellencamp from Bravo. A lot of you might know who she is, John Mellencamp's daughter. We have our I Get Dilated campaign, which November is I Get Dilated month. We have our Spot the Dog for the pediatric cancer awareness. And we have the Out of the Shadows campaign for our mucosal. With that, here are our social handles. If you want to follow us on social media, we'd love to have you. If there are any patients who want to tell their story and really want to get it out to the public, we'd be happy to elevate your voice for you. Please let me know and I'm happy to give you my card. And if anybody didn't get a folder with our information on current research and things like that, how to get some of our educational resources, I'll see you at the table outside.
I'm very excited to introduce our first keynote speaker this morning, Dr. Afreen Sharif. Dr. Sharif is an endocrinologist by training and is the director of the Duke Endo-Oncology program. So she has an endocrinologist with a specific interest and expertise in the endocrinology management of side effects of patients with cancer. She is the Associate Director of the Cancer Therapy Toxicity Program at the Duke Center for Cancer Immunotherapy, and is also the chair of the Oncoendocrinology Special Interest Group with the Endocrine Society. So many kind of titles, and really a rising star in the way we think about managing the side effects of patients who've received cancer immunotherapy. I actually first encountered her. She's also the host of a very popular, important podcast called Checkpoint Now, which I think you'll be hearing about at the end of her talk. So she's really remarkable, and it's really very exciting to welcome her to give our first keynote titled Living with Endocrine Toxicities from Checkpoint Inhibitors. Dr. Sharif, welcome.
Thank you, Dr. Hall, for that kind introduction, and it's such a pleasure to be here. I apologize ahead of time that I'm not able to present in person, but we'll do my best from across the country. So let me try with first starting off with sharing my screen and see how this goes. So we shall, all right. So I hope everyone is able to see my screen here. I'm unilaterally challenged, and I'll tell you exactly why in a few more slides, but let's try to put this on a slideshow mode. All right. Is that working well?
That looks good.
All right, fantastic. So first off, thank you all for inviting me here today to talk about one of my favorite topics, which is endocrine side effects from checkpoint inhibitors. And as I mentioned earlier, I was supposed to be here in person, but life had other plans. A couple of weeks ago, I was in an enthusiastic game of pickleball and injured my right dominant wrist, fractured it, and ended up having a surgery and some plates, titanium plates, placed in my right wrist. So behold, I recruited my 10-year-old son to scribe for me for this presentation. So when life gives you lemons, you make lemonade. So having said that, I'm delighted that because of the technological advances we have today, we are still able to stick to our commitments and present from across the country. Now, that being said, let's get started. These are my financial disclosures, and those are my Twitter handles for those of you who are Twitter enthusiasts. Let's get started. So when I think of immune checkpoint inhibitors, from my simple way of thinking of it, I think of it when I'm driving my car the first thing in the morning. I think of my foot off the brake and my foot pushing the gas pedal, and my immunity is now riding at 100 miles an hour in a 40-mile zone. What I'm really good at then is killing cancer cells, but in the way, I do have some accidents that can occur along the way. And immune-mediated or immune-related adverse events are accidents that occur along the way. And one such common side effects that we see is endocrine toxicities. Now, endocrine toxicities can present commonly with fatigue, and lab abnormalities are quite confirmatory for most cases. Now, steroids, different to other toxicities, are not commonly recommended. And endocrine toxicities end up being chronic diseases. So now your endocrinologist becomes your new best friend. So I'll be talking about 3 very common cases that we encounter in the endocrine or in the hormonal world, which are immune hypophysitis, autoimmune thyroiditis, type 1 diabetes. And I'm going to walk you through some of the case-based scenarios in how patients present, how we diagnose these cases, how we treat them, and what that would look like living with it in the long-term sense. There are fewer or rare endocrine toxicities that I would not be hitting on too much in detail. And these include primary adrenal insufficiency, which is a deficiency of cortisol that arises from the adrenal gland, Graves' disease, which is an overactive form of thyroid disease, and autoimmune hypoparathyroidism, which is a deficiency of something called parathyroid hormone that regulates your calcium, and patients can have low calcium. Again, in my 8 years of doing this, I have not encountered a single case of this, so it is exceedingly rare. So moving on, let's start with our first case of immune hypophysitis. Now, this is a 65-year-old female with a diagnosis of metastatic melanoma who was started on a combination of ipilimumab and nivolumab and was referred to endocrinology with complaints of severe fatigue, headaches, and an abnormal pituitary or brain MRI. This patient was diagnosed in October 2018. A couple months later, started on combination ipi and nivo. A few months later, probably about a month later, had decreased masses in bone mets. That means having a good response. And then shortly after, presented with fatigue, headaches, and vision changes, and an abnormal brain imaging or an MRI. And this is where endocrinology was referred to. And adrenal insufficiency can come in different shapes and sizes. And we're going to go through how common this is, what are the different types of adrenal insufficiency, what are the symptoms, how it is diagnosed, and what happens once you get diagnosed, how is it treated, and what does it mean to you in the long term. So immune hypophysitis or adrenal insufficiency can be seen in about 4 to 11% treated patients, and really depends on which studies you pick up. The earlier studies had a slightly higher incidence just because we were treating a lot more melanoma patients with monotherapy with ipilimumab, so we had a larger number. That number has come down eventually. We still end up seeing somewhere between 4 to 5% patients being treated and getting these type of side effects. Now, when I said immune checkpoint inhibitors can cause different flavors or different types of adrenal insufficiency, what I'm pointing towards is that it can cause 2 different defects. One can be a pituitary defect, which is a CEO or a mothership of all your hormones. It sits right in your brain, nicely nestled inside a bony chamber that tells you that it is a really important structure. And when I say CEO or the controller of all hormones, what the pituitary gland naturally or normally does on an everyday basis is sends out multiple thousands of emails to different hormone producing glands, including your thyroid gland, including your adrenal gland that sits right above your kidneys, to your testicles, to your ovaries, to tell it what to do, how much thyroid hormone to make, how much cortisol that comes out of the adrenal glands it should be making, how much testosterone needs to come out, and how much estrogen needs to come out. So pituitary gland, think of it as a really important hormone producing or signal producing gland that regulates all your different hormones in your body. Now, this is most commonly affected by checkpoint inhibitors. Now, when you go onto Google and you look at Google MD, the first thing that pops up when you type adrenal insufficiency is Addison's disease. And that oftentimes confuses patients because when they come over to see me, they're like, do I have Addison's disease? And I'm oftentimes explaining this concept to them that yes, you have cortisol deficiency that can occur from both pituitary defects and adrenal defects. But adrenal defects, when they occur, they're exceedingly rare. They're less than 1%. Just anecdotally, I have hundreds of patients with pituitary defects or pituitary effects of this drug versus just 3 patients who have defects of the adrenal glands, which is Addison's disease. They're treated slightly differently, and I'm going to walk you through a little bit about how that looks different. The things I want you to remember from this slide is that the defect that commonly occurs with checkpoint inhibitors is in your pituitary gland. And pituitary gland is your CEO or the mothership of all your hormones, is a major regulator, and it looks like an onion. Not technically looks like an onion, but acts like an onion. You have different layers, and each layer controls different types of hormones. So moving on to our next slide, how would you feel if you have adrenal insufficiency? Tired, tired, tired. And when I say tired, I don't mean I wasn't able to mow my lawn today. I was able to do that 2 days ago. When I say tired, I mean exceedingly tired to the point that you'd rather pee in the bed than go to the bathroom. That's the kind of fatigue, the degree of fatigue that patients with true adrenal insufficiency experience. Patients can have weight loss, especially in a shorter time frame. They have food aversion. Think of a pregnant patient, a pregnant person you know, a friend, a family member who tells you, I look at food and it makes me feel nauseous, right? That's the kind of feeling a lot of patients experience. Now, everyone doesn't have all of the above, right? Some folks have some symptoms, some folks have other symptoms, some symptoms are more prominent than others, but it kind of falls under the same umbrella. A lot of my patients have reported head in the clouds feeling, that they feel like they're part of that conversation, but they're really not processing that information. That's how they describe their feeling. I feel like my head was in the clouds and everything was just unclear to me. They also feel lightheaded, dehydrated. They can complain of abdominal pain and diarrhea. Now, what's unique to immune hypophysitis or the pituitary defect is that because the pituitary gland gets inflamed and gets enlarged, folks can have headaches and vision changes just because of the pressure it creates in the brain. That is very significant or very, I would say, specific for what we're dealing with the pituitary gland rather than with the adrenal gland. Now, with the adrenal gland, we see something called a tan skin appearance. I'm going to tell you in the next few slides why that occurs. It almost seems like someone went to Aruba and came back from a nice vacation. And you talk to them and they're like, nope, I've just been right here. Nothing has changed. And I started seeing that, my friends started noticing it, my family started noticing that I look darker skinned. So moving on to how it is diagnosed, right? So patients are going to come and they're not going to tell you, I have adrenal insufficiency. You're not going to come to your doctor and say, I have adrenal insufficiency. You got to test me for this. You're going to come in with those symptoms that I talked about. I'm tired. I was feeling okay until 2 weeks ago, and now I feel very, very tired. I just don't want to do anything that I used to do before, right? That's the kind of symptom you're going to go to your oncologist or your other doctors and talk to them about. And what we're looking at from a perspective of providing care to you, we're looking at what your blood pressure looks like. What was the trend of the blood pressure? Did it drop significantly around the same time that you started having these symptoms, right? Was there a drop in weight? And the good thing is that you're seeing your oncologist fairly frequently. You're seeing them every 3 weeks, every 6 weeks. So we have lots of data points that we can actually go back on and refer back to look at these trends. The other test we're looking at is a low sodium, a normal or a high potassium, a low cortisol. Remember, whether your adrenal glands get affected or your pituitary gland gets affected, both of them will result in a low cortisol. But what we're ultimately looking at is to put you in a bucket. Which bucket do you belong to? The pituitary defect bucket or the adrenal defect bucket? And that is determined by another lab test, which is called ACTH. I'm going to explain in the next slide what that means. Now, in endocrinology, we love pathways. We love connections. We love crosstalk. All the hormones are harmoniously working with each other, kind of talking to each other based on the needs of your body. If I have a need, my pituitary gland starts secreting something called ACTH that travels down south through the blood, goes to my adrenal glands, which are adjacent to the kidneys. That's why it's adrenal. It sits right above your kidneys. So you have 2 adrenal glands. It tells those adrenal glands to make a very important stress hormone called cortisol. Now, when the pituitary gland is affected, the ACTH or the email that comes out of the pituitary gland no longer comes out. So you have a low ACTH and a low cortisol. That is your stress hormone coming out of the adrenal glands. But when you have a defect in the adrenal gland, which is down south, which again, remember is very rare, you have less cortisol coming, but you have lots of emails coming from the pituitary gland because the pituitary gland senses that something is wrong. Something is wrong. The body needs more cortisol and the adrenal glands are not making enough. So I got to send 1,000 emails a day, 500 emails a day to make sure that adrenal gland is doing what it's supposed to do. And that's exactly what we're looking at. We're looking at what is the level of ACTH, what is the level of cortisol when we diagnose folks and put them in those buckets of pituitary defect versus adrenal defect. There is another layer of testing that is typically done in an endocrinologist's office. Again, oncologists do offer this. I would be very happy if this is done by oncologists at Seattle. We do try to get this done at our oncology practices, but sometimes it gets done well, sometimes it doesn't get done well because this is not a common test that is done in oncology practices, but very common to our practice. We do this probably I get about 2 or 3 co-centrogen stim tests per week. So this is quite common in our practice, and I'll tell you what that looks like. If any of you have been diagnosed with adrenal insufficiency in the audience or have known someone with this, there is a different kind of test that we get done. Ideally, around 8 o'clock in the morning, we want our patients to come in. We get baseline or time 0 tests where we get the ACTH and the cortisol, because remember, I want to put you in those buckets, pituitary versus adrenal. And then we give your adrenal glands a nice horse kick in the form of an ACTH shot. So we give your adrenal glands in the form of an injection that goes into your muscle or into your IV. That is a horse kick to the adrenal glands, or 1,000 emails that tell the adrenal glands, you got to make cortisol. And after 60 minutes, we wait for the adrenal glands to respond and get another cortisol test done. So you get 2 blood tests, 60 minutes apart. We look at the relative difference between the two, and we're looking at a particular number about which we say you have adrenal insufficiency, you don't have adrenal insufficiency versus you have adrenal insufficiency. So this is a sophisticated layer of diagnosis that is typically done at an endocrinologist's office, but it really puts a tag on what type of disease you have and really confirms the process that is happening. Now, how is this treated? Now, in our practice, the way we think of it, if the patient is not able to make a particular hormone, we replace what you can't make. And the good thing is that the hormones that we are able to manufacture are very similar to what your body naturally makes. So if your body can't make cortisol, we give you cortisol. If your body can't make thyroid hormone, we give you thyroid hormone. If your body cannot make testosterone or estrogen, we give you testosterone and estrogen. And depending on which bucket we put you in, whether it is pituitary defect or adrenal defect, you get a combination of different hormones. And also which layer of that onion is affected. Is the cortisol layer affected? Is the thyroid layer affected? Is the testosterone layer affected? You either can get one of these drugs or you can get multiple depending on how many layers are affected all at the same time. But treating adrenal insufficiency is, I would say, kind of where the art of medicine plays in. This is a very insightful phrase from Sir Dr. William Osler. And I'm going to repeat this here. If it were not for the great variability among individuals, medicine might as well be a science and not an art. And this is where you take the art of medicine to the next step, is when you're wanting to treat adrenal insufficiency. Treating adrenal insufficiency is like walking a fine thread or a fine rope. You don't want to overdo it. You don't want to underdo it. Both places patients don't do well. So it's a fine art to figure out, and there's no blood test, unfortunately, to figure out what is an optimal dose for patient A, patient B, and patient C. It's more of a dialogue between me and my patients to ask them, how are you feeling? How's your energy level? I ask them on a scale of 1 to 10. 10 is where you were before you got diagnosed with adrenal insufficiency, not before your cancer diagnosis, because that is a completely different baseline we're dealing with. Before your diagnosis of adrenal insufficiency, your energy level was 10. Where are you at right now? Those are the kind of questions I'm asking in a very objective fashion to figure out if we're actually giving the patient the right and optimized dose. And there are 3 layers of dosing, and you really want to be in that middle tier that I'm showing in green, which is the therapeutic dose. That is a dose where most people tend to feel good. And when we're talking replacement, we do either prednisone or hydrocortisone. We prefer hydrocortisone, and I'm going to tell you why. Hydrocortisone is a very biosimilar hormone to what your body naturally makes. It's a shorter acting hormone, and you want to simulate what the body used to do before you developed adrenal insufficiency. Now, before folks develop adrenal insufficiency, in everyone else sitting in the audience today, we make 2 peaks of cortisol every day. You wake up in the morning, your body says, go, go, go. You need some stress hormone to tackle the day. So the first peak occurs around 8 o'clock. And then after lunch, you hit that kind of siesta point after your fiesta, and your body says, hey, you got to wake up. You still have the rest of the day to tackle. So it makes a second peak around 1 to 2 p.m. And that is how we treat patients with adrenal insufficiency. We give you a nice big dose at 8 o'clock in the morning and a smaller dose between 1 and 2 in the afternoon. And there's a reason for that. If you're talking to your oncologist and your endocrinologist, why am I taking these odd doses? Why am I taking 10 in the morning and 5 in the afternoon? This is exactly why. We're trying to simulate what the body naturally used to do before you developed adrenal insufficiency. And the doses have to be in the right kind of frame. When we talk about hydrocortisone, 15 to 30 milligrams, prednisone is about 5 to 10 milligrams. Higher than that is super therapeutic, where you start developing side effects, or you could develop side effects. And subtherapeutic is where you don't feel you're optimally treated. You have ongoing fatigue. I feel very tired. I'm just not able to do my everyday activities. I'm struggling through the day. This is not what I want to hear my patients saying. That's when I'm really thinking, am I dosing them correctly? Is there something else I'm missing? Is there a thyroid abnormality I need to check for? Is there a testosterone deficiency that I need to treat? This is where I'm digging deeper and trying to find out why my patient is not very optimized. Now, when we talk about dosing, there's a second layer of thought process. So when you go to your endocrinologist's office and you go to see them for the first time, they're typically talking to you about a 3-tiered dosing model, where you have a baseline dose, which is what you take every single day. This is something, for example, if I start my patient on 10 milligrams of hydrocortisone in the morning and 5 in the afternoon, this is something you take every day, no matter what happens, right? And then there is a step up layer, which is sick day dosing. This is when you're sick enough to go to the doctor, sick enough to take antibiotics, the flu, COVID, urinary tract infections, a common cold. These are times where you start feeling that your stress hormone requirements go up. And remember, because we've boxed you into these doses of 10 and 5, you cannot make any more on your own because you're just unable to. Your checkpoint inhibitors have destroyed the glands that were supposed to make this. So when the body requires a higher dose, you have to take a higher dose to compensate for that. And that is a sick day dose. And when you're going for surgery, whether it's major or minor, you really want to talk to your endocrinologist to figure out what that would look like. And the dosing may differ depending on the complexity of the surgery and what it entails. There's the third layer, which is an emergency shot. So think of it as an EpiPen. For adrenal insufficiency, when patients are unable to take pills, keep them down, they're sick enough, they're so sick that they're just not responding to sick day dosing because they have not been able to compensate enough for the degree of stress that they're having, that their body is undergoing because of an illness. This is a shot that is given to all our patients. You carry it with you. It's a hydrocortisone IV IM form. You take it, you inject it. We teach the families to do this. What it does, it buys you time to go to the ER. This is not something you want to take and stay at home. If you get to this point, this is where you say, I got to go to the ER. It just buys you time to do that. Now, in addition to this, based on the feedback that I've gotten from my patients, I am an active student. I learn from my patients. I hear them. And cancer patients are different because they're not living a regular life like everyone else does. They're having an MRI done in the morning. They have their infusion in the afternoon. They have their regular life to live in addition to that. So they have a lot more on their plate, plus the stress, anxiety, and emotional stress that goes along with having all of the above. So there is an additional layer of treatment that I allow my patients to take, which is called extra dosing. These are days that I've heard from my patients at day 1, day 2, day 3. After their immunotherapy, they feel tired. They feel worn down, especially the ones who have adrenal insufficiency. So I allow them to take an additional smaller dose of hydrocortisone to compensate for this. So they're not chasing their tail for the next week. And they overcome that hurdle within 1 to 2 days because they've kept up with their heightened stress that their body is going through. Now, this is not validated with studies. It's not validated with the randomized trials, but it's something I've learned to do with my patients, and they responded really well. Now, moving on to prednisone and hydrocortisone. This is a common question that comes up. Why am I on hydrocortisone? Why can I not be on prednisone? Why should I be on prednisone? So most of my patients are on hydrocortisone for the reasons I mentioned earlier: physiologic, short acting, you can simulate what the body naturally does. But prednisone is not a bad option in some patients, especially if you're treating, say, rheumatoid arthritis from these patients, from these other agents. Checkpoint inhibitors can cause other inflammatory issues. And are you treating two things? Are you treating adrenal insufficiency with, say, rheumatoid arthritis? Then prednisone is a better choice. If you are dealing with someone who is forgetting to take it, so busy, they have a job, they have kids to take care of, and they can't remember to take their afternoon shot, and they keep forgetting it, and they are continuing to be tired, prednisone can be a drug of choice because it's once a day. But you have to be mindful to treat it appropriately with the right amount of the lowest possible dose that you can give, because prednisone does have a higher side effect profile when it comes to weight gain, diabetes, bone loss, especially at higher doses, not at physiologic doses, but at higher doses. So let's talk about the most common question I get asked when patients come into clinic is, what now? What now? Can I continue my immunotherapy? Absolutely. Is this going to get better? It really depends on which layer is affected. If you have adrenal insufficiency and you have ACTH deficiency, the chance of recovering that is really nil to negligible. I have tried many times, especially in patients where I have a doubtful diagnosis, where I don't know which bucket they fell in before steroids were started. I tried to get them off of steroids with slow tapers. If they have true adrenal insufficiency, they do not tolerate a steroid taper. So if you have real adrenal insufficiency from these drugs, the chances are you're going to remain on this for the rest of your life. Now, with thyroid and gonadal, that means testosterone deficiency, the chances of recovery is about 40%. So I've seen that happen in a lot of my patients. And you're going to see in this case that I'm going to talk about that the thyroid axis also recovers. So in conclusion, for this particular case, the patient continued on treatment for a few more months. Now was in remission for greater than 4 years. The patient was treated with 60 milligrams of prednisone initially and then switched to hydrocortisone. The reason for the high dose prednisone is because your pituitary gland was swollen. We wanted to shrink it down initially before we put you on replacement or physiologic steroids. The patient was started on levothyroxine and then over the span of a few months, got off of levothyroxine and has not required to take it in the last 3 years, continues on steroids, but doing well otherwise. So with that, I'm going to close the case of adrenal insufficiency and move on to our next case, which is a case of autoimmune thyroiditis. This is a 66-year-old Caucasian male with a history of metastatic melanoma, with metastatic disease to the liver, lymph nodes, presents with fatigue, 18-pound weight loss over 2 months, altered mental status, and ongoing diarrhea. The patient was diagnosed in 2015. December 2015 started this combination of agents, and then February, a couple months later, was admitted with autoimmune colitis, which is a immune-mediated adverse event or another accident that affects your gut and causes you to have diarrhea. At the same time, was noted to have abnormal thyroid tests. And this is when I was consulted. I was a fellow back in the day. We're talking 2015. So I was really excited about seeing these patients because I really learned so much about regular endocrine disease and also learned it in a very complex fashion. And I loved the physiology, the science, and the impact that that would make. So moving forward, let's talk a little bit about thyroid diseases from checkpoint inhibitors. Again, moving on with the same kind of plan that we did with adrenal insufficiency, how common this is, what are the types of thyroid disease you can see, symptoms, diagnosis, course of the disease, what happens when you get diagnosed, how is it treated, and what does that mean to you in the long term. So the thyroid disease is by far one of the most common endocrine toxicity that you can see. It's seen in about 10 to 15% treated patients, and patients who have family histories of thyroid disease tend to get it more often than those who don't, and also tend to get it more in the earlier treatment cycles, more so than those who don't have a family history of thyroid disease. Now, when I mentioned earlier with adrenal insufficiency in endocrinology, we love pathways, we love connections. So I'm going to talk a little bit about that same connection, but now not the connection between the pituitary and the adrenal. We're going to talk about the pituitary and the thyroid gland, a little shorter distance that it has to follow this time. So the other layer of the pituitary gland makes something called TSH, which is thyroid stimulating hormone. So it stimulates the thyroid to make something called T4 and T3 that the body understands as thyroid hormone. So when the thyroid hormone is unable to make thyroid hormone, and when the thyroid gland is unable to make thyroid hormone in the form of T3 and T4, the pituitary gland gets a signal that the body's struggling. There's less T4 and T3, so the thyroid gland needs to step up its game. So I'm going to send more emails to the thyroid gland to make more T4 and T3. And that is when your TSH number or your emails go up, when your T4 and T3 is low. Now, on the flip side, when your thyroid gland is making too much thyroid hormone, it tells the pituitary gland, hey, we got this. We're making way too much. I don't need you to send me any more emails. Boss, I got this. I'm doing my work. I'm overdoing my work, in fact. So that's the kind of connection we're looking at when we're testing you and we're looking at different kinds of diseases. Now, in that same flavor, there are two different things that you can see with checkpoint inhibitors with regards to your thyroid. You can see something called primary hyperthyroidism, which is primary means the problems in the thyroid gland, and it's hyperthyroidism, so it's making too much thyroid hormone, and then it's shutting down the TSH or telling the TSH, slow down. The other disease you can see is primary hypothyroidism. That means primary in the gland, hypo, low thyroidism, thyroid hormone. And what you see is low thyroid hormone with a high TSH because the pituitary gland is like, I'm going to send you more emails because you got to do more work here because you're not making enough. So these are the two flavors of thyroid diseases that you can see with checkpoint inhibitors. And when checkpoint inhibitors cause these kind of accidents, they are almost like a bazooka that goes and hits these very delicate hormone producing glands. So far, we talked about how it hits the pituitary gland, how it hits the adrenal gland. This time, we're going to talk about how it hits the thyroid gland. Now, when we talk about symptoms of how this occurs, now you can have hyperthyroidism, too much thyroid hormone, and hypothyroidism. And I want you to focus on that one word that says phase right next to hyperthyroidism. And there's a reason. I'm going to talk to you about this in the next slide, and it'll start making a lot more sense. So when I talk about patients, when patients come to me with hyperthyroidism, they appear like their body is running a marathon. They'll be sitting right in front of me, but the body on the inside is running a marathon. And how do you feel when your body is running a marathon? You feel hot, you feel sweaty, your heart rate's really high, you have tremors or shakes, you're losing weight because you're burning so many calories. You can sometimes feel anxious as well and very edgy, have difficulty falling asleep, feel like they're wired up a little bit. That's how patients describe how they feel during this hyperthyroid phase. So you're sitting down, but your body's running a marathon on the inside. I've had patients where I'm sitting and talking to them, and they're so anxious and they're feeling so wired on the inside that they don't even sit down on the seat. They're pacing the room and talking to me. And I know when I walk in the room that this is something to do with their symptoms and their labs that are telling me that this is a hyperthyroid case. And that's how restless they feel. Now, when we talk about hypothyroidism, think of a slug. That's exactly how, or a sloth, that's exactly how patients feel. They feel like they're not eating, they're gaining weight, their metabolism is really slow, they feel cold because they're not metabolizing that fast, so they're not generating that heat, they feel tired, depressed, very flat affect, very apathetic towards their families. They have a change in mood. They're tearful. They feel swollen, especially their legs. They have all of these changes that occur very abruptly. And these are the kind of symptoms or the flip of the symptoms, marathon versus sloth. Those are the two kind of dichotomies that you see with hyper and hypothyroidism. And when I said we're going to talk a little bit about the phase, let's talk a little bit about that now. When you have traditional thyroiditis, which a lot of patients, it's the most common autoimmune condition, a lot of patients have this, where you have inflammation or irritation of the thyroid gland. So think of the thyroid gland as a water balloon, and you poke a needle in the water balloon. What happens is you slowly have the thyroid hormone kind of coming out. You have high thyroid hormones because you're seeping out that thyroid hormone. So you have a clinical picture and a biochemical lab picture that you have an overactive thyroid. And then slowly the water balloon compresses and you have released all your thyroid hormone. And because the balloon is broken now, you can't inflame it anymore, or you can't blow it up anymore. So your thyroid gland moves from having too much thyroid hormone or throwing out too much thyroid hormone to not being able to make any. Now, in irregular thyroiditis or regular cases of autoimmune thyroid disease, this kind of plays out over weeks to months. In checkpoint inhibitor treated patients, it is not a needle that pokes that water balloon. It's a bazooka that blows up that thyroid balloon. So what happens is you have a rapid release of a large amount of water or thyroid hormone that is stored inside the thyroid hormone. And very fast, you move from having too much to nothing because your thyroid hormone, remember, you've just blown up your thyroid hormone, but the bazooka, nothing exists. So you move very fast over the course of weeks from having too much thyroid hormone to too little thyroid hormone. That's why I said hyperthyroidism is more of a phase than a state when you're treating patients with checkpoint inhibitors. Now, the treatment really depends on where you are and where you're found by your oncologist or by your endocrinologist. If you're caught in that hyperthyroid phase, again, it moves very quickly. Sometimes you see the doctor in 3 weeks and you've already crossed that hyperthyroid phase and no one got labs, so they don't really know that you had it. So it moves very quick and you may just come in with the hypothyroid state. So if someone catches you in their hyperthyroid state, the treatment is do nothing and just treat symptoms. It's a very hard thing to do. It's very complicated because you cannot watch a patient just sitting there with a heart rate of 120 and say, I'm not going to treat the disease. I'm actually going to treat just your symptoms. But that is the right answer. You would be treated with drugs that reduce your heart rate, slow it down a little bit. Those are called beta blockers. If you have a inflamed or irritated and large swollen thyroid gland, we give you fire extinguisher treatment, which is NSAIDs, ibuprofens. We give you steroids to slow down the thyroid gland. Steroids, not my preferred agent in this situation because it really worsens the symptoms of anxiety, lack of sleep, increased heart rate. It doesn't help with those symptoms. I prefer to keep that in the back burner. If all fails, then I'd pull that out. And if and when they move into the hypothyroid phase where they're unable to make thyroid hormone, they should be replaced with what your body can't make. Remember the same principle. Your body can't make cortisol, we give you cortisol. Your body can't make thyroid hormone, we give you thyroid hormone in the form of levothyroxine or synthetic thyroid hormone. Now, what happens once you get diagnosed, right? So hyperthyroid, as I mentioned, treatment is symptomatic. You wait and watch. Most oftentimes converts to hypothyroid. When you get into the hypothyroid phase, most often permanent. Folks that get into the hypothyroid phase rarely get off. Yes, there are some patients who can get off, but that is a smaller percentage of patients. And it requires close monitoring of your lab so that your oncologist and your endocrinologist can dial back your medications if your thyroid is responding, or if it is improving, or if it is getting healthier to start making more thyroid hormone. Now, in conclusion for this case, the patient continues on levothyroxine, no longer in checkpoint inhibitors. So patient is in remission right now. So another great story. Went through a lot initially, got treated, doing really well. So let's move on to our last case today, a case of immune-mediated type 1 diabetes. So this is a 54-year-old gentleman, regionally advanced melanoma, who presented to the oncology clinic for his third immunotherapy infusion and noted to have nausea, fatigue, polyuria, and increased thirst. His son has a history of type 1 diabetes, and the blood sugar at the visit to the oncologist was 424. To put things in context, a normal blood sugar is somewhere underneath 180, so this is really out there. And patient had no known history of diabetes prior to this. June 2019 has a new diagnosis. July 15 gets started on monotherapy with nivolumab. And then about a month later, before cycle 3, presents with hyperglycemia or high blood sugars. So following the same format, we're going to go through how common this is, what are the symptoms, how it's diagnosed, treated, what it means in the long term to be diagnosed with type 1 diabetes. Now, type 1 diabetes from checkpoint inhibitors is different. Now, if you have friends, family, coworkers that tell you, oh, I have type 2 diabetes, I'm taking pills and doing really well, I barely check my blood sugars, they're talking about another breed of diabetes. There are different types, many different types of diabetes, and there's type 1, type 2. Type 1 is insulin resistance. You have too much insulin, it doesn't work as well. Whereas type 1 is that you took that same bazooka where you hit the pituitary, you hit the thyroid gland, this time you're hitting the pancreas, and you kill those cells that make insulin and cause insulin deficiency. Now, what insulin does is when we eat food, whether it's carbs, protein, or fat, they get converted in some form into glucose because that's the fuel that the brain understands, the body understands. And when it gets converted to that, it flows in the blood. And what insulin does, it grabs that and pushes it under the rug in the form of protein, storage forms, and other things, and fat, where the glucose is taken and pushed into storage. And the absence of insulin, the glucose just sits around, keeps circulating because there's nothing that takes it and pushes it under the rug. And that's why patients present with this really high blood sugars, because they have absolutely no insulin or very low levels of insulin to tackle that blood sugar. And the way folks present is that they feel very tired because they're losing calories. They have all the sugar, but nothing is going into the cells to be used up by them. It's just circulating. So they feel very tired. They're urinating all the time because the sugar has to go somewhere. So the body says, okay, let's dump it out of the urine. So they go to the bathroom multiple times. They're waking up several times at night. They have restless sleep. They are tired because of the lack of sleep. They're eating a lot, they're drinking a lot, but they still continue to feel very dehydrated. They can present with yeast infections as well. And this happens very quickly. They'll have normal labs 1 week, very high blood sugars the next week. So it can happen very quickly, very fast. And this is very common to see as far as presentation when patients come in with their initial diagnosis. Now, how is this diagnosed? Now, you can be diagnosed in a diabetic emergency, which is diabetic ketoacidosis, and think of it as a terrible stomach bug where you feel dehydrated, nauseous, abdominal pain, maybe even having diarrhea, abdominal cramps. And your sugars are very high at this time. And these symptoms occur because of high blood sugars and high acid in your blood that drives some of these symptoms. And this is a medical emergency that you need to be seen in the hospital. You need to be kept in the hospital for a few days, and 1, to treat you, and 2, to help you leave the hospital with a safe regimen of insulin. The other ways we test you is we look for high blood sugars with low insulin and low packaging around the insulin, which is C-peptide. So insulin comes in a nice little Amazon box, and that Amazon box is your C-peptide. So we can count the C-peptide to see how much insulin you have. So you count the packages and the boxes to see how many orders you've delivered. So that's how we check for type 1 diabetes. There's another test, which is again a blood test. We love to take blood from patients. We don't do a lot of invasive stuff in endocrine, which is nice. But we are vampires. We like a lot of blood. So we do a lot of blood tests. So we do blood tests where we test for antibodies in your blood to look for markers that tell us whether you have type 1 diabetes or not. Again, these markers are not always positive. If it's positive, it helps us confirm our diagnosis and say, yeah, we were right, and this confirms it. If it is negative, it still doesn't tell us we were wrong in treating you or diagnosing you type 1 diabetes because you are unable to make insulin, and we've already tested you for that. So now that we have a kind of a picture about how it's diagnosed, and what kind of symptoms you can get with type 1 diabetes, let's spend some time talking about how it's treated. Now, this is one of those diagnoses that when I tell folks that, hey, I think you got type 1 diabetes, I want to give them a hug. I want to hold their hand and tell them it's going to be okay, because this is a tough diagnosis to deal with and a tough diagnosis to live with, because these things don't go away. And it is a huge lifestyle compromise, because you have to really watch this throughout your day, throughout your night. There's no holiday from type 1 diabetes, unfortunately. So that's the way this disease is, and that's the nature of the disease. So I have about 24 patients in the last 8 years that have taken care of with type 1 diabetes, and they are my most special patients. And we hold our hand each time we meet, and we talk about the stress that they go through with managing this. The stress is real, but it gets better. It gets better with the right knowledge, with the right kind of adaptation, and the right technical support that you can get to manage this. And the reason I say this is because it's not a pill that you take once or twice a day and forget about it for the rest of the day. When you eat, when you're stressed out, when you get steroids, when you get immunotherapy, when you get chemotherapy, your body is physically, emotionally going through stress, or you're eating or drinking something, your sugars will respond to it, and they go up and down. And that is the nature of a person who's alive. If your sugars are fluctuating, that is normal. And if they're not fluctuating, that is not normal. The sugars respond appropriately to what's happening in your body. When you lack insulin, those responses are huge. When you eat, your sugar is going to go up. So you're going to require to take insulin the same way that your body naturally makes. Remember how we treated adrenal insufficiency? We like to simulate what the body naturally does. So the body naturally makes a small amount of insulin all through the day and then gives a big jump of insulin every time you eat. So that's how we treat type 1 diabetes. We give you two different types of insulin. We give you one that is short acting. I call it the C food insulin. So you see your food and you take your shot. And when you have the food in front of you, you give the short acting insulin. And depending on how many times you eat, that could be 3 to 5 times a day. And then you take a basal insulin, which is, remember, the small micro amounts that your body releases all the time. That is the medication that you take, which is the longer acting insulin that you take once a day, almost about the same time every day. That is how we typically start you on. And then eventually, depending on how well you want to adapt to the technology, all the resources that we have around type 1 diabetes, as bad as it sounds, it is a much better time in history to have type 1 diabetes than it was even 5 or 10 years ago, because diabetes technology is advancing so fast. You have pumps, you have continuous glucose monitors that deliver you insulin and have algorithms that calculate how much insulin you should be getting. It is getting very sophisticated and more, I would say, less intense on patient decision making. So your endocrinologist might first start you on 4 or 5 shots a day and then switch you over to something called an insulin pump. That doesn't require you to give more than 1 shot every 3 days. That is when you insert the pump or you insert the pump side, that's 1 every 3 days. So it gets better, but it's definitely going to be different than where you started off. So the $1 million question I get asked every single time when patients come in, is this reversible? The answer is no. I've never seen a single patient. Whatever we know from the data is that once it sets in, the bazooka has hit the pancreas. Endocrine glands are very delicate. You damage it, the damage is almost permanent. And do you need to stop immunotherapy? The answer is no. You continue. It doesn't change anything. You already have type 1 diabetes. That is not going to change. Does life get better? Get back to before your diagnosis? Not really. It starts looking different. And stress management is key. These are folks I send to psychologists who deal with cancer and who know chronic disease management and diabetes. So I have a group of folks that do this for a living, and I send my patients to them because it adds a layer of stress to everything else that they're dealing with right now. So having said that, let's wrap up this case as well. Patient received cycle 3 infusion in their oncologist's office and then was seen in endocrine clinic shortly after, received IV fluids, insulin. It helped that the patient's son had type 1 diabetes. The patient knew everything and what they needed to do with type 1 diabetes. And then the patient developed thyroiditis, the same way the bazooka hitting the thyroid, hyperthyroidism, hypothyroidism, then requiring thyroid replacement. Now, that concludes all 3 cases. But what about patients who have pre-existing conditions, right? Now, if you have pre-existing adrenal insufficiency, you're going to get immunotherapy. If you get new onset, say, adrenal insufficiency, very hard to diagnose because remember, you're taking the pills, the blood tests, the ACTH, cortisol, all of this is going to be influenced by the pills that you're on. So it's not easy to diagnose you with new onset adrenal insufficiency while you're on steroids. Does it require you to change some doses? Probably. But the diagnosis, if you already have AI, this is probably not going to change anything for you. Now, coming to thyroid disease, very common in the general population. So if you get hit with, so you have thyroid disease, you're on some thyroid replacement, let's say you're on 100 micrograms of levothyroxine, and now you get immune checkpoint inhibitors, and now you have thyroiditis from it. What can end up happening is that when you go through the hyperthyroid phase, your dose may require to be reduced, like we may drop your dose down from 100 to 25 or even 0 for a short period of time until the hypothyroid state sets in, where your dose may be either 100 or even higher than where you started off. Because remember, that was a pin that hit your thyroid. Now you're hitting your thyroid with a bazooka. So things are a little different. So it may require dose changes. If you have diabetes, if you have type 2 diabetes, can you get type 1 diabetes? Absolutely. Does it change it? Does it make you a higher risk for having type 1 diabetes? Absolutely not. We don't have any data to support that. But yes, if you have type 1, it doesn't stop you from type 2. It doesn't stop you from having type 1. If you're getting steroids, it's going to impact your blood sugar. So and remember to have a conversation with your oncologist or your endocrinologist if you're planning, or if there's a plan to add like dexamethasone with your chemotherapy or with your immunotherapy. And if you have pre-existing type 1 diabetes, nothing changes. Maybe the dose needs adjustment, but nothing really changes with the overall plan of care. Now, in conclusion, endocrine toxicities are quite common. The course of disease, chance of recovery is very different and really depends on the side effect. And timely diagnosis is life-saving. And as you see over here, the purple ones are the ones that are chronic, don't go away. And all of the endocrine diagnoses that I just talked about are all in this slide right here to say that once these set in, they're probably here for life. Now with that, I'm going to close up on the clinical cases and what this means as far as long-term management and move on to clinical practice innovation and what we can learn from each other. And this is where I get really excited about doing what I do every day and getting excited about going to clinic every day and going to work every day is the difference that we can make from learning from each other. So we have something called an electronic consultative service at Duke, where we are able to provide expert recommendations within 1 to 2 days for patients who need that kind of expertise. So for example, if an oncologist believes that their patient or thinks that their patient has an endocrine side effect, they put an order with the electronic health record that comes to my in-basket. I review the case and I put in recommendations that go in within 1 to 2 days about maybe which medication to put the patient on, how to get started on the XYZ, and have them come into my clinic depending on how sick they are. If I need to see someone tomorrow, we put them in tomorrow in my clinic. If someone can be started on a medication and I can see them 5 weeks later, they're put in my clinic 5 weeks later. So it's a very acuity-based kind of triage system that has really been very successful. We've done over 300 consults in the last 2.5 years. And we've been able to drop the recommendation time from 87 days down to 1 to 2 days. And that makes a huge difference in who gets into the hospital and how we can prevent that, because we were able to drop the hospitalization rate for all these toxicities, the endocrine toxicities I talked about, from 11% down to 2%. So that's a huge drop, about a 70 to 80% drop in the admission rate. And we've expanded this to dermatology, to rheumatology, so that we can get the right patient in at the right time, at the right place to see the right expert who understands cancer, who understands the patients, who understands side effects. So that is very, very important. Now, the other thing I'm going to talk about as far as another project that I'm working on is a machine learning model that can predict hospitalizations from these agents. We see that a lot of patients at Duke, we see about 34% patients get admitted in the first 6 months after they get initiated on immune checkpoint inhibitors for any reason, whether it's toxicity, whether it's another side effect, for some or the other reason, 1/3 patients get admitted. How can we predict this and how can we be more proactive with this approach than reactive? So that's the project that we're working on. We have a machine learning model that basically uses old data, uses that data, learn about patients, and then apply that to prospective patients who are now going to get immunotherapy and tell us, okay, this patient in the next 2 weeks has this risk of going into the hospital. Do you want to do something different? Do you want to call up the patient and talk to them if they are feeling differently so that you can prevent the hospital admission or prevent something from getting worse before it gets to that point? So that's the model we're working on, and we're going to launch this in a couple months at Duke. So hopefully, fingers crossed, we have some good results that we can apply to other universities and other programs as well. The last thing I'm going to talk about is Checkpoint Now, that Dr. Hall kind of alluded towards. So Checkpoint Now is a podcast. It's a labor of love, a passion project, I would say, that started in the heat of COVID when I was finding it repetitive to talk to folks and tell them the same things. And I just said, you know what? I don't want this information to just stay in the ivory towers of medicine, in the Johns Hopkins, in the Dukes, in the UWashes, and stay in those ivory towers of information and expertise. We need to disseminate this information across the world, where folks have access, free access on their phones when they're driving to this valuable information that can help patients. So we started this in 2020 November. We have 2 seasons now. We have 5,000 plus praise, 51 countries that tune in to listen to this podcast. We have 2 seasons, as I mentioned. Season 1 is a dialogue between me, my co-host, who's an oncologist, and other specialty experts from around the country. And we talk about care coordination, diagnosis of these side effects, and how we can do better in managing them. And season 2 is directed towards patients. It's simple language. We talk about what these toxicities mean to you, what are the questions you should be asking, what should you expect, kind of similar flavor to what I just talked about, breaking it down into simple language so it's easy for everyone to have the right information, and information is power. And that's what I want patients in the world to have, is that they have this information and they go armed with the right questions to the doctor, feeling more reassured that what's happening is happening in the right direction. The way you can find these podcasts is you can go on Apple Podcasts, you can go on Spotify, you can go on Google Podcasts, you type Checkpoint Now, you should see my name underneath. That's how you find our podcast. And with that, I'd like to end and thank you all for the invitation. And I call myself a lifelong learner. I learn a lot from my patients, and it is a very rewarding thing to take care of, patients with cancer. They teach you a lot, not about life and about work, about everything in general. So thank you all for inviting me today. So I'll take some questions.
Wonderful talk. And I'll just point out, for those that are interested who have other side effects, Checkpoint Now doesn't just talk about the endocrine side effects. There are things on liver side effects, heart side effects. It's comprehensive. So if maybe you're someone who's had a different side effect or interested in learning more, there's probably an episode on it at this point. We have some questions. Dr. Bird.
Looking in the chat here, I hope the people online can hear this, and Dr. Sharif, you can hear this microphone. This comes from Linda Hart. Dr. Sharif, could you please comment on the relationship between the hypothalamus and the pituitary gland? Let me advance this, sorry.
Is there a test to determine if the hypothalamus is actually part of the problem? There you go.
Right. This is a pretty sophisticated question because you didn't touch on the hypothalamus at all.
Yeah, and this is exactly the reason why, because we don't have great tests to determine that. There's something called CRH, which is corticotrophin releasing hormone, that goes and sends an email to the pituitary gland to tell it to make ACTH that goes to the adrenal glands to make cortisol, but there's no great test to test for that. And oftentimes the tests, number one, are not great. They're expensive, they're not reliable, so we don't go that route. And either ways, the treatment really remains the same, whether the defect is in the hypothalamus or whether it's in the pituitary gland. The treatment ultimately comes down to the TSH deficiency, the ACTH deficiency, FSH and LH deficiency that kind of drives the type of hormone you're going to be replacing the patient, whether it's going to be cortisol, thyroid hormone, testosterone, or estradiol. Thank you for that question. That is, I'm guessing someone has a little bit of medical background behind this.
Questions from our in-person attendees. We have microphones that can circulate.
Yes, I had a question about artificial intelligence. Do you see that this might help or hinder as far as diagnosis and the patient living out the diagnosis, good or bad?
So it really depends on what you're feeding that artificial intelligence machine and how it learns and what data it learns on. So there's so much information right now and so much activity happening around ChatGPT, OpenAI, the interaction, what that's going to entail as far as what we do clinically and in healthcare. And really it depends on what you put in. You put garbage in, you get a garbage answer out, because that's what the model is using to learn, right? You put the information from experts in, you put the right guidelines in, you put the right information in, and you can get a really good answer out of them. So it really depends on what you're feeding the model, what you're feeding that artificial intelligence machine, and what you're trying to answer out of it. So that is where I think clarity is needed and regulation is needed as to what information we're using to train these kind of models. And unfortunately, the way we have it in medicine right now, the data, especially around immune checkpoint inhibitor associated toxicities or any of the newer therapies, whether it's CAR T-cell therapy or whether it's LAG therapies, we don't have ICD codes that are specific to toxicities. If I just had to click thyroiditis, I would get at least 75 different diagnoses that I have to look over. I don't have anything that says immune-mediated thyroiditis. So when Epic or OpenAI wants to work with Epic to create an AI model to say answer a question about drug-mediated or immune-mediated thyroiditis, it will not be able to tag the right cases because it doesn't have an ICD code. So I think what happens, and we're working on a project right now with Project DataSphere, that is working on developing disease definitions and consensus from expert endocrinologists around the world, where we are able to come back with the consensus and say, we think this is how thyroid disease needs to be defined. We take that to ICD, and ICD implements that in EHR. But that process took a couple of years. So whatever model, whatever data exists now in EPIC is very unclean data. So yes, with a grain of salt, I think it can do a good job, but we need to realize where the nuances are in what data we're feeding those kind of models. You don't feed the right data, you're not going to get very clean answers.
Other questions? Well, while you're thinking of it, I have a question. So we routinely monitor for thyroid and adrenal function. And we do our own cocentropic stim tests. So I'm happy to report that. But we don't often check testosterone or other, sex hormones. And so you mentioned that that's something you often pursue if someone's having ongoing symptoms and you can't identify it. When do you often think about looking at those hormones, and what's been your experience in replacing them when they've been low, and how people feel?
Well, that's a great question, and it comes up quite often, especially more as an afterthought than as kind of the initial diagnosis. I'm very excited to hear that you do your own cocentropic test, which is fantastic. I think we should have you guys come over and teach our folks at Duke to do that. But going back to the question that you asked about when is our optimal time. So there's two ways in which I utilize checking FSH and LH and say estradiol and testosterone. If it is a female patient and I don't have a clear diagnosis of whether they have immune hypophysitis or not. For example, if someone comes in on steroids to me and now I have to tease it out whether they truly have adrenal insufficiency and which bucket to put them in, I will get, if it's a postmenopausal female, I will get an estradiol, an FSH, and LH, because what should happen in a postmenopausal female, and this is more technical maybe for the kind of providers in the audience, is that if you're in menopause, you have low estradiol and your FSH and LH should be high. Now, if you have immune hypophysitis on replacement steroids, right, it should not suppress your FSH and LH. So if you have true immune hypophysitis and you send the patient to an endocrinologist and they're not able to tell you, okay, this truly a diagnosis or not, FSH, LH, and estradiol will help, because in the absence of FSH and LH signal, you can confirm or put that as a supplemental evidence that yes, this patient had some sort of pituitary damage, and that's why the patient's on steroids. So it helps as an after fact. So one way to use that, it's not very helpful in men. So in postmenopausal females is something definitely I go to if I'm not clear on the diagnosis. Now, second thing, what would be the right time to diagnose them? We typically, when we're talking about patients coming in, say, with an adrenal crisis, we don't throw in an FSH and LH and testosterone at that time, because your HPG axis can be affected just by the severe sickness that the patient's going through. But when I have optimized the patient in the sense that the patient's on the right dose of cortisol, they're on the right dose of hydrocortisone, they're on like 30 milligrams of hydrocortisone. I've inched up their dose, had those conversations, thyroid levels are optimized or they're not abnormal. That's when I start saying that, okay, let's test your testosterone. Let's get an FSH and LH and a testosterone, especially it has to be done 8 a.m. in the morning, fasting, without any energy drinks, no caffeine. Those are the rules. You get that done 2 to 3 times, and then you get the best of 3. If that is low, FSH, LH low, testosterone low, those would be good candidates for testosterone replacement, and they feel magical. Of course, with prostate cancer patients, that is a different deal. You really need that blessing from their oncologist to make sure that it is safe for them to go on testosterone. And we try to do lower doses of testosterone on those folks to avoid them from having their prostate cancer from going back. So there are ways to do this, but depending on the other risks, CVA, stroke, heart disease, really, having those conversations between oncology, the patient, and us. And we typically end up doing a trial of testosterone to see, okay, are you going to respond? Is this helping you improve? I would hate going up on steroids or converting them to like 12 milligrams of prednisone without testing their testosterone. There's another reason for their fatigue. I'd rather treat that than go up on steroids.
Great information. I've learned a lot today. And then I think we have one more online question.
Yeah, one more question from our audience, from Diane. Dr. Sharif, you mentioned, quote, accidents happen and there are side effects of the cancer treatment. Are these accidents induced by the behavior of the patient, such as if the patient does not get enough rest, or the patient exposes themselves to too much heat or too much alcohol or whatever?
So not that we know of, right? These are accidents that are just, I would say, not even off-target effects. These are kind of on-target effects of these medications. Because remember, you're ramping up that immunity to right at 100 miles an hour. So if you do that, you're kind of reckless with immunity, and it causes all these little accidents. And endocrine glands are probably some of the most prone glands that go through autoimmune attack very easily. As I mentioned, they're very delicate glands, but there's nothing you are doing differently that is going to make this worse. Yes, family histories play a role in this, in the sense that if you have autoimmune diseases in your family, for example, I have rheumatoid arthritis in my family, I have type 1 diabetes in my family. So I would be, if I receive immunotherapy, I would be at a much higher risk of getting these side effects because I already have one hit out of the 2 hits that you need to get autoimmune disease. So that is one thing that you really can't control, because it's kind of like when you're born, you put your hand in that fishbowl, you pull out a slip, and that's kind of the autoimmune disease that you end up with if you have both those hits. So there's nothing that you could do differently that can protect you from these kind of side effects. They occur, and when they occur, you just need to go to the right person, get the right diagnosis done, and get on the right treatment.
Great. With that, I think we'll conclude that presentation. Thank you so much for joining us. And I don't know if pickleball has forever been spoiled for you, but pickleball was invented on Bainbridge Island, which is a short ferry ride from Seattle. So you have an open invitation to come to Seattle, and we can get you to the home of pickleball if you're interested.
Well, I'm not going to stop playing. It's just I'm probably going to be more careful, I guess, next time.
Sounds good. Thank you
But be
so
careful
much.
out there, everyone. And thanks so much for inviting me.
All right. So for our next presentation and last before the break, it's a privilege to introduce Dr. Amanda Phipps. Dr. Phipps is an associate professor in the Public Health Sciences Division at Fred Hutch and is a member of the epidemiology department. She's really interested in how lifestyle impacts immunotherapy response and toxicity, and with a particular interest in sleep. And so she's going to be speaking today, and her talk is titled Sleep Matters. Dr. Phipps, thanks for joining us.
Thank you. Good morning, everyone. And thank you to Dr. Hall and Dr. Bird for organizing this fabulous event. And thank you for the invitation to come talk about one of my very favorite things to talk about, which is sleep. So just to kind of get the temperature in the room here, let me ask you, show of hands, how many of you got less than 7 hours of sleep last night? Okay, you're in good company. Me too. The toddler was up extra early this morning. How many of you got more than 8 hours of sleep last night? Well, you're just showing off. So you all, I'm sure, can relate to how that impacts how you feel right now, right? Depending on how much or how little sleep you got, how sufficient, how restful your sleep was, it impacts how focused you feel right now, how much you might need an extra cup of coffee, how ready you are for a break, right? So we can all relate to this feeling that sleep is important. Certainly in the short term, the immediate effects are pretty visible to us, but there are also long-term implications of whether or not we're getting the sleep that our bodies need. So that's something that I'm going to talk about today. Full disclosure, I am not a sleep medicine physician. I am not an MD. I do not treat patients. I work with data. I'm an epidemiologist. So how many of you, again, show of hands, have heard of the science of epidemiology, or at least heard of the word? Wow. Okay. So if I was here 5 years ago, there would have been crickets there, I'm guessing. Most of you have probably, or maybe many of you probably heard about epidemiology by virtue of COVID and the role that epidemiology played in the public health response. Most epidemiologists, well, maybe not most, but a large contingent of us do not do work in the area of infectious diseases. More generally speaking, epidemiology is a search for patterns. So I look across the population and I use data across the population to help me figure out these patterns, things that distinguish different groups of people, groups that are defined on the basis of their experience with certain health conditions or health outcomes. So we ask questions like, well, what's different between people who develop a particular disease and those who don't? Or what's different between people who develop this specific type of this specific disease and those who develop a different type of that specific disease? What's different between people with a certain disease or health outcome who have a good prognosis from those with the same disease who have a poor prognosis? So we're looking for patterns. Now, if I were an infectious disease epidemiologist, that search for patterns might involve things like trying to find the food source at a company picnic that led to an outbreak of E. coli. As a cancer epidemiologist, I get to look across a whole wide range of potential exposures, things that might be connected to a person's risk of developing cancer and their experience after a cancer diagnosis. So I look at things like inherited genetics, aspects of lifestyle, diet. We can also look at environmental exposures, workplace exposures, aspects of medical history, all of these things that can impact a person's risk of cancer and their prognosis after a cancer diagnosis. As I mentioned, one thing that I'm especially interested in is sleep. And sleep is also important to cancer. So one of the reasons I'm so passionate and interested in studying sleep is because, again, we can all relate to those short-term implications of not getting the sleep that our bodies need. When on a day after you don't get enough sleep, you feel it, right? You feel a little bit less focused, maybe you're a little more grumpy, you're probably less likely to stick to your healthy eating habits, you're more likely to get a cold, you don't feel like yourself. And those effects compound day after day when you are chronically not getting enough sleep. So when we look at folks who have chronic sleep insufficiency, chronic sleep disruptions, we start to see an increased risk of heart disease, an increased risk of stroke, of diabetes. We start to see sperm counts decrease. We also see an increased risk for several forms of cancer. So the earliest evidence for the link between sleep and cancer came from studies that looked at night shift workers. So think about folks who are airline pilots or flight attendants working those transatlantic or trans-Pacific overnight flights. Think about nurses working overnight, doctors working overnight. Think about factory workers working night shifts, the graveyard shift. Earlier studies have documented that folks who work these kinds of night shifts so that they are exposed to artificial light at night and are sleeping during the natural light of day experience a greater risk for certain forms of cancer, especially breast and prostate cancers. And studies looking at the effects of night shift work are consistent enough now that the World Health Organization actually classifies night shift work as a carcinogen. So it's a known cause of cancer. Now, this is not true for all forms of cancer, but as I said, especially for breast and prostate cancer, we see these elevated risks. Now, most of us do not work a night shift, but other studies have branched out to look at other aspects or dimensions of sleep. And those studies have focused primarily on sleep duration. And what they see is that for folks who consistently have a very short sleep duration, so 5 hours or fewer per night, or consistently actually a very long sleep duration, 10 hours or more, you see an increased risk for certain forms of cancer. I'd say the most consistent evidence there is with respect to lung cancer, but there's variability across different cancer types as well. One other dimension or aspect of sleep that I've been particularly interested in relation to cancer is obstructive sleep apnea. And I have selfish reasons for this because my bedside partner is somebody who also suffers from obstructive sleep apnea. Obstructive sleep apnea is this sleep breathing disorder where a person periodically stops breathing throughout the night due to an airway blockage. So if you live in the same household as someone with sleep apnea, you hear them snore loudly throughout the night and then they periodically stop and then gasp and keep going again. That's due to an oxygen deprivation. And their bodies arouse every time there's that blockage. They may not realize it. And in fact, a lot of people don't even know that they have obstructive sleep apnea. But what we've seen in our studies and in others is that folks who suffer from obstructive sleep apnea have an increased risk for certain forms of cancer. And in particular, most consistently, we see this increased risk with respect to melanoma and renal cell carcinoma. Now, why those two forms of cancer? I wish I knew. I wish I knew. I don't. But we see it, and several other studies have also documented it specifically for those two forms of cancer. So there are a few possible reasons for this. One is that with those periodic cessations of breathing, that oxygen deprivation, we call it hypoxia, intermittent hypoxia. With this intermittent hypoxia, when you're depriving your body of oxygen throughout the night, it results in this increased risk of DNA mutations. And it results in this increased risk of inflammation. And those are two key drivers of cancer pathways. It may also be that just there's this sleep fragmentation that goes along with obstructive sleep apnea. Again, people may not realize that they are waking up repeatedly, sometimes dozens, even hundreds of times a night. They may not realize that they're doing it, but it fragments their sleep. It makes it less likely that they're going to be able to get into that deep, restful phase of sleep every night. They're going to wake up less rested, and that can have downstream implications. Those kinds of implications from the sleep fragmentation and how it impacts on cancer, very similar to the pathways that have been suggested for the night shift work and for short and long sleep, that there's a contribution to these pathways of inflammation and DNA damage. And in particular, when folks are getting insufficient or disrupted sleep throughout the night, keep in mind that that time when you're sleeping during the night is the time when your body is repairing itself. It's trying to fix that DNA damage that you've accumulated throughout the day just by function of existing in the world, right? So when you reduce the amount of time that you have for that, when it's disrupted, when you're not getting into that restful phase of sleep, you're impairing your body's ability to do the work that it needs to do. This insufficient and disrupted sleep can also result in a weakened immune system. It reduces your body's ability to mount a strong immune response to things like a cold, things like COVID, but also to things like cancer. Your body produces an immune response to cancer. It's part of the reason why we can use things like immune checkpoint inhibitors. Also keep in mind that it is all connected. Sleep is connected to so many things. A few minutes ago, you heard Dr. Sharif talking about these cortisol peaks throughout the day. How your body knows when to peak the cortisol around 8 a.m. and around 1 p.m. or noon, she said, is because you have in your brain something that's called the suprachiasmatic nucleus. It is your master timekeeper. So many of your different bodily systems are on a clock. They are all on this circadian rhythm, so many of them. Your cardiovascular system, your gastrointestinal tract, your immune system, your hormones, they follow these cycles. And you want to try to keep them all aligned. That's the job of the suprachiasmatic nucleus in your brain. It is the master clock keeper. It's sending signals to all these different body systems, telling them when to peak and when to fall throughout the day. That suprachiasmatic nucleus in your brain, the master clock keeper, it is trained by your exposure to natural light. But you can also train it based on when you're sleeping and when you're eating. So right after you sleep, or right after you eat rather, your body isn't going to be like, oh, now's a perfect time for me to go to bed, right? It's got some work to do. So based on the consistency and the patterns of your sleep and your eating, that impacts the alignment of your suprachiasmatic nucleus and its ability to send these good signals out to different body systems. So up until now, I've been talking about cancer risk, but really important thing to keep in mind here is that these pathways that go from sleep to cancer, they don't stop being relevant on the day of a cancer diagnosis. They continue to have an impact because these pathways are often set in motion. So what impacts cancer risk and the development of a cancer can also impact upon cancer progression and therefore cancer survival. So when we look at studies that are focused on cancer patient populations and cancer survivor populations, what we see there too is that sleep matters. Patients with really short sleep have been found to have poor survival for breast and liver and pancreatic cancer. Poor sleep efficiency, which is, for the amount of time that you're spending in bed, how much of that is actually sleep time. If you have poor sleep efficiency, it means that you're not actually sleeping for most of the time that you're in bed. That poor sleep efficiency has been associated with poor survival for patients with breast cancer. Poor sleep quality, lack of restful sleep is associated with poor outcomes, particularly for patients with lung and colorectal cancers. And that should say obstructive sleep apnea, not just obstructive. But patients who have obstructive sleep apnea, not only is that associated with a greater risk of melanoma and renal cell carcinoma, but we also see that it's associated with poor survival, particularly when patients aren't getting the treatment that they need for obstructive sleep apnea. And a large proportion of patients with obstructive sleep apnea are not treated, or they're not even diagnosed. Or maybe they have a CPAP, but it just sits collecting dust on the side of their bed. So this relationship of sleep with cancer, it doesn't stop at the time of diagnosis. Also important though, is that the relationship of sleep with cancer, it's bidirectional. It's a chicken and the egg kind of thing, right? So yes, your sleep patterns can impact upon the development and progression of a cancer. But once a person has cancer, that cancer itself is impacting your sleep. Very much so. And I'm sure you all can probably relate to this much better than I can, but the effects can be acute. If you think about a patient during a hospital stay, your exposure to light, disruptions throughout the night, that impacts your ability to get a good restful night's sleep. But beyond that, the pain, treatment side effects, including some that Dr. Sharif talked about, not to mention the stress and anxiety that go along with a cancer diagnosis, all of that impacts on your ability to sleep. And we see this really consistently. So we've collaborated with the Fred Hutch Cancer Survivorship Clinic, which is a clinic that sees patients when they're at least 12 months out from completion of treatment. We've worked also in Dr. Hall's clinic, as well as with a study of colorectal cancer survivors. And what we see so consistently is that patients and survivors are reporting that they are less likely to get the recommended 7 to 8 hours of sleep per night. At least 50% are reporting that they are getting less than that amount. And that's in comparison to 30% of the general US population. So they're not getting enough sleep. They're also having more trouble falling asleep, which is perhaps not surprising. 15 to 20% of patients in these cohorts report it taking at least 30 minutes for them to fall asleep. And that's in comparison to about 10% of the US population. And here too, and this really hits me, more than 75% report that sleep difficulties have affected other important areas of their lives, their social life, work, and other. And this one doesn't need a comparison to the general US population, right? This number is impactful regardless. If your sleep is impacting your life, that's significant. And perhaps not surprisingly, about 30% reporting that pain is impacting their sleep. This is something that we shouldn't be ignoring. Because again, it's not just in the short term. It's not just how you feel today. How you feel today is important. It is 100% important, but it compounds over time. And so when we see patients, we see survivors, we see caregivers as well who aren't getting the sleep that they need, that is something that's worth talking about. So with all that, how many of you have I stressed out right now? Yes, okay, yeah. So keep in mind, stress is not something that's going to help you to sleep, right? So I'm saying all of this not to stress you out, but because I think it's really important to have the conversation. It's really important to have the conversation about how we prioritize sleep. It's really important to have the conversation also with your physicians. Sleep is something that we should all be talking about. It's not a luxury, it's a necessity. So with that, I'm going to leave you with some bullet points here, some suggestions, some tips. And I'd love to hear your thoughts and have a conversation about this as well. My number one tip though here, and this is really a plea, is for you to think of sleep as time well spent. We have for so much of history in this country, deprioritized sleep. We have this culture of, the hardworking person who stays up later, stays at work later. The best student is the one who stays up all night studying. Baloney. Call baloney on that, right? It's time for us to think instead about that time sleeping as time well spent. It is critical to keeping a body healthy. So aim for 7 to 8 hours of sleep each night, if you can. If you can. And the if you can comes with my next suggestion, which is to keep it consistent. And this is true with any kind of lifestyle modification you're going to make. If getting 8 hours of sleep per night or 7 hours of sleep per night is an unsustainable goal for you, then don't set out with that goal. It's like telling yourself, I'm going to run 10 miles every day and I'm going to have, 18 servings of fruits and vegetables every day. Maybe you could keep that up for one day, maybe 2, right? But if that's not something that you can keep in your life sustainably, then it's probably not a change worth making to start with. What is also really, really important about sleep is consistency. Again, think back to that suprachiasmatic nucleus. It's the timekeeper. It's using your sleep to keep your daily cycles, to keep the clock and all your different body systems. So when you have this really inconsistent sleep schedule from day to day to day, it's hard to keep that suprachiasmatic nucleus aligned and consistent. So perhaps just as importantly, or maybe even more important, try to be consistent. Try to keep a consistent bedtime and a consistent wake time 7 days a week. Now, I know that it's really nice to sleep in on the weekends, but you don't get to catch up is the thing. When you have a sleep deficit, getting an extra hour or two of sleep on the weekend, it feels good, but it doesn't undo the damage. So think about what you can do sustainably. Think about how to keep your sleep consistent, because that keeps your body on this regular circadian rhythm that allows it to optimize or to work at its best. Then also think about practicing good sleep hygiene, by which I mean set yourself up for success, right? If you're going to bed in a room where the neighbor's porch light pours directly onto your pillow, it's going to be really hard to fall asleep. If you are drinking a cup of coffee right before you get into bed, you are not setting yourself up for success, right? So think about how you put yourself in that space to get the best sleep that you can. Limit your caffeine intake, especially later in the day. If it's really bright in your room, think about maybe getting an eye mask or blackout blinds, because the dark is really important. Remember that suprachiasmatic nucleus, it is trained by your exposure to light. So if you're in a really light room and trying to sleep, you're not getting your best sleep. And I know you've probably heard this one a bunch in recent years, but no screen time for 30 minutes before going to bed. That's a tough one. I know so many of us like to scroll right before we go to sleep, or maybe wind down in front of a show. And that's good, because it's good to be relaxed. But that blue light from the screen can really impact your ability to fall asleep. So try to keep the phone out of the room if you can, or try to give yourself a little buffer between when you turn off the screen and when you go to bed. And also don't eat right before you go to bed, because again, that's sending a signal to your body of, oh, I need to process this right now. It's setting off some hormones that you don't want to be triggered right before you're trying to fall asleep. And lastly, talk about it. As I said before, we don't talk about sleep enough, but it's important. It's impactful. It's impactful to your health. It's impactful to your quality of life. And that's not nothing. Also, if you suspect that you might be experiencing a sleep disorder, insomnia, sleep apnea, that's really important to get treated. So again, have the conversation. And if you are a caregiver or a partner who is seeing that your partner is experiencing sleep apnea or a sleep disorder, encourage them to talk about it. Encourage them to seek treatment for it, because that can have a big impact as well. All right. I hope I haven't frightened you too much. I'm happy to take questions or comments.
Can I talk with you?
Sure. And if you could
I'll
repeat,
repeat.
absolutely, I can repeat the question.
This doesn't have to do specifically with melanoma, but you were talking about the circadian clock.
Mhm.
Is there a higher incidence for blind people?
That's really interesting. So the question was, is there a higher incidence of cancer for blind people who don't have natural light to entrain their suprachiasmatic nucleus? There have been studies, and they are limited, as you might expect, because there are, with cancer, one of the things that I find really fascinating about studying cancer is that a cancer we see today didn't start yesterday, right? So, and that's different from like COVID or E. coli. We can trace back like a week ago and say, what did you eat? Where did you go? But with cancer, if a person is blind today, it could be that their cancer had started before they became blind, right? So there we have to look at cohorts in particular of folks who grew up without vision. And then there's also the distinction between people who are blind, but maybe still see light, right? And so it's a really niche population to find those folks who have lacked exposure to light at all. And so it's been hard to get like consistent studies out of it, but it's a really interesting question. Yeah.
Related question, how about people who live in the northern climes?
Yeah, so people who live in northern climates where we have very short days during the summer as opposed to, and then very long days during the winter. I'm sorry, very long days during the summer, very short days during the winter. Yeah, so that's a really great question. The truth is, and again, hear this, like, this is why I love epidemiology. It's so hard to isolate the one thing that's different, because along with that northern climate, you have differences in daylight. You also have differences in diet. So if you think about, for example, Alaska Native patients, people who are Alaska Native, they experience very high rates of colorectal cancer, the highest in the world. Now, part of that may be due to light exposure or lack of light exposure. Part of that may also be due to aspects of diet, because it's harder to grow certain or access healthy fruits and vegetables, fresh fruits and vegetables, right? So there's a lot of things that go along with northern latitude, but there are certain forms of cancer that do follow sort of an increase as you go further north, and other conditions as well. For example, MS, very much associated with latitude. So there may be something with light exposure there as well.
Huh, thank you. Can you comment about jet lag and how best to manage it?
I wish I could. Yes, so certainly for folks experiencing jet lag, and again, I'm not a sleep medicine doctor, so I'm not going to tell you to take melatonin, although that's probably what you would see if you went online. But certainly giving yourself an opportunity to slowly acclimate as opposed to just expecting that you're going to switch automatically. Is one way to kind of slowly train your body. But then that kind of depends. Are you going to, if you're going to go somewhere for 3 days, or if you're going to go somewhere for a month, how much your body really has time to acclimate to it.
We have two online here, and then we'll get back to, and I'll just go two together.
Perfect.
One is, can the 7 or 8 hours recommended be accomplished with 6 hours of sleep and an hour and a half nap during the day? That's one. The second is, what about the weight? You mentioned falling asleep. What about waking up at 3 to 4 a.m. is often accompanying depression or others? And what do you do if you wake up at 3 or 4 and can't go back to sleep?
Yeah. So a couple of things there. I would say the general recommendation is that if you're going to nap, keep it to 30 minutes or less. And also longer naps than that do not compensate for shorter nap or shorter sleep time overnight. So again, consistency is good. Consistency, if you're every day taking that nap, maybe your body is kind of becoming trained to that, and that's different. But in general, we suggest that keeping naps to about 30 minutes or less. And then, I'm sorry, I forgot what the second word. Waking up. Oh yeah. So waking up in the middle of the night, also super common. But it is still a sleep disruption. So it's something that you should be talking about, because that is not the time of day when your body is designed to be waking up. And you probably have not gotten all the sleep that your body needs at that point in time either. But once you're awake, obviously, I know it's harder to fall back asleep. And then it's this vicious self-fulfilling prophecy, because you look at the clock and you're like, I'm not asleep. And then you start stressing about the fact that you're not asleep. And then that makes you even less likely to fall back asleep, right? So again, it's something that's important to talk about with your care team.
You talked about what not to do before you go to sleep that would hinder it. What things can you do to promote getting yourself to sleep?
Well, to promote getting yourself to sleep, I would say making sure that you have usually we suggest at least 2 hours between when you last eat, at least 2 hours, and when you try to go to sleep, making sure that the room is nice and dark, making sure that the room is quiet, trying to use the place where you sleep, the bedroom where you sleep, to be not for activities and work, and, kind of keeping that in a separate space. And if it's helpful to read a book or something that's taking you away from a screen immediately before bed, a lot of folks find that helpful also, just as kind of like something that signals to your body, I'm winding down.
Yeah, music or meditation.
Yeah, exactly.
Amanda, would you please weigh in on sleep medications?
Oh, sleep medications are so incredibly common. And it's, for short-term care, absolutely fine. For longer term, that's where I start to get more concerned. But again, I'm not a sleep medicine doctor. So I would preserve those kinds of conversations for a sleep medicine doctor or for your other members of your care team. But, as a short term, to help you get the sleep that you need in that short term, they can be really beneficial for a lot of folks.
Real quick, are your slides available? reviewing it, can we get copies of your slides? I would like them.
So yeah, actually this is recorded, and as after the event, you'll get a link to the recording, so you can actually watch Dr. Fripp's presentation again. It'll include her slides.
And maybe
Yeah.
it'll put you to sleep.
Oh, we-
You mentioned melatonin. Do you recommend never taking it or how?
You know, I think as with so many dietary supplements that are out there right now, and I think there was actually an article about this in the New York Times not that long ago, that it's really hard to know how much is actually in there. So for example, I think they looked at kid doses of melatonin because some folks have started to say, oh, wouldn't it be helpful to help my child sleep by giving them a dose of melatonin? But the amount that's on the label and the amount that's actually in the dose, in the pill or gummy or however it's being administered, is they're not always a match. So I would say certainly not unless you're talking to your doctor about it, and not in the long term.
And just a quick comment, you mentioned 30% of patients, pain is the reason they're staying awake. So I get asked a lot, well, I take a sleeping pill. Well, what's keeping you awake? Well, it's pain. Sleeping pill does not treat pain. It treat with appropriate pain medication if pain is the reason why you're not sleeping.
Yeah.
Important, I think, sort out what is the reason for the lack of sleep.
See, that's a great question, but I would say it really depends. So the question was, is there an ideal time to go to bed? And it really depends on the person. So there's something called chronotype, which is sort of your body's natural rhythm. We think of them as like morning birds or morning larks and night owls. And that's a real thing, right? So for a night owl, their optimal bedtime is later than for an early bird or morning lark, right? But also their wake time, their natural preferable wake time is different. Unfortunately, in our US society and in others as well, for a night owl, the time they wake up is kind of dictated by when the workday starts, regardless of when they want to wake up. So we often see that those folks with the late chronotype, the night owls, those are the ones who tend to be most sleep deprived because they may be going to bed at their natural time, the time that their body is desiring to fall asleep, but they're being woken up too early. So it really depends on sort of whether you are that morning lark or a night owl or somewhere in between. So no ideal time unless it's ideal based on your own biology.
Wonderful. Thank you very much. So now it's time for a break. We'll resume at 10:40. I'm told there are extra breakfast boxes that are still out there, so feel free to have those in addition to some of the snacks that are out there. Thank you. See you back here in 15 minutes.
You know, we talk, you asked me, but I talked to everybody. We were talking like this. Is both of us agree, he got less sleep at the caregiver than he did when he was. And.
Yeah.
Caregivers, big. That's a huge area where you kind of hear, but you put everything off to the side.
Yeah. George, I'm in the middle of that myself. No, I'm just saying. Yeah, I'm completely aware of that. wanted to say hi and thank you again. It was about 3 years ago. One of these things. Good morning. Do we have everybody? Do we have everybody on? How are we doing? Everybody on? I know they don't. Yeah. We're trying to. Yeah. I think we have just about everybody back in. Can you hear from this far from the microphone? Can you hear me okay? Okay, great. I think both Dr. Hall and I tend to go into the microphone and we should stand up a little straighter. Okay, so let's continue. Those were great talks, weren't they, that we've already heard this morning? Well, we have our second keynote speaker. I'm delighted to introduce to you Dr. Charlotte Arian. She's the Carol Lowenstein Chair in Clinical Research and co-leader of the Melanoma DMT at Memorial Sloan Kettering. So she's a seasoned melanoma surgeon as part of one of the world's expert institutions in treating melanoma. And she wasn't able to come out in person, but she was kind enough to have one of her Saturdays dedicated to this. And I love the title of her talk. This is a surgeon talking about the future is bright, and probably a lot of it will not have to do with surgery. So Dr. Arian, thank you very much.
Well, thank you very much for the invitation. I'm sorry I can't be there in person, but this is a wonderful event and I've enjoyed the talks this morning as well. And hopefully this can be, informative to everyone there as well, and look forward to discussing this more. So, okay, these are my disclosures. So we know that survival has been improving for melanoma, and this is from our MSKCC database of about 10,000 melanoma patients. And you can see when we break patients down into the recent decade of treatment. So if you look on the left with the red arrow, that's 2008 to 2018 compared to our historical controls. You can see its survival by presentation year is markedly improved in this more recent decade of effective systemic therapies. And this is for every stage of disease, even over on the right here, where you see patients who have M1C disease, our most advanced disease. There's people who are surviving more, and see how flat this curve is. It seems that people are actually being cured, which is amazing feat. And yet, as we know, because we're all here today, melanoma remains a public health problem. It's one of the most commonly diagnosed cancers in men and women. And for the future, we need to focus on patients who don't respond to these standard treatments and maintaining their quality of life. So, overall, as you heard in my introduction, the pendulum of treatment in melanoma today has swung. And this is really to the point of multimodality treatment, which I hope to show you today is actually a great way forward. So on the left, you see surgery. And for many years, surgery was our only treatment. And that was because we didn't have a good systemic treatment. And there was a philosophy that more and aggressive surgery was the only way. But through multiple prospective randomized trials shown below on the arrow, some of which I'll talk about today, we've gotten to be able to de-escalate surgery. And on the right, we've had a resurgence of effective systemic therapies. And now we're looking at how to introduce those earlier and earlier in the treatment of disease. So improving outcomes in melanoma is a multi-pronged approach, trying to treat with less side effects now, less aggressive surgery, better systemic therapies that potentially could give you less side effects, personalizing therapy to patients, understanding their genomic vulnerabilities of their tumors in a very individual fashion, giving them the capacity to unleash their own immune system to target the cancer rather than just cytotoxic chemotherapies, which didn't work as well in melanoma, utilizing their own tumors in their own way. And I'll talk a little bit about this today, something called TIL therapy, personalized vaccines, which are new and on the forefront, and I'll talk about a little bit today, and then new opportunities for the future, which again is even brighter, looking at ways to combine therapies and novel treatments. So surgery, as I said, was often the only treatment for melanoma and was often too aggressive. And this was an approach proponent that was really started by a doctor called Dr. Halsted, and we call it a Halstedian type theory. But as you see in this green table at the end, he showed that if he was very aggressive in his surgery, this was in breast cancer, he had lower recurrence rates and better outcomes. And this for many years permeated many areas of surgery, including melanoma, where we would actually take out a primary melanoma, all the lymph node channels that were involved with melanoma and the lymph nodes in an effort to try to cure patients. And it was a way over treatment. It was too aggressive and left people with lifelong debilitating lymphedema and pain. In many ways, a very prominent surgeon, Dr. Morton, actually tested many of these Halstedian theories in prospective randomized trials, which thankfully many patients helped prove that it was not an effective way to treat the cancer. And so if we follow this Halstedian therapy, hypothesis that the more surgery and the more aggressive, the better, what you can see is from a local tumor up top to a primary metastasis, which in melanoma is most commonly in the draining lymph node, or to a distant metastasis, there could be areas to intervene surgically that would interrupt this cascade. And he developed two trials, the MSLT1 and 2, which I'll talk about quickly, that really look at the effect of surgery and intervening on that if you believe that this is the way things go. So the first was the MSLT1 trial. This looked at patients who had an intermediate thickness melanoma and underwent a wide excision with a lymph node excision at the same time, something called a sentinel lymph node excision or biopsy, with an immediate removal of micrometastatic disease should it be detected. And that was compared to people who just had a wide excision of their melanoma and were followed for recurrence. And what we found from this trial is that a sentinel lymph node excision, which is a minimally invasive excision of a draining node, does really portend your outcome. It's an excellent predictor of disease and how you will do. You see on the left-hand side is melanoma-specific survival. But overall, removing that disease has no effect on overall survival, and that's because it's not addressing your distant metastasis. So if you looked at the trial, the primary endpoint was the endpoint between these patients who had a wide excision and a sentinel node biopsy. We couldn't randomize at the time for patients who just had node positive disease because we didn't know who those people were going to be. And so if you follow these patients and look at those patients that had nodes removed early versus late, there is a better survival for these people who had the nodes removed earlier. But it's not clear these are the same people. And if you're benefiting anyone, you're benefiting a very small percentage of people who had node positive disease that then had a nodal recurrence. And if you look at the long-term follow-up of MSLT1, you can see that at 10 years, there was a 3% benefit in patients who had their nodes removed early. And those are probably patients who had primarily nodotropic disease that weren't going to progress to distant disease. Even still, it was hard to identify those patients, and it's not statistically significant. And in MSLT2, which was the next portion of this, where they took just the highest risk patients who had a disease detected in their lymph node or a positive sentinel node, and they looked at whether they should have more surgery, something called a completion lymph node dissection. So this MSLT2 trial looked at patients, again, high risk, metastatic disease in the detected by this minimally invasive technique, and they were randomized to either have more surgery or be followed. Now, this is an important group to remember, because I'll talk about them later, because this group that was followed was recently, data was recently published to look at the nodal recurrence. Again, these are all patients with metastatic disease in their sentinel node. But the bottom line is, removing those lymph nodes, the additional nodes, had no effect on survival by the MSLT2 trial. And it had no effect in another trial called the DCOG trial, which was from Europe, which was slightly earlier patients in disease. And so in essence, we've all decided that improvements in disease have come, and these are patients with stage 3 disease, from better systemic therapy, not from more surgery. And surgery has to be more guided and personalized. We also have a current trial going on right now, a de-escalation of surgery of the primary treatment of melanoma. So some of you may know that originally we started with 5-centimeter margins in melanoma. We're now down to a 2-centimeter margin for most advanced melanomas and a 1-centimeter margin for very early melanomas. And there's currently a worldwide trial going on right now looking at a randomization of these intermediate melanomas for either a 1 or a 2-centimeter margin. And this will hopefully finally answer the question of whether a 1-centimeter margin will be adequate for all. The obvious benefit would be less aggressive surgery, less need for skin grafts, other types of treatments if it's deemed to be safe. So de-escalating surgery in early disease has been guided by, fortunately, randomized controlled trials from multiple patients and physicians in the melanoma community. And now we know that we can give adjuvant immune therapy in patients who have stage 3 disease. I'm not going to go through these trials, but after a positive sentinel node and no further surgery that's mandated, patients have the option to get either immune therapy, which takes the brakes off the immune system, or an adjuvant targeted therapy. All of these drugs have shown, as shown here, have been shown to improve relapse-free survival, but their effect on overall survival is more questionable and may be hard to ever show, because it is also possible to get these drugs when you recur and have a benefit at that time. Adjuvant therapy this year actually was also approved for patients with earlier disease, stage 2B and C melanoma, and this is only immune therapy. So the question comes, should we de-escalate surgery even further? And do we need to do a sentinel lymph node biopsy at all on patients? I think this is best framed in the context of a clinical case. If we took a young, healthy man, 45 years old, without any past medical history or medications, who presents with a new diagnosis of a T3B ulcerated melanoma of the back and has a normal exam, but has a BRAF mutated melanoma, this patient could be referred for a discussion of adjuvant therapy and not undergo any further surgery other than a wide excision, which could theoretically be done in the office. Sorry about this. So what we know about this patient comes a lot from some of the work that we did at MSK, led by Dr. Coit. Now, this was patients who had stage 2 melanoma and had a negative sentinel lymph node biopsy, so we truly knew they were stage 2. But you could see it's a historic group, and the risk of recurrence in stage 2 is not insignificant. You can see at least 20 to 30%. However, even in this historic cohort, melanoma-specific survival is actually better, suggesting that there are capacity to rescue people even in the setting of relapse prior to effective systemic treatments. Not surprisingly, in a group where you've done a sentinel lymph node biopsy and eliminated those patients who have nodotropic disease, the most common primary site of metastasis is the lung. And so this would suggest that our patient who we presented here has about a 20 to 30% risk of recurrence based upon the findings there. And he could have a discussion about adjuvant immune therapy. So adjuvant immune therapy, or PD-1, was studied in a trial that was recently published. Patients were randomized. Now, they did have a wide excision sentinel node to either get, so we knew they were stage 2, to either get PD-1 or placebo. And you can see at 2 years, there was an 8% benefit in recurrence-free survival. This is the graph on the left. On the right, you can see that the distant metastasis-free survival was also improved, also on the order of 6% or so, with the treatment with pembrolizumab. So an absolute risk reduction somewhere around 8%. Now, 17% of the patients had adverse events, which is actually more than your reduction in recurrence-free survival. But these findings are definitely solid, and they've been recently confirmed in a second trial of a different PD-1 inhibitor that was recently out. Now, not surprisingly, the benefit of distant metastases-free survival is seen mostly in the lungs. So you can see these are patients who got immunotherapy or didn't, but we already knew this from the natural history of melanoma stage 2, that that's where the benefit would be if you're going to have it, because it's the most common site of metastasis. So for this patient, what's the value of learning something more? Right now, we know that the risk of recurrence is somewhere around 20 to 30%. The absolute risk reduction of adjuvant therapy is 8%. The toxicity is 17%, and there is a salvage for the patient because we know that these drugs work in stage 4 disease, and or surgery could be an option as well. But if the patient undergoes a sentinel lymph node biopsy and is found to have 2 sentinel nodes and his BRAF V600 mutation is also confirmed, we now know that his risk of recurrence is actually much greater. And from the adjuvant studies in stage 3 melanoma, we know that the absolute risk reduction is actually greater in this group as well, whether we're talking about immune therapy or targeted therapy, both of which are options for this patient who can get these in stage 3 disease. Just as a note, right now, there isn't an approval for BRAF MEK as an adjuvant in stage 2, but there are trials looking at this. So in stage 3, your toxicity is similar for immune therapy, probably lower for the targeted therapy, and now is less than your benefit, if you will, or risk reduction of adjuvant therapy. And yet we still have a discussion with patients about whether they want to do adjuvant therapy, but it's in a very different context because of the setting and what was learned from the sentinel node. In addition, as I mentioned before, the MSLT2 control arm trial was a group of patients who had only their first site of metastasis removed, which was the lymph node, and got no additional treatment. And long-term follow-up from this group, as shown in this graph here, shows that this very straightforward metastatectomy, if you will, provides excellent regional control with very few patients recurring in the nodal basin over many, many years of follow-up. And this is important because if we took all these, if we didn't do a sentinel node, and so there are 100% of people who didn't get a sentinel node, and you treated them all with adjuvant therapy only, which again has a much lower response rate, a significant number of patients will be recurring in their nodal basin with immune therapy, and then this will create a very complicated situation in the future of nodal recurrence on immunotherapy. So I think that this is something that's being debated hotly in the field right now. I still fall on the side of doing a sentinel node, not only for the prognostic information, but for the other reasons I demonstrated. And I think it still provides a context for which to discuss things better with the patients, but obviously it's a joint decision. Okay, how about people who have more bulky disease? You guys have heard of neoadjuvant therapy, and this means treatment before surgery. The data from this actually came from great preclinical studies looking at, as you can see with the mouse, a mouse who had a tumor who got surgery first and then had immune therapy, or who got neoadjuvant treatment followed by surgery. You can see in the two graphs that there was an improvement in survival and better immune activation shown on the right with tumor-specific cells in mice who got the neoadjuvant treatment. Now, this has been studied in humans in several different ways as well. Again, these are patients with bulky nodal disease who ended up getting immune therapy, so CTLA-4 and PD-1 followed by surgery, followed by adjuvant, versus surgery up front, followed by adjuvant. And these early studies use a higher dose of ipilimumab. This is 3 milligrams per kilogram. And in these early studies, and these were a small number of patients, there was a signal that the neoadjuvant group, the blue, did better than the adjuvant group. But furthermore, in confirming the preclinical studies, there was data that there was better immune activation and diversity in the patients who got neoadjuvant treatment. So these blue lines are patients who had neoadjuvant treatment, and is looking at clones of T cell receptors that were either present and expanded or newly detected with the neoadjuvant treatment. And you can see that in each individual patient, which is the column, they seem to get better, and it's better than on the adjuvant side. So it seems like it's getting more activation and of tumor specific, you hope, responses, and at least increasing the diversity. Now, interestingly, and particularly in light of all the neo epitope data that's out there and vaccines, personalized vaccines that you've seen, in this trial, they tried to sequence the tumor and look for neoantigens and then tried to detect them by tetramers in the patient's blood. And they actually could not do that. And so they abandoned that part of the trial. It doesn't mean that they couldn't find it. Maybe the technology has gotten better, but it is interesting in light of all the new vaccine data that they weren't able to detect or show this in this cohort. This was also at the almost the same time being studied by the MD Anderson group, which looked at neoadjuvant PD-1 alone as nivolumab, or the combination of IPI and nivo followed by surgery and then adjuvant treatment. Again, they showed that there were really great responses in both groups, but more in the combination groups. So CTLA-4 and PD-1 had a remarkable 45% path complete response rate with an overall response rate of 73%, but this came at a great cost to the patients. 8 out of 11 patients had grade 3 adverse events or greater, so that puts you in the hospital and is very significant. Furthermore, there were some delays in treatment because of these adverse events. And actually, in the PD-1 alone group, there were some patients that progressed. So there was actually a hold put on this trial. And as we'll talk about, it was changed to look for a quote unquote better tolerated neoadjuvant profile. But this data about whether neoadjuvant is better than adjuvant was really exciting this year because this trial's results actually came out. So this was patients who had resectable melanoma who were randomized to either get surgery followed by adjuvant immune therapy, or to get neoadjuvant therapy followed by surgery followed by adjuvant therapy. So it's the same doses of therapy ultimately, just given in a different time frame. And this was the first randomized trial, had a good number of patients in each group. And you can see that the neoadjuvant group had a better event-free survival, which was the primary endpoint of the trial. Now, the overall survival is looking promising, but is still not that mature. And so it remains to be seen. But overall, I think this has really solidified everybody's enthusiasm for neoadjuvant therapy. And as I'll show you, it's really a more personalized approach to patients, and also is looking at ways to escalate or de-escalate based upon this personalized approach. So can we give neoadjuvant with less side effects? Everyone also agrees that maybe the PD-1 alone in this is not what they would necessarily choose in most patients. So the MD Anderson trial was actually modified, and we joined them on this trial looking at another checkpoint inhibitor called LAG-3. Most of you have heard of this, but it's another marker on exhausted T cells, and a blockade of LAG-3 through a drug called relatlimab that we used here had been shown in stage 4 patients to have efficacy. And so we looked at it in a neoadjuvant fashion, again with PD-1 blockade or nivolumab. So patients were given 2 doses of drug, then they went on to surgical resection, and then they went and had adjuvant therapy. And you can see here on the bottom, this waterfall plot, there was 66% a major path response. And there is a 92% relapse-free survival with a short follow-up of 2 years. So this is very exciting. I think it's in line with what we saw with the CTLA-4 and PD-1 blockade. And if we looked at some of the correlative factors that correlated with response, it's similar to other trials. So you can see a pre-treatment tumor biopsy that shows more immune cells correlates with response, and also a increase in effector CD8 cells, our so-called workhorse cells during treatment also correlates with a response. But interestingly, levels of PD-1 or LAG-3 on T cells, including CD4s and CD8s, were not different amongst the treatment groups. So it suggests that there's something else going on that we're also affecting, or maybe we're just affecting those levels better in some patients. And interestingly, when we looked at things like M2 macrophages, you can see that they decreased during treatment on responders, and we didn't see the same thing in non-responders. And I know you guys have Dr. Kim there who's working on a lot of this as well. So this is a very promising area to be working on. And also during treatment, we saw an increase in EMEs on CD8 cells as well, which again may be a potential marker in responders. But most importantly, the toxicity of the PD-1 and LAG-3 was less. We had no 3-4 treatment toxicities prior to treatment. So we didn't have delays and people getting to surgery. We only had one patient who progressed. So in general, it was much better tolerated. And really all the toxicity was in the patients who received drug in the adjuvant fashion. And so in fact, 33% of patients actually ended up discontinuing treatment in the adjuvant setting because of some of those toxicities. And again, it brings up this question, do patients with a great pathological response really even need adjuvant therapy? And I think this is where we're going, where we're going to personalize treatment based upon this. And there is some data to support this, again, from Christian Blank's work in the Prado trial. So this is personalized response-directed surgery and adjuvant therapy after neoadjuvant ipilimumab. And nivolumab. And so this is really a great trial looking at really escalating or de-escalating treatment based upon pathological assessment. So what you see here is that you had patients with resectable disease, and they had shown previously that if they put an index marker on the patient's index node that's palpable or enlarged, that's an effective way to do a path assessment about what's going on, and it correlates with the other nodes. So they gave now a lower dose of IPI and gave two doses, and then just took out that index node. And then if you had a very good path response, you didn't get any further surgery, and you actually didn't get any further adjuvant therapy, systemic therapy. If you have a partial response, which has this amount of viable tumor in it, then you got further surgery but nothing else. And if you had no response at all, again, greater than 50% viable tumor, they upped the treatment in both areas. You got more surgery and you got multimodality treatments with either adjuvant therapy, consideration of radiation, etc. And so this is important because you can see that the patients who had a complete response had an excellent relapse-free survival and distant metastasis-free survival with no adjuvant treatment. Patients with a partial response, now this is a much lower group, and it's quite remarkable. I want to add that the patients with a near complete response or complete response were 60 out of 99 patients. It's a lot. The patients with a partial response only got more surgery, and they actually had the worst relapse and distant metastasis-free survival out of the group, as you can see, at 64%. And patients who had no response really had disease, multimodality treatment, and actually had a better relapse-free survival and distant metastasis-free survival. So it really argues that actually maybe this middle group also needs augmentation of treatment as well. Now, interestingly, one of the outcomes of this trial was actually looking at nodal recurrences in this top group, patients who had a complete response. And the way they set up the statistics, this portion of the trial was actually negative because they only allowed one nodal recurrence, and instead they actually had 4. So that was actually a negative part of the trial. But all those patients, 3 out of 4 of them went on to have surgery and are fine. And that's why you see a great distant metastasis-free survival rate. One patient was not able to be rescued with surgery, also had distant metastatic disease. So I would make the argument that this nodal recurrence rate is actually in line or even less than what we saw when we did completion lymph node dissection. So just excising this low node is enough in a majority of people who've had an excellent response to systemic treatment. Furthermore, by omitting this more radical surgery, or what we call therapeutic lymph node dissection, and just taking out the index node, not surprisingly, you have less adverse events. So on the top in the green and blue, we're showing you the surgical grade of complication, which is obviously less in patients who had less surgery. And below in the green and red, we're showing you quality of life through different measures of physical functioning, quality of life scores that are validated, and fatigue. And you can see that it's better for the patients who had a major path response. So in the green, and less fatigue, for example, on the right, lower right, and those are people who didn't go on to have more surgery. So it's also correlated. Okay, what about surgery for stage 4 or more advanced disease? Can multimodality treatment also improve outcomes and change what we have been doing? Well, this is also an area that was studied very well by Dr. Morton and his colleagues, who was a big proponent of operating on people for stage 4 disease. It gave them a lot of hope, and there were a few people who he helped. You can see this is, again, in the era before effective systemic treatment, that surgery plus the best systemic therapy at the time is in the red. Those patients did better than patients who only got systemic medical therapy alone. Now, of course, it's hard to know because, people selected for surgery are probably have there's a little bit of a selection bias there. But this was a very careful cohort. These are patients who were in the MSLT1 trial who were being followed very, very carefully. So it is a good cohort, suggesting that surgery helps some people, but it does not a winner. Now, the first data for the effectiveness of surgery plus immune therapy, ironically, comes from Dr. Morton's vaccine trials, which I'll talk more about later. But this was a phase 3 randomized trial looking at a Canvaxin, which is a melanoma vaccine with BCG as an adjuvant to try to augment responses versus BCG alone. And these are patients who had resected a metastatic disease and then went on to get adjuvant vaccine. And you can see that actually the overall survival was not different between the groups, but for a very advanced group, they have an excellent survival, better than historical numbers, suggesting that maybe there was some benefit to both, but they just couldn't show the benefit of the vaccine. Now, more recently, we have the long-term follow-up of this amazing cohort of patients who received immune therapy for stage 4 unresectable stage 3 disease that was published. And this is really a landmark in our treatment of patients with melanoma. You can see in the red line that these are patients who received Nivo plus Ipi, so CTLA-4 plus PD-1, or in the blue is nivolumab alone, and the green is Ipi alone. So the combination therapy has resulted with 6.5 years of follow-up with a progression-free survival, which is acceptable, but more importantly, an overall survival that's 49%, so almost 50% survival at 6.5 years. And for a group that used to survive on average, less than a year, this is really, really remarkable. Now, it's definitely true that the drugs have driven this, but as you see here, even if you look at the best drugs, you can see that a significant number of patients progress on the left, and yet their survival is still good. So what happens to those patients when they progress? And so by this paper, you can see even in the best group, which is the red group, 77% of patients never receive a subsequent additional systemic therapy. So what are the local therapies that they receive? Well, we do know that the lymph node, this is from this paper, is actually one of the most common sites of relapse after immune therapy. So you can see here in the first line site of progression of therapy, it's actually lymph node is first and liver is second, and then it's soft tissue. So lymph node and soft tissue are very surgically resectable sites of disease. And if you look here, you can see that actually about 22 to 30% of patients did get surgery as their subsequent treatment. And so who should we select to get surgery at relapse? So this was looked at by the group at Yale. They looked at their patients who they selected for surgery, and they took patients who were on checkpoint inhibitor, who had an incomplete response and who had survived at least 6 months. And if they had survived at least 6 months, they kind of divide them into groups where a group that could be resected to no evidence of disease, or a group that had non-progressing residual disease, which is obviously a small portion of the overall cohort, but is an important way to try to get at the biology of what's going on in these patients. And so you can see here on the right and left for progression-free survival and distant metastasis-free survival, the patients who underwent surgery who did best were the patients that were resected to no evidence of disease, but it actually wasn't statistically significant for the patients who were selected for surgery, again, based upon not having any progressive disease at the time of an operation and having the benefit of being on checkpoint inhibitor for 6 months. And again, if you look at the percent survival, this is greater than what we've seen traditionally for patients with stage 4 disease. So I think this is another opportunity for us to frame in a setting of a patient that I also had. And I should just mention that all the patients that I'm presenting gave me permission to present this information today. So this was a patient, he is a male who has a history of a truncal melanoma. In 2012, he underwent a wide excision and had a positive sentinel node biopsy from both groins and underwent completion lymph node dissections at that time. He then presented with lung metastasis, recurrent groin metastasis, pelvic nodes, and he got CTLA-4 blockade, where he actually had a great systemic response, but not in the lymph nodes. So then he went on PD-1, but he continued to progress in the lymph nodes. And then they weren't sure what to do. So then they radiated the nodes, but he still had progressing disease clinically and radiologically and was sent for consideration of surgery. And so you can see the patient had very bulky disease on the CAT scan. Some of these looked a little necrotic, but there was plenty of live nodes as well. And this was a quality of life even issue for the patient based upon comfort and everything else that we decided to take the patient to the operating room. And so we resected the disease, had our plastic surgery colleagues put in a nice flap. He's been NED without any further treatment for 10 years. So it made us think about how many patients we are doing surgery with who've been treated with immunotherapy at MSK. And along with my colleague Danielle Bello, we looked at patients treated with checkpoint inhibitor who ended up going to surgery. And you can see that it's of patients who actually are undergoing a real surgery, not just a med port placement or some other non-significant, intention to treat the tumor surgery. It's only 15% of patients that we've treated with checkpoint inhibition. But if at the time that they were referred to surgery, we stratified them based upon a response to immune therapy, we saw significant differences in their outcome. So if we took a patient who had a responding lesion or a stable lesion that we could resect to NED, which was actually our smallest group of patients referred for surgery, they do quite well, as I'll show you. This most interesting group is this intermediate group who had been on checkpoint inhibitor and either had a single site that was progressing or had a single site that was progressing in the context of residual stable disease. So they had had some sort of systemic response, but they had an, if you will, escape lesion. And that was 106 patients. And then we had patients who had multiple sites of progression. And we would expect these people to do poorly because it suggests that they're not responding to immune therapy or systemic treatment. And that was also just over 100 patients, 119 patients. So these are the group of patients, primarily stage 4, some unresectable, stage 3, mostly cutaneous melanoma, but a few other subtypes such as acral and mucosal. Most patients got IPI or combination therapy, and this is really because of the context, the historical context of our group. And some people had again, we had more than one tumor that was removed in some patients, but mostly it was a single resection of one item. So only 87 patients were resected to NED, and we'll show you the follow-up. So again, selecting patients by systemic response to immune therapy, if we remove one lesion that remains after treatment with immune therapy, this group does quite well. And some of these patients had residual, actually, viable tumors. Some patients did not on surgical resection. And I don't think this is surprising that these people do well. What is interesting is this patients with isolated progressors, how well they did. And I'm going to show you more about them in the next slide. And then lastly, these patients with multifocal progression, this to me is what we used to see when we did surgery for patients who had stage 4 disease in the era prior to immune therapy. They do quite poorly. And I really think in these people, we should only be operating for symptom palliation. So again, this group in the middle is quite interesting, who have these isolated progressors. You can see even if we resect to NED, not surprising, they do better, but even with residual disease, they have still a pretty good outcome. And it's a suggestion that surgical removal of an isolated escape lesion may be an effective strategy in the setting of an overall good response to immune therapy. Again, at this time, no further therapy was used in a lot of people, so suggesting that, that this was a durable response. So as we think about other treatments for patients who progress, we're now going to switch more to other personalized treatments. Again, just highlighting the fact that people who get immune therapy or targeted therapy, a significant number of them are faced with a recurrence at some point. And this is one of our major issues in the field of melanoma right now. So one of the personalized treatments is TIL therapy. And this is a tumor infiltrating lymphocyte, or TIL is how we talk about it. And basically, the surgeons take out a tumor in coordination with the medical oncologist from the patient, and then it is either in a in-house fashion or through new companies which have been developed. The tumor is digested, and the infiltrating lymphocytes which are in the tumor are expanded and stimulated in a dish, and then either cryopreserved or immediately used while the patient is being prepared in the hospital. And there is a few steps to this. The patient is actually admitted to the hospital, undergoes a chemotherapy to reduce the cells in the body. The TILs are infused along with a T cell growth factor called IL-2, and then obviously assessed for response. So there's several companies that are doing this. This is a recent publication from the Iovance group, looking at several different trials. But basically what I think is so important here is looking at patients who had a median of 3 prior therapies, who then went on to get TIL. You can see that there's a 31% response rate, and some of these were complete responses. So this is remarkable and is really opening up the door for new treatments. Furthermore, there was a trial that was just recently published, and this was a prospective randomized trial of patients who progressed after a single line of systemic therapy. 98% of those patients had received PD-1, and interestingly, about 20% of them have received PD-1 in the adjuvant. Is the progression-free survival. So there seem to be very durable responses in the TIL group compared to the IPI group alone. So this is very, very exciting. It's opening the door to a whole new area of treatment in melanoma, and particularly for our biggest need, and that's for patients who have failed our standard immune therapy, and suggesting that TIL can still rescue some of these patients, which is extraordinarily exciting. Okay. So the other area of personalized medicine that's made the news a lot recently is vaccines. And I wanted to take a moment to just talk about it, because there's been a long history of the immune system and vaccines in cancer, and particularly in melanoma. And this is a paper from 1996 looking at all these different vaccines that were available at the time. And these were all smaller studies, but not insignificant studies, looking at trying to see if injecting patients with either live irradiated cells or predicted antigens in the setting of different types of adjuvants to increase the immune recognition would correlate with an immune response, and whether the immune response correlated with survival. Now, most of these were phase 2 trials. There was this phase 3 trial looking at a vaccinia, and actually it didn't actually show any benefit. But the one that, was best studied is the Canvaxin trial. So I just want to talk about that quickly. So the Canvaxin was 3 irradiated cell lines that were used in an adjuvant fashion for patients after surgical resection and was given for 5 years after surgery. And it was given with BCG, as I said. So obviously that's you can look for a delayed type hypersensitivity response with a positive PPD. So they use that as a measure of, vaccination and being able to activate a person's immune system, which actually was quite effective. And you can see in these phase 2 studies from 1996 that there was a benefit for surgery and adjuvant Canvaxin in this phase 2 study. This was in patients who had their lymph nodes removed. So this was stage 3 disease. And this was in the setting of metastatectomy for stage 4 disease. And the blue is the surgery plus the Canvaxin. So very, very promising. But so it was really heartbreaking to all of us when this trial was done, which was a prospective randomized trial, randomizing people to surgery plus this BCG or BCG Canvaxin. And I showed you these results. There was no improvement with the Canvaxin vaccine. And again, maybe it's because the BCG had some efficacy itself, but this really shut down a lot of the vaccine hope for a lot of us in the melanoma field. And people have tried to do more elegant studies since then, really targeting antigen presenting cells, other types of peptides, et cetera. But when this, I'm sorry, is just to show you that even when they looked across many different factors with a multivariate analysis, they didn't see any benefit for the vaccine. So the first trial showing a benefit of CTLA-4 blockade was designed with a vaccine in line. This was a GP100 vaccine, which is a peptide vaccine, and it was given at either alone or in context with IPI, with the idea that, okay, in the context of checkpoint blockade, things are going to be better. So if you look at this is the original paper that allowed for IPI to be FDA approved. You can see that the best survival is actually in the IPI group, and the GP100 is just below it, GP100 plus IPI. They're not statistically significant, but the vaccine itself didn't seem to do anything, and there certainly didn't seem to be any clear improvement with the GP100 vaccine given at the time of checkpoint blockade. Again, disappointing news for a vaccine. But we're in a new era, new hope. Now there's all this mRNA technology, and it maybe even improve systemic therapies, improve checkpoint blockade. So is there better hope for this? Well, I just want to reiterate that the mRNA research has been going on for years. So this is a paper published in 1992, which was actually the first shown way that people were using mRNA to just deliver things into the cell. So this was in a rat that didn't have the capacity to produce a protein called vasopressin, and they used this mRNA technology, demonstrating that they could get it into the brain of these rats, and it could temporarily reverse their disease. So there was no integration into the genome. It was only a delivery, and it was only temporary. It wasn't forever, because the mRNA is degraded. So there was a lot of hurdles to overcome in the mRNA vaccine world. And these are just some minor things that I think are important to highlight that were occurring for many years, thankfully, before we had COVID and everything. But one thing was that the RNA was not stable and was hard to grow in a dish or in vitro. And they've done some molecular biology techniques to change that to allow this to happen more easily. Another was that the RNA is recognized by the immune system and destroyed. If your cells are dying, your immune system has these pattern recognition receptors that recognize free-floating RNA, and it's not a good thing. Your body recognizes it's not a good thing. So it actually revs up your immune system, and your immune system destroys the RNA. So they did something to modify the uracil on the RNA so that it doesn't get destroyed right away. And furthermore, the RNA is hard to deliver into a cell, and they figured out a way to package it in these lipid nanoparticles, which changes the charge and allows it to get into the cell more easily. This lipid nanoparticle has been going on for many years, and some of you may know that many of our drugs are actually put into lipid nanoparticles as well, and it has reduced the toxicity and maintained the efficacy of drugs such as doxorubicin, which used to be very cardiotoxic, and now we're able to avoid that. So using all these technologies, there was just recently a clinical trial in melanoma looking at a personalized cancer vaccine using the mRNA technology with Pembro alone versus Pembro plus vaccine in patients with high-risk melanoma. It's just presented at AACR. It's not even published yet, but it's exciting, and I wanted to discuss it a little bit today. So it took patients with advanced melanoma who underwent a surgical resection, and they were randomized to either get PD-1 blockade alone or with this personalized mRNA vaccine. Now, what they did is at the surgical resection is that they harvested the tumor, they sequenced it to look for the neoantigens, then they used molecular and prediction techniques to look for what's called the HLA, or the capacity for these antigens to bind. And then they created these neoantigens and put it into the vaccine and then injected it back into the patient. So pretty remarkable. And this is, again, not published. This is just from the internet and demonstrating that there is a signal here for the patients who got adjuvant Pembro plus the vaccine versus Pembro alone. If you look at these patients, they were very high risk patients. This gray line, which is Pembro alone, I think is in line with the other trials that we've seen. So it does seem like there's a real signal towards improvement. But I think, in light of everything we've seen with the prior vaccines, we have to see if it's really different. So do we think it's different? I think what's really remarkable is that you can create a personalized vaccine in 6 weeks and get it back into a patient, and the opportunity to use more than one antigen. So like when you think back to GP100, it's just one, one peptide that they were using. Here they can use over 30. There's currently a phase 3 trial that's really going to determine these final results of, it's going to be a multi-institutional trial where we're participating. You guys may as well. And lastly, I think what's really an important consideration is how this adjuvant therapy will compare against stage 3 patients who receive neoadjuvant therapy, because for many people, and ourselves included, patients with high risk bulky disease are really being shuttled more towards neoadjuvant treatment at this stage. And as you saw, those patients who have a complete response are doing excellent. And in many ways, those neoadjuvant treatments are almost an in vivo vaccine for a patient, because you're allowing them to release their own immune system and use their own cells that are there to attack the cancer. So maybe those people don't actually need a vaccine. And lastly, like I said, the treatment's likely expensive. So maybe these in vivo vaccines at a better time point would be better. Another way to probably create an in vivo vaccine, if you will, is to use local therapies to enhance immune therapy responses. And this is an area that I don't have a ton of time to get into, but is really an emerging therapy. And I know you guys have been working on it there as well at the Hutch, is using something local, radiation, local chemotherapy, viral therapies such as TVEC or many new TLR agonists into the tumor, IL-2. You get some cell death, you get changes of the local tumor, you can increase antigen presentation, combine that with checkpoint blockade, and see tumor specific responses. And so in many ways, this is fast and probably less expensive than a true vaccination for the people it works for. We studied this at MSK through a tumor model, looking at local melphalan, because we knew we could replicate this with a limb infusion in combination with immune therapy. We saw that it was better in mice. And when we gave the chemotherapy, we upregulated things like MHC class 1 and PD-L1, which suggested that we could, in fact, uprate some of these immune markers, and that some of this was interferon dependent, because when we did this in mice that lacked the receptor for interferon, these effects were lost. So we then wanted to translate it, as I noted, into a model of limb infusion, which was we do really in a palliative setting for patients with metastatic melanoma and in-transit disease. So limb infusion is been around since the 50s. It has it's again, as you see in the picture, it's infusing chemotherapy just into the limb itself. It has about a 50% response rate. Half of those are complete, but the durability is quite low, and most patients die of distant disease. So this is just looking from the Duke experience of looking at limb infusion or something called limb perfusion, which allows a more aggressive infiltration of chemotherapy. And you can see that there's no difference in survival between the two groups, although there was a difference in response rates. And that's again because people go on to die of distant disease. So we designed a trial looking at this in patients with local chemotherapy along with systemic therapy. And we saw a remarkable increase response rate with this local chemotherapy. So it was 85%, so greater than the 50 that had been historically seen. But most important was that the progression-free survival was over 50%, suggesting that most complete responses were durable. And when we look in the tumors, we saw lots of inflammatory changes that you would expect, both in the tumor and in the blood. And also, we see changes really at the level of the tumor itself. So increase in MHC class 1 expression shown here in the brown. And actually, while we saw more CD8 cells, we actually saw quite a lot more CD4 cells as well. You can see these were some of our changes in T cell clonality. Wasn't really seen in the blood, but we did see some in the tumor itself. So when we looked at this, as far as progression-free survival, this is progression-free survival that was published from John Zager's group, just looking at whether you had high or low burden of disease. This is a cohort of a lot of patients from a lot of different places. You can see it's about a 20% win. This is progression-free survival with IPI or PD-1 alone, again, in the stage, more stage 4. And again, in transit disease, patients are not as well represented in those studies, but this was our progression-free survival. Again, very small number of patients. And what we're really using it for at MSK now is patients who actually have failure on standard treatments. So this is an example of a patient who had an acral melanoma, had in-transit disease, failed BRAF, failed PD-1, then got a limb infusion plus IPI, NED 7 years later. Again, could have been a response to IPI alone, but we think there's some augmentation with the systemic treatment. And now we're moving this into a trial that is ongoing in patients with sarcoma. So sarcoma is thought to be more of an immunologically silent disease. This is an example of a patient who just has a P53 mutation and ATRX, who had 7 resections of recurrent myxofibrosarcoma, had disease in and out of the limb, so in the leg and in the nodal basin. And you can see after limb infusion, and this is PD-1, we see a lot of immune cells, and the nodal disease went away, the local disease went away, and she's like 3 years out without anything coming back. So we think it's exciting. That's one way to get there. There's many, many other ways to get there. But in conclusion, I think the future is bright because we have so many different modalities from which to go. We've come a long way from very aggressive surgery and only surgery, and through a very educated way to more refined surgery, as predicted in the beginning of my talk, and integration with great systemic treatments. And I think the future are going to be some of these personalized vaccines for patients who really need it. Maybe we're going to give this to people whose interferon signature, for example, is very low on pre-treatment biopsy, and they're not going to get neoadjuvant therapy, and we're going to, because we know they're less likely to respond. And then we're going to, reserve the vaccine for those people. That would be one hypothesis. Also genomics is going to enter into this as we understand more novel drugs. I didn't have time to talk about that, but our unmet need is clearly some of these more immunologically silent tumors or other NRAS tumors where we need better novel drugs. And there's a lot of work going on there. I think TIL therapy is super exciting, and we're going to have to define who's its best use for as well, because it's certainly more invasive than a drug that you get as an outpatient. And also just maybe designing the TIL therapy to be able to be given as an outpatient would be an ultimate goal. So I do think the future is bright. I think the whole field is just exploding, lots of possibilities. And I hope you can see how far we've come. And so with that, I just want to thank everybody for your attention and for everyone who's helped support this work.
Well, thank you, Dr. Arian. There will not be a quiz from the content covered here. I think, Charlotte, as you know, that is a ton of material, fascinating work. And what I would distill from what you say, I'm a surgeon I'm a cancer doctor first who happens to be a surgeon. Fortunately, I treat breast cancer as well. I saw the neoadjuvant treatment with breast cancer 25 years ago. And the trouble is we didn't have drugs for melanoma. So we've been doing neoadjuvant treatment for breast cancer for 25 years plus, because you can effectively reduce tumor size, get the life-threatening treatment or disease treated at the earliest possible time, and downsize the amount of surgery. So I had to work on my melanoma medical oncology colleagues, and I was delighted there were a couple of them here today, to help bring them along to say, now we're there with melanoma. I see it. I knew exactly where we were going because I watched it with breast cancer and now with these successful drugs. So I think what you saw from Dr. Arian was you saw a group of patients with advanced disease with a dismal survival curve. These curves went down to 5-8%. And those numbers have popped up. And not only are the survival curves higher, but the flatness of the curve. And you heard her use the word cure in there. She didn't even say it as quietly as many of us are saying it. She said some of these patients are cured. These are stage 4 and advanced disease, but we never saw that before. So I think that's one of the main things. The other is patients with earlier stage disease, stage 2 disease. We've tended to follow them after surgery in our clinics, and there's a substantial number who recur. So how do we follow those patients more effectively and bring in our medical oncology colleagues to make sure we're not missing out on either something up front or close follow-up to go after that? What she didn't talk about is what we do know is 80% of patients are cured with surgery alone with melanoma. In the early stage disease, we still have them. And even before that, we'd love to prevent it and have people get out and avoid sunburns if they possibly can. But I think, Charlotte, this was very exciting to hear this. I think we're a little short on time for questions, but I do want to open at least for a couple of questions. And again, there's no quiz, but the slides I think will be available. And you did cover a lot of great material. We have questions. There's a question from the audience over here.
Hi, yes. Hi, Dr. Bird.
Hi.
I was just curious, you did say the C word, the cure word. So for years, we've been going with NED is the best you can be, So are we now saying that melanoma can be cured then actually, or are you in remission? Or are you still NED? Like, what's the right terminology to use? Because I'm just curious, because I'd like to be able to use the right words in talking about survival, right?
Right. Well, I think it is a context. How many years do you need to be with that disease to say you're cured? We don't know, but at the earliest report, many years ago was that, there was patients alive and well. These are the original patients treated from the NIH. When that report came out, they were 10-year survivors. And I know people who are, surviving more than 10 years. So maybe we need to change the context, because maybe you can just live with your disease, and that's also an important thing as well, that we're seeing with immune therapy, that people are living with disease. So I don't know, maybe we need to just reframe it that you've learned to live with the disease at some level, right? I don't know. I don't think there's a magic number where we're ever going to say cured, but for me, it's people who are living out longer than 10 years without anything coming back. And that these patients, for example, who had brain metastasis or something terrible, where we never saw them live before, that's the most meaningful group. But
yeah,
everything's meaningful.
Go ahead.
No, it's fine.
How I use that is, I really don't like the word remission. Remission means, well, it's still there, but it's coming back at some point. We don't know when that is. It's in remission. And especially for early stage patients, I am personally convinced there's a large proportion who are cured, meaning disease never comes back in the time they are alive. Something else will end their life. But I also know that the word cure has an absolute sound to it that means it is not coming back, and none of us can say there's no chance of that. So I think likely cured, meaning no disease coming back in your lifetime, is something I use a lot in earlier stage patients. I think we're going to be using it more and more in these flat curve immunotherapy treated patients who were out with these flat survival curves. So that's how I use it. Remission, you really don't like it. Cure, use it carefully, but probably more often. Well, no NED means no evidence of disease, just so you know what that means. And that's a little bit of a neutral term, but it sounds good. I like NED.
Question from the chat. This gets at the idea of personalizing treatment. So the question basically is there anything in the melanoma itself or the pathology report that would help identify early stage patients who are more likely to have future problems? So kind of thinking about how do we maybe intensify care for that group? Any thoughts about where we're heading in that regard?
This is a great question. I didn't get a chance to discuss this, but another area of escalation or de-escalation is trying to predict beyond what we know from pathology reports. And so certainly we know things such as ulceration, high mitoses, those things are associated with a little bit higher risk of recurrence. And there are some patients who recur with earlier disease. There's a lot of work going on now looking at gene prediction signatures. So through different companies that have developed kind of a risk score, I think that this is a great adjunct as long as it adds more to our current, staging system that we have. But I think if you have a stage 1 melanoma, you should be comforted that thousands of patients throughout the world have showed us that most of those people do really, really well. And so I think, as was just being said, putting this in context of your other risk factors for life is really important.
Great questions. And thank you for joining us so much. Very informative.
Yes.
And maybe we'll get you out here in person next time.
I'd love to.
Thank you.
Thank you.
Okay, we're a few minutes behind, but we got a really important topic here, a couple coming up. And we're switching gears a little bit into the survivorship aspect of what we were talking about. And it's my pleasure to introduce Lexi Harlow. Lexi's title, I believe, is Manager of Rehabilitation Services at Fred Hutch. The word manager to me describes somebody about here. This is a leader in rehabilitation services. And I would say Lexi is a leader with passion. So I'm delighted she was willing to talk about rehab and patients with melanoma. One of my best friends and one of my favorite humans on the planet.
Thank you, Doctor.
Thank you very much. It's a pleasure to be here. As I was sitting and listening to the speaker before, I was just thinking about my journey as a rehab professional and treating patients with side effects from melanoma treatment. And I have to say that I am happy to report that the things that I saw early in my career, we don't see as much anymore. And as I go through my presentation, you will see me touch on that. And I think that that's just another great development to just know in the survivorship and the quality of life that we've impacted that tremendously. And again, I have seen that in my career. All right, so I'm going to talk about two main topics today: lymphedema, because it's so prevalent in melanoma for obvious reasons, probably from the previous presentation. We're sort of wreaking havoc often with that system. So that's a side effect that we treat a lot of in rehab. And then I'm going to finish up with talking about, I would be remiss as a physical therapist to not talk about exercise and physical activity. So I will end there. But let's start with lymphedema. So what is this? It's an excessive buildup of fluid in the body tissues that are due to a disruption in the lymphatic system. This can come from a variety of reasons, either the tumor itself or we're disrupting the actual structures of the lymphatic system. If it's not treated, it causes chronic inflammation, infection, hardening of the skin, and it damages lymph vessels, which has a negative impact on the body. This usually develops slowly, and it's typically progressive. That can be the tricky part about this, is we can actually see patients who are showing subtle signs of lymphedema, but it may be hard to kind of figure that out. But we've also grown in this area, and I'll talk about that in a moment, of tools that allow us to do this. Most lymphedema in this country is due to cancer or treatment for cancer. Really important to know that and recognize that. Unfortunately, there is no cure for lymphedema. So early detection and intervention is key. Once you have lymphedema, you have it for life. So just briefly, the lymphatic system here is made up of a number of different structures. You have vessels, you have nodes, you have capillaries. And this is actually showing the lymphatic system at work, these few diagrams here. And MLD noted there, that's actually a tool we use in therapy called manual lymphatic drainage. And this tool is very effective in actually moving the fluid through the vessels and the tissues when there is a blockage or an issue. We actually move it from one part of the body to another in order to help mobilize and get that fluid out of the area that it's congested in. This is the node itself and showing all the intricate details of how the system has to work. And what's really interesting about the lymphatic system is there's no central pump like your circulatory system. And so it has to depend on other mechanisms in the body. And one way that we also work on lymphedema is by exercise and muscle pumping. It's very, very important. And so I'll talk about that also as a central key of how we treat lymphedema. But lymphedema is just more than fluid. And I want to touch on this because it's really important. This is why we care about it not progressing. And when early in my career, when I would see patients with lymphedema, we would see all of these things happening in a very profound way. Fortunately, we've gotten better and we don't see as many of these issues happening because we are addressing this condition earlier. But it is more than just fluid. It's chronic inflammation. There are connective tissue changes, otherwise called fibrosis, that happen. There's fatty deposits, there's skin changes, and the risk for infection is much more elevated in those areas that are experiencing lymphedema. You can see on the diagram here that there's the sort of non-lymphedema and then lymphedema. So it is really drastically changing the tissue. So really, really important. And one of the things we try to do early on is prevent the changes of those tissues, because again, once they change, that has changed. We can't really reverse that. That's just again showing non-lymphedema, and then we're seeing lymphedema, which is really interesting here. And I don't have time to talk about this today, but the fatty deposits and sort of this whole cyclical process that happens in the body to actually increase the rate of that is very interesting in lymphedema. So specific to melanoma, what is the incidence? Okay, you're probably going to say this is really wide. It is. The problem with us definitively knowing this is we haven't quite gotten to the point where we're all defining lymphedema in the same way. And also it can be hard to study lymphedema. I already alluded to when are we diagnosing, how do we diagnose, how do we figure out stage? So there has been studies done on incidence, but you will see it's very widespread. I also believe this is widespread because clinically, we can't predict, well, who's going to end up with lymphedema. We can have patients who have one lymph node removed, just one, that sentinel node, and they end up with eventually stage 3 lymphedema. We can have other patients who have several lymph nodes removed, 7, 10, and they do fine. They just do risk reduction strategies and they never end up with lymphedema. So the incidence range is wide. Lower extremity there is 7.6 to 82.5, and then upper extremity 4.4 to 14.6. I will say, I do think this is moving in the right direction. The incidence is becoming less and less. And again, I believe that's due to the attention being paid by our surgeons and those that are treating these patients to understand the impact, the negative impact that lymphedema has on patients' lives. So what are overall risk factors? And these are just important to remember in general. If you come to the table or you are experiencing these at the same time that your lymphatic system is disrupted, it increases your risk. So if you have a more invasive surgery as part of treatment, lymph node dissection versus sentinel node, if you have radiation therapy on top of that, I call it the double whammy. So if you have surgery, lymph nodes are disrupted, removed, and then you radiate, That's sort of setting you up for a problem. So that's an important piece of the puzzle too. Or if you've had other radiation in the past, that can also lead to a risk factor. Obesity, I talked before about fat and being an issue with lymphedema. It's definitely something we have to pay attention to when we're treating it to make sure that we manage this well. Infection puts you at risk for lymphedema. Sometimes patients can get an infection and that causes the lymphedema. So just an important risk factor. Tumor obstruction, and then finally age. As we all get older, our systems just don't work as well. So I've had a number of patients in my career too, where they'll be going along fine and then all of a sudden something happens, usually cardiovascular wise or with another system in the body. And then we start to see the swelling that's a result of the lymphatic system also being affected. So how do we diagnose lymphedema? So there's a number of ways. And again, this is an area I think that we're all in this area of practice getting better at figuring out how to do this well. But you typically figure out diagnosis by a number of ways. History and physical examination. So visibly, what are we seeing? What is the patient reporting? And honestly, I can tell you clinically, sometimes that is the best indicator of when someone is experiencing lymphedema, is they know there is something going on. They tell you there is a difference because it can be very subtle. There are imaging capabilities, and these are getting more and more refined all the time. There are lymphography studies or lymphocytography studies, and these really look at the vessels and the structures themselves, both superficially and then deep, because there are two kind of big components of the system in that regard anatomically. And so they're looking to see where are the blockages, how is the flow happening, is the flow leading to actually the ICG, which is a chemical they'll use in these scans, showing up in areas it shouldn't. It helps them to just understand what's going on with the system. We do a lot of limb measurements. We take measurements all the time with our patients with lymphedema because we're tracking that change over time, both from a baseline perspective as well as progression of the condition. And then a very recent development, and this is really a proactive tool that we will use, and we're fortunate at Fred Hutch to have a couple of these machines. They also have them at UW. And these are bioimpedance spectroscopy machines, and they're really looking at the amount of fluid in the limbs, and they'll look at the normal side versus the at-risk side and tell you if there is a difference from side to side. And it just helps us. It's a tool. It's not definitive. It doesn't, shoot something out of the machine. Oh, this patient has lymphedema. It's just one thing that we look at, and it helps us to know, especially for early stage, what we call stage 0 lymphedema, whether or not someone is headed in a direction that we need to be concerned about. So what are those signs and symptoms as a patient you should be looking for? What are the things we ask about in physical therapy or a rehab visit? So heaviness, fullness in the limb, chest wall, area that's at risk. That's really, again, subjective report is really important. Jewelry or clothing fitting too tight. It seems sort of like, but that's often an early sign as well, because something is changing in the body and it's subtle. Tightness of the skin, so less definition of tendons we look for. Pitting edema, maybe edema or swelling that's coming and going. Less mobility in the joints, your joints feel tighter or more stiff. And then clinically, we look for greater than a 5 to 10% difference in volume. And again, we can use some of the tools we have like the SOZO unit, or we just do this with volumetric measurements of using a tape measure, old-fashioned tape measure, and figuring this out clinically. Is there enough of a change in the difference in volume? If there is edema going on, and we can't attribute it to something else, we have to consider lymphedema unless proven otherwise, okay? So at that point, that's where we're starting to really go down that path of addressing lymphedema. So how do we treat lymphedema? So the gold standard, it's something called, you'll hear CDT, that stands for complete decongestive therapy. This is the hallmark of treating lymphedema. It's very effective in volume reduction, but it's tricky because once you reduce the limb, You have to maintain the size, and that can be the challenge for patients. So what are the goals with CDT? Again, we're reducing volume. We're avoiding infections because remember, that's a risk factor for progression. And we're minimizing those tissue changes that become permanent for patients. So what are the components of that? I already touched on one, which is manual lymphatic drainage. This is not just massage. It's actually very specialized. It's actually very gentle. We have to get, as therapists, additional training in order to do this because it is a certain technique and sequence, and how we move the fluid through the body is very key to this. We then use multi-layer short stretch compression bandaging. These are not ACE bandages. And in fact, if you walk into our clinic with ACE bandages on, it makes all of our blood pressure go up because you are actually going to create more of a problem. So you have to use very specialized bandages, and we teach and train caregivers on actually how to wrap using these bandages because there is a sequence and an order to them as well. I already touched on exercise, very, very key. Once someone has their volume reduced and compressed, they need to be exercising because that is the muscle pump that moves the fluid through the body in the lymphatic system. We want to avoid infection again, so skin and nail care, we talk a lot about that, keeping your skin hydrated, watching out for cuts or breaks in the skin, that type of thing. And then finally, we do a lot of education in regards to management and wear of compression garments. So more details just quickly here, and I really have a lot of detail. You'll be able to see these slides and take them home, but I just want to touch on a few things. Is that compression garments need to be worn all the time, okay? Once you're reduced. Now, that can shift and change depending upon how you're going through your course of lymphedema management, but I really just want to highlight, it's really important that those are worn and they're replaced regularly. Treatment should ideally be delivered by someone who is certified in treating lymphedema. Really important, I touched on that. This is a skill set that not all therapists have. At Fred Hutch, all of our therapists are certified in treating this. Risk reduction is very, very important. The strengths of CDT are that we get that significant volume reduction. It's very, very effective. It's not invasive. There's limited side effects, and most patients can do it. So those are the sort of pros of this type of treatment. What are the limitations? We're focused on the symptoms. We're not necessarily addressing the cause or the issue, and I'll touch on that in a moment. We talk about surgeries. It's less effective in later stage lymphedema, so we really struggle as therapists to help patients at a certain point because it's progressed to the point where, gosh, CDT is really not going to get the benefit that we want. So what do we do in those situations? It's time consuming. When you sign up for this, any of you that have been through it, or if you come to our clinic, we will require a lot of time from you to manage your lymphedema with you. It's expensive. These garments can be thousands of dollars, and you have to keep them on and you have to replace them. It's lifelong. Again, this doesn't go away. And it's hard to find therapists who do what we do. We are a hot commodity. We have a wait time typically of 6 to 8 weeks in our clinic. That's very typical for most therapists that work in this area of practice. There are other modalities in my career that I've seen involved in treating lymphedema, which are exciting. Those are lasers. Touch is like a vacuum pressure device we will use on patients. And then I think a really great development that I've seen in my career is really the surgical techniques that are now being used to help really in the later stage, but we've also seen development in early stage, which is exciting too. And those are the LVA and the lymph node transfer. But before I get there, this is just a picture I want to show you. These are the realities of compression for lymphedema, okay? When lymphedema was first being managed, when I was young in my career, we kind of had limited options. There was sort of like a type of garment, a type of thing you could use. Fortunately for patients, to benefit all of you, there are so many different things. And this is so great as a therapist because we can usually find something that we can use on any patient, which that was not always the case. That was really a struggle for us for a long time. But as you can see, this doesn't look very fun either for patients. So on that note, we have had a lot of developments in recent years around surgical management of lymphedema. This is an exciting area of practice. We are doing these techniques at the University of Washington, and we are seeing clinically a big impact on the outcomes from these surgeries. And that's exciting when I think about the patients who could have benefited decades ago around some of these treatments. So what are the goals? Again, volume reduction, decreasing incidence of infection, preventing disease progression, improving that limb function, how the limb looks, but again, it's not curative. Lymphedema is there, it's going to be there. So what are these procedures? So there's two primary procedures I'm going to talk about. The first is the LVA, or the lymphovenous anastomosis and bypass. So this is literally a procedure where, and this is microsurgeons who do this. So you have to have very specialized surgeons in plastic surgery that work on this. And we have a good, robust group of them at UW, again, doing these. And they actually will bypass from the lymphatic system to the veins in order to give it a different path for that fluid to go. This can be used in early stage lymphedema, and we're seeing that done in breast cancer with lympha. They call lympha procedure, where they're trying to be proactive about lymphedema. We also see this being used sometimes for mid-stage. It's a little trickier in later stage, but it is an option that those surgeons will offer to patients as a potential way to help manage lymphedema. In later stage lymphedema, you're typically going to see more of this route happening, where there's a lymph node transfer, where they're actually trying to move a structure that can filter the fluid, a lymph node, from one area of the body to another to help with where that blockage is happening. So what are the outcomes of these surgeries? I will tell you overall that studies are showing that the outcomes are significantly better of the combination of surgeries with CDD versus CDT alone. So there's a lot of attention being paid on this. I will tell you from a reimbursement perspective, that's still tricky. We're working on that. So not all insurance is on board with this, so that can be a limitation, but I think we're gonna get there, and I'm hopeful about that. But what are the outcomes that the evidence has shown? Reducing occurrence of an infection, huge in lymphedema, huge. Decrease the need for those compression garments I showed you. Many of these patients can go from having very high compression garments to much lower, much more manageable compression. Reducing the actual size or volume of the limb. I didn't touch on it, but there's actually procedures that are done to remove some of that fibrotic tissue just to change the size of the limb. So it's much more manageable for garments, and it just looks better for patients. And so there are some procedures out there that work on that as well. Quality of life is huge. Okay, and patients that end up with lymphedema, they struggle with this. They struggle with what they're going to wear. They struggle with heat. They struggle with flying. They struggle with elevation. So it really impacts quality of life. If we can improve that, that is a win as a survivor, a huge win. And then function. They function better. They're more active. They want to be active because they feel better. Okay. So I want you to have takeaways. I'm a therapist first and foremost. So here's sort of my homework or send out for you, that if you do have lymphedema or at your risk for lymphedema, important things to remember. Skin care, moisturize well, treat cuts and breaks in the skin, avoid needle sticks on the affected side, wear gloves, use sunscreen. All of this is about protecting the skin, keeping that skin intact, because that is your first line barrier from progression of lymphedema. Active lifestyle, muscle pumping, manage your weight. We work on this in therapy because it really, really matters, okay? Wearing compression when exercising, except, and this is a love that many patients with lymphedema have, if they can go into a pool, they don't have to wear their compression. If you do weight lift, there is strong evidence that shows you can start slow and go slow, okay? You don't have to avoid it. Avoid limb constriction, nothing too tight, okay? Don't cause a tourniquet in an area that's affected by lymphedema. Wear your compression garments, number one thing. I can do all the manual lymphatic drainage in the world, but if that limb does not stay compressed, it negates all of that. And then avoiding extreme temperatures. Okay, this is very exciting. I have to say, and maybe it's only because I'm a certified lymphedema therapist that this is exciting, but there's an act that was passed, Lymphedema Treatment Act, actually last December. And this is effective as of next January. And basically this was forcing Medicare in particular to cover compression garments. Now you remember me talking about how compression is the number one most important thing. Medicare was not even covering the cost of these items, okay? So it's mind-boggling, but this is changing. And so this will be fundamentally a very positive impact for those that are treating, but more importantly, for those of you that are experiencing lymphedema. And we know this will trickle to commercial payers and others. And so bottom line is there's going to be the ability to just access these things and get them easier than there has been in the past. Okay, I'm going to switch gears here and quickly talk about active survivorship and exercise, because again, I would be remiss to not touch on this. So why should we be active? Why should we exercise? There is so much evidence. I could have an entire lecture telling you all the evidence about exercise. Do it. That's the biggest message, okay? But let me give you some tips and tricks on how to do it and what matters, because it's overwhelming and it's overwhelming for most patients. But I think there's things I can leave you with today to hopefully get you going on the right track if you're not already there. So what do we know about being active? It reduces fatigue, which you probably all know this is the most common side effect of cancer. Very, very important. It improves depression and anxiety. We heard earlier about sleeping. If you want to sleep better, trust me, exercise is really powerful to do that. Improve your ability to get things done in your day-to-day life, improve your strength, your flexibility, helps your body just work better. Exercise is truly medicine. It is. And it also decreases the risk of cancer coming back. I hear this statement said in the field, and I think it's really, really true of oncology rehab, and we say this all the time, but it is powerful. If we could harness the power of exercise into a medication or a pill, I guarantee you all the physicians sitting in this room would be prescribing that. Okay, that's how powerful it is. So this is my mantra to patients: start where you are, use what you have, do what you can. Okay, there are a lot of guidelines out there about you have to do this, you have to do that. I literally tell patients you just need to do something. Help me to help you do something, because whatever you do is a dose of medicine in a positive way for your body. So what should you do? How often? How hard? How much? So this is also a great development in our field as rehabilitation professionals. The American College of Sports Medicine actually came out with some very defined parameters for exercise for cancer survivors. We in the field have been waiting for this for a long time. There was research that needed to happen. There was the studies, the analysis of studies that needed to happen. But we have some very tangible evidence that can be taken away now to say, if I'm experiencing X issue, what is the most bang for my buck for exercise? So I have literally taken the material here and put it into the slides for you. I'm not going to go over it in detail, but I will tell you that this is the prescription you need to do. And if you're not doing this, this is the goal. This is where you want to work toward. And you can see here, they have specifics related to anxiety, quality of life, fatigue, overall physical function, sleep, depression, and bone health. And again, these are all backed up by evidence, okay? This should be a prescription just as much as any other prescription you get when you see your oncologist, okay? Bottom line, you need to avoid inactivity. It is not good to be inactive. But rehab professionals can help you if you're struggling with how to be active because you have side effects. Come see us. Really important to remember too, in the context of lymphedema, I touched on this, but I'm going to hit it again, that if you do a supervised program, meaning working with someone who understands the risk benefit of exercise, you can do progressive weight training and it won't make your lymphedema worse. We used to think that was the case, but we have proven otherwise. All right. There are some great references here. I would just draw your attention to. You want more information about the exercise. It's the Moving Through Cancer site there. And then also there are some great resources on lymphedema listed there as well. So with that, I will take questions. Thank you for your attention.
Great talk, Lexi. Question from the audience, I know we have one on the. Yes.
While you're answering questions, can you back up, I think, 3 screens to the, yes, that, thank you.
Absolutely. I went too fast. I know there's a lot of information there. You'll
Hi
have
there.
these slides. Yes.
This is so great. I'm so excited that you were here today. So thank you so
Oh,
much.
thank you.
14 years NED, but
Wonderful.
lymphedema is what I deal with every day.
Yeah.
So I've been wearing, thank goodness, compression hose every day, pretty much of those last 14 years.
Yay, I
Yay.
celebrate that. Yeah, that's huge.
A couple years ago, at one of these, I asked a doctor who was talking about it, and I asked about lymph node transfer or
Yeah.
whatever. And I don't think it was, he's like, oh, your lymph has already figured out how to go back,
Mm.
I didn't really say that
Mhm.
that was something. So that sounds like what's happening now. So how do you, how do you know when you
Mhm.
get to the surgeries,
Yeah.
how far along do you have to be to get to the place where you think that you can either transfer lymph nodes or do the other thing that you mentioned?
Yeah, the LVA. So I will tell you, I actually was on a call with the head of plastic surgery because the UW recently was designated as a network center of excellence for lymphedema. So one of the things we are charged with that is figuring out exactly what you're talking about, how we as therapists identify and work really closely with the plastic surgeons who are doing this work in order to figure out that timing. And one of the things we were talking about was that referral pathway and what that looks like, because we both have all of us, oncologists included, have a role to play in catching this. And so I think that's evolving and changing for us organizationally, but we don't have a good answer to that. I will tell you, most facilities do it a little bit different. There are some triggers that will indicate that, but I also think what you see happening, and I touched on it a bit, particularly in breast cancer, is these procedures are being done as part of the initial sort of surgery for breast cancer through lympha procedure. And I think we're going to see this evolve and change, and it's going to become an earlier intervention. But I would say if you haven't explored it or ever consulted with the docs and you're interested, it's worth reaching out and seeing if you want to get a consultation.
That's great because
Yeah.
Dr. Bird spent 5.5 hours on me and took out all my lymph nodes.
Yeah, yeah.
I just doubt. Now I have lymphedema. So
Right. I'm not going to promise anything.
I know,
Because
so
if I can
I
stand here
would
and say
love
it'll
to-
fix you, but at least you should consult.
And then the only other question is, what about surgery in the area of where you don't have lymph nodes? Is that more risky, and should that be considered in deciding if you should have surgery or not, like a hip replacement or a knee replacement in the areas that don't have lymph nodes?
Yeah, absolutely. I think
Absolutely, but-
absolutely you have to keep it in mind. It should be a conversation with the surgeon who's going to do that surgery to say, I am at risk for lymphedema. And I will tell you, you sometimes have to be an advocate for yourself, because that orthopedic surgeon might not even, with all due respect to the physicians in the room, even understand the aspects of lymphedema and how that is impacting the potential of that surgery. So I think you do have to ask the questions and be adamant about that and explain why you're concerned. Yeah.
Let's do one last question from the chat.
Yes, there is a question in the chat about, is there any thought or data on acupuncture being a benefit as a treatment for lymphedema?
My acupuncture, we are lucky to have colleagues here at Fred Hutch, and I will tell you, there is no evidence to show that that is effective. They don't routinely treat, we don't routinely treat with acupuncture here because we are very evidence-based focused. But I think, again, acupuncture is being shown to be effective in a number of different areas. Another one I can think of is peripheral neuropathy, where it is being effective. So I think, we still have a lot to learn about lymphedema. I say, as a therapist in this area for a long time, let's try it. Every patient is a little bit different. If we think it's effective, why not? There's no evidence to show that putting acupuncture needles in anyone causes any issues with lymphedema. So I think that's an important distinction. But we just, we don't have enough evidence, and so we don't do it routinely.
Thank you very much.
Yeah.
So I think this is going great. I'm really excited by this. It's my pleasure to introduce a new face to our melanoma symposium, because Dr. Ho is fairly new to Fred Hutch. So Dr. Joel Ho is a medical oncologist in our melanoma group who has recently arrived. He came to us by way of MD Anderson, where he did a special melanoma medical oncology fellowship. He is a lovely person. We are so fortunate that we were able to recruit him here and have him join our team. And he's going to be talking today about a melanoma subtype that doesn't often get a lot of attention, but is one that is very unique and presents unique challenges, mucosal melanoma. Thank you, Dr. Ho.
Thank you so much, Dr. Ho, for the introduction. And thank you all for the opportunity here today to talk about mucosal melanoma, which is this rare melanoma that does not arise from the skin. And specifically, I want to talk about medication that we use and can work for this rare type of melanoma. So start with disclosures. So in essence, what is mucosal melanoma? So melanoma are cancer cells that are derived from uncontrolled growth of melanocytes. And what melanocytes are that these cells that live in the skin and produce melanin and give our skin pigment to protect us from UV damage. But through kind of evolution, for some reason, even in UV shielded areas, such as those mucosal membrane inside your head and neck area, inside your GI tract, or your genital area, there are still some melanocytes over there, and those melanocytes have the potential to become melanoma. And the function for these cells that are there are not really clear, but it's thought to be just a remnant from fetal development. So this is considered a rare cancer, accounting for less than 2% of the melanoma in the United States. And unlike skin melanoma, there really isn't a clear risk factor such as UV damage that is associated with this. It typically affects older patients with a slight higher prevalence in females. So for me to understand how to treat mucosal melanoma, I think I have to first understand how is it different from skin melanoma. So one of the major differences in the total mutation burden. So mutation in melanoma happens as it's exposed to UV radiation, and it produces these neoantigens that is expressed in the tumor cells that helps our immune system distinguish what are cancer cells and what are the normal cells. And traditionally, melanoma is the cancer cells that has the highest tumor mutational burden, as you can see in the graph to the left. And the ones that come second, third, and fourth are mostly lung cancer and bladder cancer, and those are thought to have lots of mutation come from smoking influence. But when you look at the figure to the right, you can see that mucosal melanoma are not really like skin melanoma, that they don't have as much tumor mutational burden. So on average, mucosal melanoma has about 10 times less kind of mutation that we see in skin melanoma. And when they do next generation sequencing, they don't really see signatures that are derived from UV damage as we sort of expected. Mucosal melanoma also comes at different sites that are not in the skin. It rises in the mucosal membrane. The most common site is the head and neck area, more so in the sinus than the oropharyngeal area. Second is in the GI tract, most of them in the anal rectal area. And lastly, they can also occur in the urinary or the genital tract area. And one I think is the most important difference is to understand that the mutational landscape, which are mutation in these cells, are also different than what we are seeing in skin melanoma. One of the really important pathway that we think about in melanoma is what we call the MAP kinase pathway. And these are the ones that is associated with the BRAF or NRAS mutations. And these are really important because there are FDA-approved regimens that have shown that it has worked very well for skin melanoma. Those account for 50% of BRAF mutation. We can see that in skin melanoma, another 25% we see them, which is sort of more upstream mutations in the pathway in skin melanoma. But in mucosal melanoma, we see a completely different landscape. We only see BRAF and NRAS in about 5 to 10% of them. However, we're seeing a lot of other pathways such as KIT or NF1 that influence this pathway through other means. But more importantly, it also shows that 44% of there are mutations that we don't know what they are yet. So to me, that represents an opportunity for oncology researchers to tap into. So in general, mucosal melanoma does behave more aggressively and has worse prognosis compared to skin melanoma. The 5-year survival rate generally historically has been reported to be around 14 to 25%. And partly it's due to a lot of these patients are found at a higher stage. About 23% of them is found to have stage 4 at diagnosis, much lower compared to, that's much higher compared to skin cancer. And because of this disease is fairly rare, we don't really have a good standardized staging system to help us understand the natural history and the prognosis like we do in skin melanoma. So what medication can work for these mucosal melanoma? And of course, I have to start with immunotherapy, really the poster child that really changes the game for melanoma. So before immunotherapy is introduced, melanoma was a terrible, terrible diagnosis. And you can see here to the left in 2008, the median survival for a patient with metastatic melanoma is about 6 months. And very rarely we see patient that lives more than 3 years. And this is in the era that is before immunotherapy. And now we're seeing a significant amount of patients doing really well with 6 to 7 years of follow-up from a stage 4 diagnosis. So naturally, the first question to ask is that if immunotherapy works for skin melanoma, it should also work for mucosal melanoma. So let's look into those data. And when we think about immunotherapy, we start with immunotherapy that already have shown great efficacy in patients with skin melanoma. And these are generally checkpoint inhibitors that targets PD-1 or CTLA-4. And how these work is that these inhibit the mechanism that the cancer cells or the T cells use to either evade the immune system or to temper down the immune system. And by blocking these, it stimulates the immune response to cancer. So one of the downsides of mucosal melanoma is that it's very rare. So naturally, we don't have as robust data as we do in skin melanoma. So what do we do in the first step is that we look at from the melanoma trial that is already done, and we pull those mucosal melanoma patients out to see how they do with immunotherapy. So in 2017, Dr. DeAngelo did a pool study from 5 studies with a total of 889 patients and identified about 86 patients with mucosal melanoma. And to the right that you can see the progression-free survival probability for these patients treated with combination seems to be doing a little bit better at around 6 months and with single agents around 3 months. These had not met statistical significance, but it provides a little bit of a signal that maybe these are cancer that needs the combination immunotherapy. It also tells us that maybe mucosal melanoma are not as sensitive to immunotherapy, because when we think about the median progression-free survival for skin melanoma, it's generally about 7 months to a year, compared to what we're seeing here is about 3 to 6 months. And indeed, when we look at the waterfall plot, which is basically a plot for each of the patient, what is the largest tumor burden changes that they're seeing with treatment? And generally, a patient is considered having an objective response when all the tumor shrinks by about 30%. So to the left, you can see in the mucosal melanoma patients, the response rate to combination immunotherapy is about 37% compared to just single agent treatment, that's 23%. This is slightly lower compared to what we are seeing in skin melanoma, where combination shows is 58% response rate and single agent is about 45%. But it's important to keep in mind that immunotherapy has the potential to provide a durable response. So generally, this is still the drug that we first reach out to. So more recently, Dr. Dimitrio and Dr. Lam published the largest international cohort study for patients with mucosal melanoma. And this is the largest study to date, looking at 545 patients for this really rare type of melanoma with metastatic or unresectable melanoma who had never been treated with immunotherapy before. They did allow for some patient who has some other systemic therapy, such as chemotherapy, and often this is tried a lot more in other parts of the world, such as in Asia. And this is an international study effort combining 25 centers from Australia, Europe, USA to Asia. One thing to keep in mind, important, that this is a retrospective study, meaning it looked back. So naturally, that may have introduced a bit more variables, but still, I think that this is a valuable database to look at just based on the sheer number of patients that was included in this analysis. So among a total of 545 patients, about 350 of them got just PD-1 alone. About 200 of them got combination with ipilimumab and the PD-1 immunotherapy. And they see a response rate of about 30%. But to your surprise, that the response rate to PD-1 alone and to combination immunotherapy are quite similar. Really, there's a difference of 2% between the two of them. And they try to look and say, oh, maybe different site, they respond differently. But the only signal that is seeing that maybe it is in the oropharyngeal area that combination works slightly better, but none of these really make statistical significance. And at a median follow-up of 31 months, and this is the progression-free survival and overall survival data, to the left, you can see these data stratified by the treatment type. And what I appreciated here is that you have to look really, really, really closely between the two lines to separate them two out. So naturally, one of the questions to think about is that if just single agent may work just as well with combination, are there patients that we can select for that we can just get away with just using single agent, as we know that in combination treatment, sometimes they have higher toxicity rate. But sometimes when we think about patients that may have more aggressive disease, combination immunotherapy may offer the advantage of working a little bit faster. So so it still requires very individualized decisions with your oncologist. What I do think is a silver lining here is this green box over here. So in a median follow-up in 31 months, that we're seeing about 15 to 20% of the patient can still have a durable response in this very, very aggressive type of cancer. And these may be accounted for patients who had the complete response that you can see to the right, that's the curve to the green, that they do very well. So I think a cool question to ask next is that, who are these patients? What are their tumors looking like? And what makes their tumor more sensitive to immunotherapy? Now, I think as we all know, there's a new kid that came into the block in 2022 with Opdualag, anti-LAG-free with nivolumab or relatlimab. So there was approved for metastatic melanoma. So let's dive a little bit into and see how this works for mucosal melanoma. So when we look at the landmark trial Relativity 047, they have about 7% of patients with mucosal melanoma. So that's not a lot of patients, about 20 to 30 patients each in each arm. So numerically, they see the response rate seems to be doing a little bit better with mucosal melanoma at 30% with Opdualag compared to 25% with just nivolumab alone. But the data and the number of patients is so small, so it's hard to make any meaningful difference between the two of them. But it did tell me that this is a combination that has efficacy. So overall, immunotherapy still tend to be the first treatment of choice that we reach for, because I personally really hope for the 15 and 20% of patients that have that prolonged and sustained response. The response rate that we're seeing are not a skin melanoma, and generally that is somewhere between 20 to 30% of them. So now moving beyond a little bit about immunotherapy. Remember, at the very beginning of the talk, we looked at that pie chart about the difference in mutation. So let's try targeting these mutations with targeted therapy. So one of the mutations that is found at a higher frequency in mucosal melanoma are KIT mutation. It is found in about 13% of mucosal melanoma. So this is a pathway that indirectly activates that MAP kinase pathway, again, that BRAF and RAS pathway that we see in skin melanoma. And KIT mutation occurs in two flavors. Either they can be an activating mutation, meaning once they get mutated, they're just constantly being activated, working the downstream pathway, making the tumor cells grow. The other flavor is that it can express more of these receptors. So you have a higher chance of getting the downstream pathway being activated to cause tumor growth that way. Specifically, we see that in exon 11 and 13 mutation in the KIT seems to be more sensitive to KIT inhibitors, but for melanoma that has the KIT exon 17 or amplification, the one that just has more receptor, does not seem to do as well with KIT inhibitors. So this is a quick summary of the data that we're seeing with KIT inhibitors in patients. In general, we do see a response rate about 20 to 30%. So I do think that it's quite important to look for these mutations for patients with mucosal melanoma, as sometimes that this is not the typical mutation such as BRAF that we think about. And as you can see here, most of the response rate are largely driven by those patients that has exon 11 and 13 patient. So it's really important to look at not just whether someone has a KIT mutation, it's also to look at what that mutation is to really think about whether this is some therapy that may give the patient some benefits. And in general, if someone has an eligible KIT mutation and they try immunotherapy, this is something that I do consider because KIT inhibitors such as imatinib or nilotinib, in general, they do have fairly tolerable side effects. Now, what are other things that we target? So as we know that cancer grows really fast, and one thing for us, for cancer that they need to grow are blood supply. So can we look at targeting blood supply growth in conjunction with maybe with immunotherapy to see if that works? So when cancer rapidly outgrows the blood supply, it makes the environment around the tumor have lower oxygen, so more hypoxic, and it create a more acidic environment around the tumor as well. So this in turn promotes a more immunosuppressive mechanism. It causes changes in the endothelial cells, in the blood vessel, the receptors that they express, and sometimes it changes the T cells around the tumor, the profiles, what they look like, and the degrees of maturation also changes as well. So there are studies to show that maybe if you give a target therapy that blocks some of these blood vessel growth in conjunction with immunotherapy, this may be a way to try to stimulate the immune response by changing how that microenvironment looks like. And this concept is not new. So in another tumor site that we treat a lot in the skin and renal group, this has been combination therapy has been FDA approved in kidney cancer for many years. So here's some of the summary of this data looking at immunotherapy combining with a medication that targets blood vessel growth. And most of these data come from China because China has a huge interest in looking mucosal melanoma because proportionally, they have a much lesser incidence of having skin melanoma, and they have a much higher proportion of patients with mucosal melanoma. And some of the early study that we're seeing there, that they are reporting a pretty impressive response rate, upwards of 40 to 50%. But a few things to keep in mind is that most of these patients never had immunotherapy before. So it's really hard to understand what is carrying the weight. Is it just the immunotherapy alone, or is it really adding this medication that block blood vessel that goes with it? And we look at the median overall survival, numerically, it does still seem pretty comparable of using just immunotherapy alone, but there's a lot of limitation when you start comparing to different trials across. But in last year, in 2022, the LEAP-004 study has been published, and that's the first one over there showing pembrolizumab and lenvatinib for these patients who progresses after PD-1 immunotherapy. And these included mucosal melanoma, but does have a lot of patients who are not mucosal melanoma as well. But they're still seeing a response rate about 20%. So there are some signs of efficacy. And arguably, this is probably the drug combination that is most easily accessible here in the United States. So for selected patient and for the right patient, if after progression with immunotherapy, sometimes this is a therapy that's worth having a discussion with the oncologist about. So some take-home messages here is that, so for resectable disease in general surgery right now still remain the mainstay of treatment. There is some systemic therapy option, and immunotherapy can still work for this patient, and we're still seeing durable response for a subset of these patients. Looking at different mutation and targeting blood vessels may have a role in mucosal melanoma. But what I think is so exciting is that I think there's so much more to learn about how these mucosal melanoma comes to be, what their genetic mix-up are, and what their clinical behavior looks like compared to skin melanoma. And I share a lot of the enthusiasm with other colleagues of how TIL treatment is going to change this. Can we target other mutation that we can find here? And even moving the space a little bit forward to see, can we use some of these treatments to improve outcomes for patients with resectable disease? Thank you all very much for your time.
Questions for Dr. Ho? There is a question in the chat, and I'm glad they're asking you because I don't want to answer it. Maybe this is maybe a broader melanoma medical oncology question, not necessarily specific to mucosal. But the general question in the chat is from someone who's been on immunotherapy for a long time and the cancer seems well controlled. How do you think about the decision of when to stop?
Ooh. So a lot of times this is a great question in general. We think about after 2 years of a patient, especially with those patients that had a complete response or no signs of active disease, this is the time that we can talk about maybe stopping immunotherapy, knowing that the risk of recurrence is low, but not impossible. I think one of the really interesting study that we're doing here in our group by Dr. Tachiki is looking, because we know that these PD-1 receptor can bind to the T cells for a longer period of time. After 2 years, can we lengthen out the treatment duration? So instead of coming every 3 to 4 weeks for immunotherapy, can we do every 9 months? So I'm very excited to see the work that she's published to see whether that can guide us to de-escalate treatment for those patients who had great response.
And I'll just, I share Dr. Ho's feeling. It's a really common, it's thankfully becoming an increasingly common discussion we have in clinic, which usually happens in the setting of the cancer responding well to treatment. So it's a good question, but one that we don't have a ton of data on. But I think there are tools coming. Some of the work out of Sloan Kettering, Dr. Aryan's institution is looking at PET scans. And if people have a negative PET scan, that seems to predict potentially a safe time to stop. And then looking at DNA, evidence of tumor DNA in the bloodstream as a new way beyond imaging to try to track melanoma activity. So I think in the next couple of years, we'll probably have a better answer for that question, but it's a really important one.
What might cause mucosal melanoma?
I think people try to look for that, but unfortunately, there hasn't been a clear risk factor that has been associated. At least in the head and neck area, there is a condition called oral melanosis, where they see some of these melanocytes being deposited in a specific area that may be a risk factor, but it's not still a very strong risk factor. It's not the sun.
All right. Well, thank you very much. So it's lunchtime. So I think lunch is out across the hall, and we'll resume the program at 1:30. Thanks.
Here with you today. That's right, I knew it. Okay, well, thanks for coming back after lunch. Looks like the number is pretty close to the group that left for lunch, which is a good sign, because we do have a great afternoon coming up here. And any questions you have from the morning, just in general? Format worked okay? Think that, and we can't really ask the people on Zoom, but we will through the chat. So we'd like to, this is our continuation of the survivorship part of our Science to Survivorship. And the only question I had is, should we have had Dr. Bates right before or right after our earlier talk on sleep? Yeah, because yeah, she said she was causing us stress as talking about how much we need sleep and the anxiety that came even through lists. She even told us she was going to make us more anxious. So your talk right after hers might have been perfect. We didn't quite know it was going to go that way. Anyway, it's my pleasure to introduce Dr. Nicole Bates. She's an attending psychiatrist at the Fred Hutch and your clinical assistant professor at UW Department of Psychiatry and Behavioral Science, and navigating anxiety in the melanoma patient topic. Thank you very much.
Thank you, Dr. Bird. And thank you everyone for coming back after what was probably a beautiful lunch in the sunshine to then talk about anxiety. And I will do my best to hold whatever distress remains from the sleep we are or should be getting. I want to take a brief moment to acknowledge where we are and where this land has come from historically. And then to make some acknowledgements of my own. So first, I want to acknowledge that even though I'm a psychiatrist that works with patients with cancer day in, day out, that's not the same as your lived experience. And so while I may know the research, the interventions, I may walk alongside you, I don't know exactly what it's like to walk in your shoes. And I want to acknowledge and respect that. Also, rest assured, I'm not diagnosing anyone with anything today. So you're in the room with a psychiatrist, but I'm here for education, again, not to pathologize. And as such, interventions that we talk about are for education, not for diagnosis or treatment. So I would want you to go to the people who can help, your care teams, if you need that treatment. And on a serious note, I want to acknowledge some people struggle with severe mental health issues, including thoughts of suicide. So if you or a loved one is in crisis, I'd want you to know the National Suicide and Crisis Lifeline, which is 988, similar to 911. So brief roadmap, we'll talk about what I mean by fear of cancer recurrence, how anxiety impacts daily life and experience with medical care, and then more practically, what you and your care teams can do about it. And finally, I hope to save time for questions and will do my best to field whatever comes my way. There will be some light participation, and I'll just say as much as you're comfortable with. So if you are comfortable, I'd like anyone who can answer yes to this question to just put up a hand. I have experienced fear, worry, or concern related to the possibility that cancer will come back or progress. Yeah, right. So thank you for those brave enough to raise hands, and even if not, for considering that. This is the definition of fear of cancer recurrence, and I'll broaden it to say fear of cancer progression as well. And as you saw in the room here, you're not alone if you raised your hand. So there are over 18.1 million cancer survivors in the US, and many struggle with fears of cancer recurrence or progression. So anyone with a history of melanoma, 50% of those people will have fear of cancer recurrence. For someone with a new diagnosis or a recurrent diagnosis, that rises to 66%. And then for people with metastatic melanoma, it jumps to 86%. So again, this is common. You're really not alone in this. Now, I'm going to talk about anxiety, hopefully to reel back a little bit and depathologize. Not all anxiety is bad. So anxiety can serve a really protective function for us. And I think evolutionarily, historically, we want our bodies to be able to recognize real threats, respond to them to keep us safe. So these questions here are from a type of psychotherapy called cognitive behavior therapy that's highly effective for things like anxiety and depression. So we can ask some questions when we have fears or worries. So first, is my fear true? And sometimes that answer is yes. So realistically, you know, I know that a melanoma diagnosis does increase the risk of recurrence or a new melanoma. That's real. And so thinking about that, some anxiety is realistic and expected. We can also ask, if I have a fear or worry, is it useful? And sometimes that answer is yes too. So understanding a realistic risk can help motivate people to act where they do have agency. And so much of the time, anxiety is rooted in this loss of control, a fear that we can't act, that we're trapped. So being able to reframe to where we do have agency can be really empowering. And if we think about the practicalities, that fear of recurrence can motivate people to attend regular surveillance, follow-up, to present in a timely manner, which can reduce the risk of disease going unchecked. So sometimes anxiety can really be useful. But there's a tipping point, right? And this is kind of hard to distinguish, but how do you know when anxiety is too much? There are some common examples here. And again, if you recognize these in yourself or others, I don't want to stress you out more, just to acknowledge that this happens. So frequent, chronic, intrusive thoughts. So thoughts that come into our mind unbidden about a possible recurrence or progression can be excessive or clinical anxiety. A disproportionate fear, so one that's out of proportion to the actual risk someone has of recurrence of progression. Excessive need for reassurance, so frequent phone calls, checking in, asking the same questions again and again. And sometimes it's our family members or our care teams who may see and recognize that behavior. And then, of course, anxiety becomes problematic when it causes a functional impairment in life. And that can be not just as a patient, but as a human in all the other roles that you play. It's not surprising that fear of cancer recurrence has, again, real and wide-ranging impacts. And I'll start down in the purple section. So at the core, I'm thinking about well-being. People with high fear of cancer recurrence or progression are at higher risk for worse depression and anxiety. Unfortunately, if not treated or supported, fear of cancer recurrence doesn't just tend to go away, so it can persist. And then broadly, that can lower quality of life in multiple domains. Unsurprisingly, that can result in some maladaptive or unhealthy health behaviors. In melanoma, that could be things like reduced sun safety, avoiding medical care, even delaying things like surveillance or scans. And then that impacts people's experience with their health care. People with high fear of cancer recurrence use more health care. So more phone calls, appointments, tests, procedures, while at the same time having lower care satisfaction. So I hope I'm setting up a case that we would want to do something about this type of fear and anxiety. And the good news is we do know some things. There is some research, there are things that help. Also reassuringly, remember how many people have fear of cancer recurrence, right? Most people with melanoma. And most of those will have minimal or mild fear of cancer recurrence, in which case standard medical care, education, and empowering self-guided tools really are the best interventions. But for moderate or severe anxiety or fear of cancer recurrence or progression, we'd want people to get to treatment. So things like individual and group psychotherapies, sometimes medications. So those are the patients I'm working with in clinic. There's lots of acronyms up there. So in psychotherapy, it's just this alphabet soup of acronyms. CBT is that cognitive behavior therapy I talked about. So those questions we reviewed. SCT is supportive and existential therapies, helping you hold emotions and acknowledging the existential impacts of cancer. So to speak frankly, life, death, and major changes in your sense of self. Conquer Fear and Fear Less are specific manualized interventions that are still being researched, but they're for fears of cancer recurrence. And Fear Less is in early trials, but that was built for patients with melanoma. So there's some encouraging research, there are things that work. And then of course, there's the reality that we're not where we need to be. So first, we need to improve our screening to identify patients that may or may not need more support and to triage them to care. Every single research study you'll read tends to end with some statement to the effect that more research is needed. So more studies, bigger studies, more specific populations. So we know not just what works and doesn't work, but for which particular circumstances, what would work best for you. And then we can have the best research in the world, but if we don't have the mental health professionals available to deliver it, it's not going to do you much good. And that's a space where I really acknowledge an unmet need. If anyone's tried to access mental health care, you probably know it can take months and months to get in to see someone. And unfortunately, that's true even here at Fred Hutch. If I were you, this is the question I'd be asking, right? So all this research, all of this knowledge, how does it actually help me now? I'm going to talk about what medical teams and healthcare systems can do to support anxiety. I'm also going to talk about what you as individuals can do, but we'll start with the former. So there are some things we can do structurally. One example is tailoring clinical follow-up frequency to a patient's level of risk of disease coming back or progressing. And one thing studies have shown is that for people who have a lower risk of recurrence, actually less frequent meetings can reduce their sense of worry. We can empower patients and their caregivers. And that looks like increased education. So for your cancer, for the location, the stage, the treatment you had, what's the right level of surveillance? What things could be normal? What things would be red flags and reasons to reach out? And then I talked about increased psychological support. So as per the last slide, we want to screen patients, identify those that need more support, and ideally have that support readily available. And we're not there yet. I'm going to get back to that idea of control and empowerment, lack of agency, and self-efficacy, because that can make a big difference in how anxiety impacts you. So there are things you can do. And I'm going to mention there are lots of things you're already doing to help reduce anxiety and fear of recurrence. We'll have a participatory moment in just a second, but I'll talk through these briefly. And again, this is my psychiatry bias. I think it's essential to acknowledge emotions. If anxiety is there, it's there. Denying it, suppressing it, pretending it's not there, expecting it to go away isn't going to make it disappear, but it's not going to give it the outlets it needs for you to deal with it. So I think it can also take the teeth out of anxiety just to call it what it is, to say I'm worried, to say I'm anxious. So that's a first step. You and your teams can also create a survivorship plan. And so ASCO cancer.net has great patient resources. This is a way to summarize the specifics of your cancer, what treatment you've had, and then for you, what does survivorship or surveillance or monitoring need to look like? you can stay informed. So I think encouragingly, research is advancing all the time. What exists for your melanoma today could be vastly different from 6 months or a year or 5 years from now. And so staying up to date can help empower you to know where things stand. This sounds obvious, but engaging with supports is key. So isolation can become an echo chamber for anxiety. So reaching out to the people who already know and love you, your family, your friends, work community, religious or cultural communities, as well as cancer support communities, can really help normalize what you're experiencing and bolster your supports for that. I talked about controlling what you can. So again, I wish we could all snap our fingers and sleep beautifully. You can't, but things like sleep, nutrition, physical activity, healthy coping, which is the next thing, really can make a difference. And not just your quality of life, but your trajectory as well. So managing stress in healthy ways. Easier said than done. I wouldn't have a job if it were easy. But I want to acknowledge all of us. When we're under stress, we regress. So we go to less mature, less adaptive coping mechanisms. In a time when you're feeling calmer, it can be really helpful to think about what helps me when life gets hard. How do I cope well with stress? And then how can I marshal that when things are harder? So here's the participatory part. If you would, and those are mine, if they need attention, I will step away. But I'll ask you, look at this list, think a minute. What's one thing you're already doing in one of these domains? And if you feel comfortable, share it with a person next to you because you may learn something. I'll give you a moment for that. Hearing some chatter, like acknowledging emotions. Good, good, good. Yeah. All right. Thank you for talking and sharing. The next piece is, again, I want you to look at this list and think, what's one thing now that you can add to your quiver of arrows for how you deal with anxiety? What could you add that you're not currently doing? And if you feel comfortable, share that with somebody nearby. Absolutely. Yeah. 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 We had a really great point up in the front that I'm gonna broadcast, which is we all cope with stress differently. And of course we do. So for me, what a healthy way of managing stress is could look very different from what you do or what you do or what my little people back there do. And there's not a right or a wrong way to manage stress. I think it's helpful to check in with yourself to assess what your strengths are and sometimes to assess, what could you do better? What do you need more support for? So thank you for taking a moment there. And that's what I'm going to add. These are all self-management skills, but if you need more help, I hope that you'll ask for it. And these are reasons that people really should seek support for anxiety so they can get the treatment they need. It's a lot, so I'm going to cruise through it briefly, but this is when anxiety really crosses that line into functionally impairing clinical, pathological anxiety. So this is fear or worry you just can't control. It may interfere with your ability to concentrate, the roles that you play in your life, even your relationships. If you notice that you're turning to unhealthy coping, so relying more on substances, or just engaging in more risky behaviors, those are warning signs. When your fear leads to avoidance, right? Skipping appointments, canceling scans, delaying labs. If anxiety stops you from being able to eat or to sleep healthily, if you have a big change, those are reasons to reach out. If you feel hopeless about the future, and I'll jump to the bottom, or if it gets so bad that you have thoughts of ending your life or suicide, I would certainly want you to reach out. Other things are if worry stops you from being able to enjoy things you used to, right? You're not doing activities that used to bring you joy because you feel paralyzed with fear or you can't make decisions due to your worry. Those are all reasons to seek treatment. And this is where you can go. So I present all of this, again, recognizing that there aren't enough of us in mental health to give all the care that all of you deserve. But I would still want you to reach out to your cancer teams. So your physicians, your advanced practice providers, nurses, team coordinators, patient navigators. For people in active treatment at Fred Hutch, you also have access to social work for psychotherapy, psychology, me and psychiatry, spiritual care. Beyond the cancer center, your dermatologist, your primary care provider, your insurer, maybe even your employer can have excellent resources and get you connected. In the community, there are lots of cancer support organizations. So 2 here in Seattle, Cancer Lifeline, Cancer Pathways, which used to be Gilda's Club. You may feel more comfortable with the cultural or faith-based support, and that can be immensely powerful too. And then again, I talk about severe mental health issues because I would want people to reach out if they're in a crisis. So I'm going to share the team that I'm a part of here at Fred Hutch. It was about half this size when I joined 4 years ago. We're still growing. We are still understaffed, and I know that. But these are people who, just like me, spend their career walking alongside people who are facing cancer, trying to improve mental health and your experience as a human. You have all been so patient, and I appreciate the time here. I want to give the rest of the presentation to questions that you have here in the room or in our online forum.
Great talk. So I'll start this out. We have the chat coming through here. This is a comment from one of our participants. If you don't have a support system, create one. Friends, family, others who have had the melanoma experiences. Just, it's like a Nike thing, just do it, is what he's saying here.
Yeah. Well,
That includes caregivers.
Exactly. Caregivers
Absolutely.
often left out. Question, that's a great talk.
Can you use the microphone?
I will. This is kind of for you, Dr. Bird. In talking to some other people, the My Chart is wonderful and getting test results immediately is wonderful. But the follow-up sometimes takes quite a long time. And those of us that have been part of this melanoma community for a long time, and I was a caregiver. Well, love of my life. But you know, you might look at that and really be fearful when you might not need to be. So is there any, I know that you can't really answer it, but just putting it out there. I know that my husband and I probably weren't the only people that would read before we talk to the oncologist. And that there can be fear there because we're not medically trained.
Yeah, that you probably noted, that's a much bigger question than you may have intended to ask. What I'll do is, because I don't want to take time away from here. There's an EPIC question, or EPIC healthcare, the communication piece, the 21st Century Cares Act that allows all of us to get our results as soon as they're out, which often puts patients ahead of providers. On the surgery side, pathology, you see it before I see it. There's a number of other issues, and it's all about communication and making sure that you have the information you need in a timely way and have it be interpreted by your team in a timely way. So we can talk about more of that offline, but it's a great question, but way bigger question than you may have intended with that. You want to comment?
And actually, that's a very relevant question to what we're talking about. And so navigating My Chart EPIC results with patients comes up so frequently. And I'm going to go back to another thing you raised, which is each of us copes differently. So I see a wide range of patients with anxiety. Some of them want those results immediately, even if they don't have the interpretation. Some of them realize that without anchoring it in a doctor's visit or having context to explain, those results just unanchored drive their anxiety even higher. And so that's something that I would encourage you to think about for yourself, to talk about with your care teams. I have some patients who have actually found and you can do this, you can elect not to have your results released automatically, but that has to come from you. So there are ways to modify that. I think communication is key.
Mhm.
Yeah.
Great question. Other questions?
I just wanted to give a quick positive Yelp review to your department. I've worked with your associate Julia. She's great, and you guys have been terrifically responsive.
Oh, that means a lot. May I pass positive feedback along? Okay, thank you.
I thought I overheard this behind me, but it comes up all the time. Our patients have a unique situation in that sunshine, which often for people has been something they've enjoyed doing in their life. They have a different relationship to it after a melanoma diagnosis. Any tips you'd have about kind of how to handle that as a patient, wanting to do things that you said bring you joy and peace, but also navigating that, sun isn't, maybe a different relationship than it used to be.
Absolutely. And I'd love to speak to that. And I know it's only going to scratch the surface. So the slide I'm going to go back to is, again, things you can do. So I'm going to start with acknowledge emotions. How have you felt when you got that news that now the sunshine is something that actually poses you a risk? Just toss it out. What emotions come up? Uh-huh. So lots of them. And I think that's a first place to start. A lot of the psychotherapy work that we do with people includes validating that what you're feeling is normal because you are facing very abnormal and challenging circumstances. So I would say acknowledge the emotions, and then I'm going to jump to stay informed. So ask your teams. And I'd say this comes up with all types of cancer. I'm thinking about transplant too, where people have this immensely transformed way of living, and it can help them to ask their team, so what can I do? What SPF should I wear? What kind of sun protection should I be wearing? Where should I go? Where should I not go? So that your behaviors can be anchored in, again, expert guidance. And then the engage with supports comes up, right? In some ways that can be really isolating. If you're the one person in your social community that can't do those things unfettered, having cancer support groups can help with that. Just being honest with the people you're with can also help make you feel less isolated. And then there's also that control what you can, right? So if you want to go out in a beautiful sunshiny day, what things can you do to make that more possible for you? Great question.
I've got a quick one for you about the periodic anxiety. There's baseline anxiety that all of us have a little bit. Some of us have it driving on I-5, and some of us have it when they think about cancer. But you wake up after a series of bad dreams at night, and your whole day starts off more anxious, or in conversation, you have a peak and valley anxiety that can happen. I hear that a fair amount. Do you have a way of leveling it or recognizing when it changes and either preventing or coping with it?
Yeah, really good question. And so in terms of treating anxiety, if you kind of imagine that ramp up from where you sit normally, let's say way up here to a panic attack, the earlier you intervene, the more effective those interventions are and the less intense they need to be. So we really prefer to help people analyze what things trigger their anxiety, what things make them vulnerable. So a bad night of sleep or nightmares, or I don't know, maybe a scan coming up in a week. So acknowledging what drives your anxiety, calling it out, and then using strategies that can help calm your body down. I do, and our psychologists do, a lot of mindfulness meditation, and people roll their eyes at me, and that's okay. There's actually a great literature base that's something that can help calm your mind, calm your body, help you navigate cancer. Some people will do breath work. I have people who will do grounding exercises, which is a way of helping your body connect with what's around you. So all of those things can help recenter your nervous system truly, and then let you step forward. Our big, beautiful frontal lobes that do our executive function and problem solving, they don't engage well when we're in a fear response state. So having small things that can bring you back to a calmer, full brain engaged state will help you navigate that anxiety better.
Great answer. Thank you so much. I think we have to thank your two kids, your 7-year-old and 3-year-old. we should applaud for their mommy, but they shared, and to them, a great behavior. Thanks, kids.
Thanks, everybody.
Yeah. Great talk. Yes, we definitely had to have that talk on the same day as a sleep one, I can tell. A little switching gears again, some science back in. I want to thank Dr. Emily Marciano, who is subbing for Dr. Brittany Barber, who you may have seen was in the original agenda. They're actually our colleagues and partners. And unlike the syllabus shows, she's not in my department of surgery, although we'd love to have her in our department. She's in the Department of Otolaryngology. She's an acting assistant instructor, recently joined the faculty. And the title is not going to be a repeat of what you heard this morning from Dr. Arian, because she's an otolaryngologist and head and neck surgeon. So she'll be focused on surgery and perspective and approaches to head and neck melanomas. Thank you, Dr. Marciano.
Thank you for having me. Pleasure to be here. I labeled my talk in this way because so much about how we think about surgery in melanoma has changed and has really narrowed. When I was coming up in my training, we actually did a lot more surgery for melanoma than we do now. And those of us in the field are adapting and changing. And a lot of what we're trying to do is not to do too much surgery. We want to do the right amount of surgery for a patient because we only want to do surgery that we know is going to help you. Is it a click? Sorry, it's not advancing arrow. Okay, there we go. So I thought I would talk about a few things. One, a little bit about the preoperative evaluation, just in how it relates to head and neck melanoma specifically, because there are some unique aspects to head and neck cancer and head and neck melanoma that are different. Sentinel lymph node biopsy. Why? Because this is such an important thing that as a surgeon, we do for many patients. And when patients come to meet me, often this is one of the core questions that they have. Because before they have their surgery, they're lacking a lot of information, right? And the surgery often provides a lot of information, both prognostic and otherwise, that allow you to make decisions with your oncologist and helps you to better understand your disease. So before you've had your procedure with me, there's often still a lot of questions in the air. And that can be speaking about anxiety, a very anxiety-provoking period of time in treatment because there's a lot of questions, right? And things are open. And then a little bit about reconstruction, because in the head and neck, you can imagine that, there's not a lot of, it's high-priced real estate. There's not a lot of space. And the surgeries that we do to people have significant impacts on their quality of life. It makes their cancer very visible to the world. And so we do our best to try and reconstruct them both in form and function. So when you come to see me, we do a comprehensive exam, but, really a dermal exam, so that I can understand your primary. And I'll show you a picture in a second about a patient of mine recently, which sometimes is easy and sometimes isn't, because sometimes we don't know exactly where it is, or the biopsy made it gone, or you have lots of different spots and we're trying to figure out where this starts and stops. And then a lymph node exam. This is really important. Most of what I'm talking about today are patients who come to me who don't have lumps and bumps already, but we're trying to detect any that might be there. And in the head and neck, there's a lot of different places that lymph nodes can drain to, and it's not predictable. So we, as the surgeon, have to really have our eyes out for that, trying to figure out whether a patient might have disease before we can detect it. The other is that in the head and neck, we have something called the parotid gland, which is a salivary gland in our cheek. And the reason why this is so important is that many cutaneous malignancies will drain there, and the parotid gland houses our facial nerve. And the facial nerve is what allows our face to move. If you've ever met a patient who's had a stroke, for instance, or somebody who had Bell's palsy, you understand that that's a really significant impact on somebody's quality of life. And so we have to be very attuned to both identifying disease in the parotid gland and ensuring that we're doing the right amount of surgery in the parotid gland. Again, because we know that those cranial nerve injuries or facial nerve injuries really impact your quality of life moving forward.
I brought up before because sometimes it's not so clear. This was a patient of mine who walked into my office who had this spot for 15 years. Seen lots of dermatologists. Wasn't a problem. Finally had a biopsy. Was a melanoma, actually a thick melanoma. And so when I met him, a lot of our discussion is, well, are we going to take this whole thing out? Like, is the whole thing melanoma? Well, I'm not sure. You know, so we did mapping biopsies and that helped, right, to make a decision because you can see the difference between just taking that little scab out and taking the whole thing out was significant for this patient. And so understanding that and recognizing that it's not always so clear, right? So who's identifying these things for you? This patient knew that they had this for a long time. They just didn't know it was a problem. Actually, a patient, this is like their third malignancy. So not a patient who isn't interfacing with the healthcare community, right? This is somebody who's seeing lots of docs for lots of reasons. Sometimes it's your hairdresser, right? Who identifies a spot in your scalp. And for a lot of my patients, sometimes it's things like the ear. We forget about the ear, right? Hats don't cover the ear sometimes. Who puts sunscreen on their ears? Other than people who have, you know, experience, other than the people in this room. Yeah. And myself, my little one who's like, you know, white, very, very, so, you know, it's like, these are the things that we have to take into consideration, right? And, you know, this patient probably walked in the grocery store for a long time. Did, you know, and would we have said anything to him? Sometimes these flat lesions are not always dangerous, right? But sometimes they are, and it can actually be really difficult to tell the difference between a reassuring lesion and a concerning lesion, right? Unless it's something that you do every day, right? Like our wonderful dermatology colleagues. So when you come to meet a surgeon, there's two things that we're trying to consider. Management of the primary lesion and management of the nodal basin as we talk about it, or the lymph nodes. And again, I'm talking about mostly patients who come to my clinic with a melanoma where they don't have lumps or bumps already. We don't have clinically evident disease in the lymph nodes, but in people we're trying to find out whether they might have what we call occult disease, right? Or microscopic disease that has already spread to the lymph nodes. So when we talk about the primary, we talk about how much are we going to take? How much are we going to go around this lesion? You know, you might come into the office with something that looks like, you know, like pretty small, like a dime. And now somebody's talking about, you know, making a really big hole. When we talk about things like basal cell carcinomas, that's the first white line. So that's like 5 millimeters. That's not so bad. But there are some studies and some thicknesses of melanoma where we start talking about taking 2 centimeters around the lesion. Now, when you talk about doing that on your nose or your ear, you might be talking about taking your whole ear off or half of your ear off, right? That's not insignificant. And so while we don't have perfect data to support this, the vast majority of surgeons will take a 1 centimeter margin in the head and neck because the data hasn't supported that taking 2 centimeters patients necessarily do better. They may in some situations, but again, it's very, very morbid to use a 2 centimeter margin in that area. And so for that reason, you may have met a surgeon if you had a head and neck melanoma that steered with more of a 1 centimeter margin. It's still significant though, right? When you're thinking about it around an entire lesion. I don't want to get into the weeds of this, but just to mention these 2 studies, because this is how my practice is bore out of, right? These 2 studies, MSLT 1 and 2, which were published, you know, in the last 10 or 15 years. And they're why we do sentinel lymph node biopsies. They showed us the data that prove that sentinel lymph node biopsies provides important prognostic information for patients, even more than the thickness of your melanoma. The status of your sentinel node is really quite important, and it helped people to identify who might benefit from additional therapies. And then they followed up this study. So this is what I was saying before. When I was coming up in my training, if you had a positive sentinel lymph node biopsy, you got a neck dissection afterwards, which means that you had another operation and you had all the lymph nodes removed from that area. And that was standard of care. We did that for a long time. Now we're not doing that so much anymore. And that's partially because of this study, because we found that while doing that surgery might prevent a lump or bump coming back in that area, it doesn't necessarily improve your melanoma specific survival. And that's really important. So understanding, you know, how much surgery we do and what types of things it's going to impact. Now, in fairness, for head and neck, we sometimes are nuanced about this because not as many head and neck melanoma patients were included in these studies. And for the reasons that I mentioned before, that when a lump or bump does come back in the head and neck, it can be in the parotid gland or in areas that can cause significant nerve damage. And so we do have a balanced approach, but generally these studies are what have kind of given us our foundation for sentinel lymph node biopsy. So when a patient comes in on the morning of surgery, this is what we get on the back end. Most patients don't actually see this, but you get injected in the pre-op area with a radio tracer, and it goes into your primary lesion. And then the nuclear medicine docs give us this great picture, which looks like a PET scan. And it makes the lymph node light up for us. In the head and neck, it's quite complex anatomy. So we really appreciate our radiology colleagues and our nuclear medicine colleagues providing us really high quality imaging. I always like to remind my patients that this is not a PET scan, even though it looks like one. And just because the lymph node lights up doesn't mean it has cancer in it, right? The idea of this procedure is to identify where a cancer would have traveled if it had gone there. What would have been the first lymph node it would have gone to? And that's why melanoma is so complex, because we can't predict. There are other cancers that I treat that are very predictable. I know exactly where the lymph node is going to be. I can tell you exactly where it's going to go in 99.9% of patients. But in skin cancers and in melanoma, that's not true because we have so much geography and it's so complex that we can't predict that location. So this technology was groundbreaking for us to be able to do that. Many surgeons will also, if anybody saw a little blue dye around their site, it's because we often will inject something called methylene blue, or really just a blue dye. It's not more complex than that, but it's quite interesting because it will travel through the lymphatics and it will make the lymph node blue. It doesn't always work, but it's nice to have both, especially in the head and neck, where it can be hard to find these lymph nodes. These are normal lymph nodes typically, so they're not very big. So it's challenging to locate them. And we know that there are patients who have a false negative rate, meaning that they're told that their sentinel lymph node is negative and they still go on to have recurrences or relapses in that region. And part of it is that we know that occasionally it's low single-digit %, but still it happens that we either don't identify the right lymph node or we can't identify the lymph node on that day of surgery. So like I said, sentinel lymph node biopsy in the head and neck, like more lymph nodes tend to be identified. So there's a higher number of sentinel nodes. So that means for a patient, they may have several incisions or several different places that a surgeon has to dissect. The primary site and the lymph nodes are closer together geographically, so it can make it challenging for us to identify them. And then again, going back to this concept of parotidectomy, this is what a lot of surgeons spend time thinking about. I do parotidectomy once or twice a week for lots of reasons, but it's not a surgery we undertake without serious counseling of a patient or consideration, because again, the facial nerve has such a significant impact on a patient's quality of life. So I'm going to spend a couple of minutes talking about reconstruction in the head and neck, kind of in broad views. Most of these images are not terribly graphic, but some of them are in the operating room. So if this might be a moment to look away from the screen, if that's bothersome to any of you. But when we think about reconstruction in general, we think about sort of the most simple to the most complex. So allowing a wound, you might have gotten a biopsy, right? And they just leave it be and it kind of heals over on its own. That's the simplest thing you can do. Closing a lesion back up right in a line, taking a skin graft from somewhere else in your body. That's a very common way that we reconstruct cancers. But sometimes we can't rely on some of those simpler techniques, and we need to do things that require us to rotate tissues around or to use tissue from nearby in the body. And then the most complex thing we do is something called free tissue transfer, which is really like a transplant. We actually go to another part of your body, your arm, your leg, your back, and we take tissue from you and we hook it up to a blood vessel in your neck. I will say this is not commonly done for melanoma because we have so many other wonderful adjuncts that we can utilize, but occasionally we are using it in the recurrent setting, and I have done that for patients before. So this is a patient who had a T2B tumor on their cheek, and this is an example of talking about the margin status, right? You can see that continuing to go out into the margin. Now you're talking about resecting somebody's lip into their mouth, right? And how that, and we will do that procedure, but we want to be sure that we're doing it for the right reasons and that it's going to impact this person. Now, thankfully, the location of this is such that we're able to pretty much hide it into somebody's pre-existing skin crease. And so this is an early post-op picture. It's a little bit red still, but you can see that generally the form and function is pretty preserved, and this patient has a really nice outcome. And so sometimes we're able to do that with essentially a primary closure. So they don't have to have a lot of other incisions or things in their face. This is a scalp lesion. This is an after picture. Scalp is a really common place to have melanoma in the head and neck for obvious reasons. It's just a high sun exposure area of our body. But thankfully, actually skin grafts work amazing in the scalp, and patients can get a really nice outcome from a really big lesion. So you can see that this actually blends in pretty nicely after a bit of healing, but nonetheless, the morbidity for this patient from both the procedure and the donor site are relatively low. And that's what we like to think about when we're talking about reconstruction, especially if we know that someone might need more procedures. This patient had an early stage tumor, but we want to get them healed as quickly as possible. Sometimes we have to use tissue from other parts of the body or rotate tissue in. This is important to know from patient perspective, because as a surgeon, often you don't want to do procedures like this on the day of your cancer resection. And that's because, as you all know, we unfortunately don't have the ability to do frozen sections in melanoma or to understand our margin status on the day of surgery. It's not something we know until our pathologists are able to do full pathology, which takes about a week, right? So many surgeons, myself included, don't want to do a lot of really fancy reconstruction that day, because if we do have a positive margin or a close margin, now you're talking about having to undo a very complex thing. And so for some patients, that means multiple surgeries, stage surgeries. And not everyone wants to pursue that, and that's okay. There's always other options. It just depends on what goal or what outcome is most important to you. And for some people, the best aesthetic outcome is most important. And for some people, simplicity is the best outcome. So again, having that discussion with your surgeon and making those decisions. So this is a patient with a large, this might have actually been a Merkel cell, but another advanced cutaneous malignancy of the cheek. And you can see that it's going to be a pretty big area right in the cheek. And where we've drawn it out, it means that this patient has to actually have quite a bit of other incisions, longer incisions, in order to have this ultimate outcome, which is really nice. But it ends up being a bigger surgery than you might have anticipated when you walk in with this relatively small thing, right? Now, all of a sudden, someone's talking to you about what turns into like an incision down your neck and all the way across your face. In the end, I think this is a really nice outcome for the patient. But that probably wasn't what they were expecting when they walked in the door. The last one is briefly to talk about free tissue transfer, because we do occasionally do this, and it requires us to completely disconnect a piece of tissue from somewhere else in your body. Often we're using it from the back to reconstruct the scalp, which is what I'm going to show here, a procedure that I did yesterday for a patient. This is an intraoperative photo, so you can see how big this area is. It's a really, really big area for this patient, right? Yeah. Most of their scalp, and this is what they look like a couple months later, healed really nicely for them. So we, again, in melanoma, we're not doing surgeries this big as much anymore because of all the other options that we have, but occasionally there are settings where this still does occur. And so we have those available to patients if needed.
Crisp, clear, appropriately graphic, I would say. Lots of questions. Right here.
Okay, so I had the exact dissection you are describing. I haven't really missed that side of my neck or all those many lymph nodes I don't have anymore, but and I did have that moment of after the surgery being kind of shocked by the extent. If I missed this, I apologize, but what do you do? This was 10 years ago. What do you do now? What's your choice for a tumor or lymph node?
Dr. Hall's office takes over medical oncology, and sometimes some patients get immunotherapy, but typically we don't complete the lymph node dissections just for a sentinel lymph node biopsy. Now, in patients who have positive nodal disease and things like that, it's different, but you probably would not have that neck dissection done today.
Yeah, you had a grossly positive node and got the node dissection. But even then, as you heard from the earlier talk, downstaging up front for that node would likely take place now. And if there's a clip or a marker in there such that that could be found as the index node you heard about and removed, and if there's no evidence of melanoma, we don't think you need the full dissection, even if you came in with an obvious abnormal node. And she's really talking about MSLT2, where a sentinel node's positive, and we know completing the node dissection does not improve survival. So diagnosed now with what you had, very different approach. Yeah. Other questions? So I've done the one thing about the margins, and I think some people know this because some people have had this surgery. You showed the big scalp things. The melanoma of the face, the ear, the nose, as you said, I think everybody would go with 1 centimeter margins. The scalp's a little different for two reasons. One is it's easier. You're almost always going to need to do some kind of reconstruction, skin graft or other. And there's a higher local recurrence rate of scalp melanomas than there are for face or ear or nose. So it's not uncommon for a thicker melanoma to go with a 2 centimeter margin on the scalp, but almost uniformly, no one does the 1 centimeter margins. You heard about the Melmart study that she mentioned for 1 versus 2 centimeter margins throughout the body. Nobody's even questioning that for face. We don't even want to consider a 2 centimeter margin for face. Everybody's going to get a 1 centimeter margin for that. So questions about preparation for patients afterwards. You mentioned talking about potential facial nerve deficits or others. How do you set them up for appropriate expectation? Do you let them see photos or talk to patients of testimonials to know what that's going to look like in the short run and what it's going to look like 3 to 6 months later?
It's patient specific. Some of my patients really want to see pictures and some don't. If I have high concern that we will have a facial nerve injury or paralysis after surgery, I almost always have them meet one of my facial plastics colleagues before surgery, because they will often do facial nerve rehabilitation, and it's helpful for them to meet someone else who might be a part of their care team, even if it's in the future, 6 months from now, because they can kind of give a little bit more of a sense of what we might do to fix that, what those procedures might look like, and what their ultimate outcome might be. So that's always another person on the team that they will usually meet if I think that's going to be an issue.
Dr. Hall.
Oh.
You have one.
I just want to give a shout out to the doctors, the surgeons. We had a surgery to remove melanoma, and there was a drain put in and a graft made. The graft failed, and then the drain plugged up. And so what we thought would be a 2-week recovery process turned into more like 2 months. But the surgeon who had done the surgery responded in text to all of our questions and concerns within 2 or 3 hours every time. And he was working a full load of surgeries, but he kept responding. And so that lowered our anxiety a lot.
Yeah, thank you for that.
When I'm seeing patients who've had head and neck surgery and examining them, I sometimes can't even tell which side their surgery was on if it's been a few years, which is truly remarkable. But they do often mention that the sensory, that they continue to have numbness. And I'm just wondering what the long-term, what you would tell people to expect, or what the long-term expectation is for regaining of nerve function in terms of sensory nerves.
Yeah, great question. So I think most people get most recovery in 6 to 9 months, up to 12 months. I think by that point you have what you will have. And a lot of people have persistent numbness that it goes on forever, especially of the earlobe, depending on where they were. And that's really bothersome to people who wear earrings because they do it by feel and not by touch. So, or not by looking in the mirror. That actually is a really bothersome complaint from a lot of my patients. So I think, you get numbness and tingling that happens over that 3 to 9 month period when you see some nerve recovery. And then after that, by 12 months, I think you're where you're going to be. And I always caution people that they will probably have some numbness that's never quite the same.
Great talk. Thank you. She got note about 5 days notice to do this talk. I think it's pretty impressive. Thank you. So we're going to switch to a different portion of our meeting we always save for the end. Now, those of you who've been attending this for a long time, I'll do this back and I'll use this one. Know that patient stories have been part of the symposium since the beginning. I think I mentioned 2006, Katie Bunker, age 16, shared her story with node positive melanoma with the entire room, took the place down. So COVID took the legs out from underneath us, and we did not have a symposium in 2020, as you may know. And then when we restarted, because we were not going to be in person and we felt patient stories in person give the respect to the story more than trying to do it virtually. So we haven't had that. So this is our first year, I'll call it back, because to me, this is the most important part of what we do, which is share who we are, what our stories are, and how they've affected us. And the people who volunteer to tell their stories, and I know there are one or two in the audience who have done this in the past, my gratitude continues for you. There's a component of bravery. There's a component of need to get the word out, but there's also a component of, I don't really know what I'm going to say, and I don't think it's very interesting. And it always is exactly interesting because you connect to the people who've gone through this. So I want to thank the people who've already done it. I want to solicit those of you who might be interested in telling your story. Those of you online as well, for upcoming symposia, please identify yourselves. And we make sure we do that in communication with you, that it works for you to tell your story. So I think that's really important. So we have two patients willing to share their story. One brings a village right up here who will be our closer for the day with her village. One going before her, very brave soul, who will tell his story. But I wanted to start off the session, not with a story, but with reading a paragraph from another member of our audience, Debbie Gessert, who is right there in the second row, whose husband passed away in March from melanoma after 11 years. And here is what she just sent as an email. She said, after a melanoma journey that began 11 years ago, my husband died 6 weeks ago at our home in Ocean Shores. Michael had been treated by many specialists, the UW and SCCA. Dr. Sylvia Lee was his oncologist, Dr. Otto Moshiri was his dermatologist, and one of his surgeons was Dr. Bird. Just after his death, the invitation to the Northwest Melanoma Symposium arrived by mail. I know that this is an event for patients and caregivers, but is it open to those like me whose spouse has died of this dreaded disease? My husband of 47 years faced his initial diagnosis, surgeries, metastasis, 2 years of immunotherapy treatment, two side effects of treatment, one severe and one life-threatening, terminal diagnosis and hospice, all with a positive attitude and thankfulness to the medical community. I'm honored to be his wife. So to answer your question, it is absolutely appropriate, and we are delighted that you're here. Your message, you already heard, it resonates. We're not going to be talking as much about caregivers, although our stories may very well include caregivers, but you represent the caregiver who is often as involved in different ways in this journey. So thank you for the message and thank you for being there.
Okay. My husband didn't die. There was no and he sit here and hear this. And I'm his friend. And I'm not different from you. We are a community, whether you are the patient or the caregiver. I mean, you're a caregiver. You're more than a caregiver. You're my love. We are a community, and I feel that way now.
Thank you, Debbie, very much. I'm going to have Dr. Hall come up and introduce our first storyteller. Story in the best sense of the word. Oh, I'll bring it.
Great. So I am very excited to invite Mr. Mike Gaines down to the front. I have met Mike for the first time just a few months ago, but he's been a patient of ours for a while, and I think he has a remarkable story that he's generously offered to share with us. So come on down.
Absolutely.
And before we get started, I think you had expressed if there were questions from the audience that came up, you would be okay to field those. We talked
Absolutely.
about that, but I just wanted to
Yeah.
confirm that. So feel free if you have a question for Mike to raise your hand. This will hopefully be kind of a conversation. So thank you for doing this. I'm wondering if you could take us back several years to the time that you were originally diagnosed. Tell us a bit about what your life was like and what led to the diagnosis and how that felt at the time, if you can.
Of course. The first thing I want to say is that I'm here for people like your husband. I might as well lose it right at the start, right? I'm driven to pay forward, not just for the kindnesses that I've received from medical professionals over the past 10 years and fellow patients, but for the thousands and thousands and thousands of people who weren't as ridiculously, insanely fortunate as I have been to go to stage 4 right after immunotherapy became available. I mean, literally 6 weeks. To be surrounded in treatment by people who weren't going to walk out. And to be, in the case of one nurse who'd been there 12 years, I was the first one. So, and I read a book by a woman named Mary Elizabeth Williams, who's a writer for Slate, who was one of the first study subjects at Sloan Kettering back in 2011, 2012. And she made it, went through levels of hell that I can't even imagine. Nobody else from her group survived. So if I can do or say anything that gives back some of that, that's one of the best purposes in life that I could imagine. And thank you for your story. And thank you for getting me crying before we even started. So my first diagnosis was when I got out of the shower in 2013, right after Christmas. And I swear to God, that lump on my neck wasn't there when I went into the shower because I shaved first. I came out and there it was. And the head and neck surgeon to whom I was referred, remarkable woman, 6'2" or 3, pregnant with, I believe, her 8th child at the time that I met her. I'm not surprised she retired shortly thereafter. And I will tell a story just for you because she's the one who broke the news to me that the lump on my neck was malignant, which we expected, but that it was not the lymphoma that I expected. We were both shocked that it was melanoma because I had no primary. I was one of the 2% that didn't have any skin manifestations at all. And so when the PET scan came back negative, and it was confirmed that there was a reason to go in and have the surgery, because if the PET scan had been positive at that time, they'd have canceled the surgery. And I came bouncing into the ER. I was so excited. I'm about to lose a third of my neck and I couldn't wait. I was like, get this sucker out of here. And the entire surgical team was female, all 5 people. And of course, I expressed my delight at that. And my surgeon said, "That's right. And when in future years, people admire this spectacular scar I'm about to give you, you can tell them that 5 beautiful women knocked you unconscious and cut your throat from ear to ear. And just leave it there. And I exploded. The last thing I heard in my own ears before I went under was a room full of laughter. And I've often reflected that if I hadn't waked up from that 6 hours of surgery, that would have been a beautiful way to go out. But I had the surgery. The recovery wasn't a whole lot of fun. The 2 things that I love doing most are singing and playing soccer, and I couldn't do either for a little over a year, but bounced back from that. And then, as reflected by the study that you mentioned, back it came as stage 4.
And if you wouldn't mind, what was your life like at the time of your diagnosis? You mentioned what you liked doing, and how did your feeling, in terms of work and family or friends, how did that change kind of around the time of your diagnosis, or did it?
It really didn't, because for some reason, I was pretty confident that it was going to be a one and done. And the doctor explained to me, Alan Al-Ghazi from UCSF said it was a coin flip, might never come back. And after a year, we were getting increasingly comfortable, and we bought a beach house on the coast in Oregon, and we were moving on. And then, there was a pain in the belly, and the whole thing shifted.
And that's a natural lead into what happened next. Do you mind telling people the next major speed bump you encountered?
It was a mysterious lower bowel blockage that didn't show up on the CT scans. So Ian and I went to this local country hospital in Crescent City, California, and they didn't have. This is another incredibly lucky break. They didn't have any resident surgeons in this little hospital. They had a rotating surgeon system. And the guy who opened me up at 11 o'clock on a Friday night happened to be not only a cancer specialist, but a melanoma specialist from John Wayne. And he knew immediately what he was seeing. And he, widened the field and explored everything. Absolutely could not believe that he didn't see any other metastases, because it was a big sucking tumor. Took it out. Off I went to UCSF to find out that there now was a treatment. As of 6 weeks earlier, immunotherapy had been approved, and they had all these drugs lined up for me to try.
And if you can remember, and it maybe very reasonably was a blur, but if you can put us back in time, the melanoma had come back kind of dramatically, resulting in you having emergency surgery. Do you remember how you felt about the future and what might come next at that time?
I was really more concerned about my wife and my mother-in-law, who were for the moment left alone in this big old beach house that had just had a wall blown through by a big storm. So they were dealing with a house full of, floods and contractors, and 40 degrees in December. So they're bundled up, and I'm concerned about how they're going to get through it. English is not even their second language, it's their third. And they're dealing with insurance agents while I'm stuck in this little country hospital. So I wasn't even really worried about me. I was concerned about getting them through it. Once I got back to San Francisco and started looking at the treatment options, then I started to feel a little bit more comfortable with the process. I was knowing that there was a treatment and there was something we could do. That hopefully at that point it was about extending my life a year. Now there was no thought that it was a possibly permanent treatment, because it was so brand new that it was just. Dr. Al-Ghazi told me to live as if I had 2 years. which is, as he said, is a good philosophy of life anyway.
And I think that's a great point, because at the time when you received the treatment, we'll talk more about that in a second, but the curves that we saw earlier today are, 8 to 10 years of follow-up in patients, but we didn't have 8 to 10 years of follow-up when you received the treatment. So this was really cutting edge. And so it sounds like there was quite a bit of uncertainty about how efficacious this would be and what the future held for you.
Yeah. Yeah.
And would you mind telling us, what do you remember about how immunotherapy was described to you, and kind of, if you remember at all?
Well, yeah, he said it's a lot easier on your body than chemo, which sounded great. He said you should be able to lead a fairly normal life. If you got trips you want to take while you got the chance, you'll be able to take them, without taking along chemicals that you have to be plugged into. All that sounded pretty good to me. I started off on the Ipi-Nivo combination, the Opdivo and what's the other one? Yervoy. First treatment went great. I felt wonderful. Second treatment went kind of south, and things actually went really south. That was the only night that I really came close to not making it, because the drug attacked my pancreas. And I remember they'd given me a long list of bad stuff that could happen with the immunotherapy, and that wasn't even on the list. It was a virtually unknown complication at the time. I lost 16 pounds in 18 hours. Yeah, it was just about like that. And I felt fine the next morning. I was on an insulin drip. I was a type 1 diabetic, the most chicken-hearted needle phobe on the face of the planet, who thought it was ironic enough, one of God's great jokes that I had become a cancer patient. Now I was going to have to stick a needle in my belly 5 times a day.
And so
It was a thrill.
Just to summarize that, because we've talked about it. So as a consequence of the immunotherapy, you developed autoimmune diabetes, which we actually heard about way in our very first talk from Dr. Sharif, as a rare, but really life-altering side effect of treatment. So how did, just from my perspective, it sounds like you're in this, I imagine, dizzying place where the short and intermediate term is highly uncertain. It's dealing with a life-threatening illness, and now you're dealt another serious illness that wasn't even on the table before. How do you begin to deal with that?
For me, it was just one step at a time. How in the world do I put this needle on this thing and actually without fainting, which I actually did the first couple times. And then it was all about a really sharp education curve on getting used to the new drug, the Keytruda, and learning how to dose myself with the insulin, and what time do I do this, and it just sort of fell together. It was truly amazing. This was in February. By May, I had regained 15 of the 30 pounds I had lost in the whole process. I was back on the soccer field, back in the gym, and life just sort of went and tilted back to something resembling a new normal. And it was basically just keep my head down and put one foot in front of the other.
And as you mentioned, around that time, your medical treatment changed to pembrolizumab or Keytruda. Did you have any other side effects or issues during the course of the treatment that limited or impacted you aside from the diabetes?
Nothing serious. I had some skin ulcers. Got a few scars from that. I had some skin itching, which I still have. Thank you very much. Muscle cramps and things like that, but nothing really terrible. Nothing really that I couldn't handle. And over the years after treatment ended, it just sort of dissipated, except for the itching. And it felt like an almost natural process. And at that point, I was resigned to doing it the rest of my life. That was something that I was simply going to have to live with.
And so, as you mentioned, so shortly after starting your initial immunotherapy, you had this quite severe complication, which you recovered from and adapted to remarkably, sounds like. And then you went on to continue to receive treatment. As the months went along and there wasn't any evidence of new cancer, how did that feel, and how did it start to change things about how you thought about the future?
Not at that point. Where it really changed was, and this was an earthquake for me and my doctors at the time. Merck came out with a study in May 2017, announced that from their original patient panel, they had a segment of complete responders, and they had taken them off treatment after 2 years in the study. And a year after coming off treatment, they were all still alive, and 94% of them were still cancer-free. And that's what flipped the world for me, because at that point I was 18 months in, and there was a possibility that I was not going to have to live with this drug the rest of my life. And there was a possibility that I could live a whole lot longer. And that was really the turning point. I had just come back from Europe. I had been, hosted by my favorite professional soccer team in England. This was a farewell tour. I was never going to see these people again. Whole thing changed right there.
As we're talking, I feel like your case is a brilliant example for why we have the symposium, and the title's From Science to Survivorship. So you're by the timing of when your recurrence happened, you've been on the cutting edge, the leading edge. This was a new treatment. No one really knew what to tell you about the prognosis in any sort of refined way. And then as you were on treatment, the first data came out about that people could come off and seemingly do well. And then it just strikes me that you really are the science. And then you mentioned some of the survivorship. I'm wondering if you could share with us, you stopped treatment around 2018, is my understanding. It's been about
December 2017. Yeah.
2017. So it's been over 5 years. How has time looked after the infusion stopped? And how does that differ to when you were still getting treatment, if you could?
Well, it's funny. I still feel like cutting edge. I met when I first moved to this area a year and a half ago. First thing I had to do was find a new dermatologist, and I met Dr. Rasmussen in Bremerton. And he's been in the field a long time. First time I met him, he comes bursting into the room, still fully gowned right out of a procedure, grabs my hand, tells me that he's been participating in research on advanced melanoma for decades, and I'm the first stage 4 survivor he ever met. Wow. Really? And he was as emotional as I was. I remember Dr. Taylor at OHSU in Portland, offhand telling me that I was in remission. What? He'd never used that word before. It's not just huge for me. It's huge for people who deliberately chose to go into a specialty of medicine where every patient died, most of them in 6 months or a year. Dr. Algazi in the video talked about the reason they had so much trouble doing research on this was because the patient base disappeared on them in 6 months. And I can't even imagine what it's like to devote your life to something like that and then suddenly have all your hopes answered. To see your patients walk out when none of them ever did, it's got to be incredible. I mean, it's pretty cool for me, but for people who devoted their lives to it, that's overwhelming.
It's
That
pretty cool for us
makes me
too.
cry.
I'm pretty confident I can speak for the physicians when I say
I
that
bet
when
you
we see
can.
something like that happen, that's pretty darn cool.
I'll bet you can.
Mike referenced a video. So you were profiled in a PBS special about kind of the changing face of melanoma treatment.
Yep.
And we're going to share that in the post symposium, the link to that, if anyone's interested in watching it. It's quite inspirational.
And for anybody who does watch it, they profiled a young lady who was about to have the same neck surgery that I had. And she was 30 and had just 29 and had just gotten married. And not to spoil the spoiler, but she made it. She's clear.
I want to open it up. Does anyone have any questions they'd like to ask Mike? I have a list here, but if there are things on people's mind, this is, I think, yeah, let's get a microphone so those can hear the question.
Hi, Mike.
Hi.
My name's Deb.
Hi,
I
Deb.
was diagnosed with stage 4 in 2010. So unfortunately, I had to go through nasty IL-2, anybody? Before IPI became FDA approved.
There's one person raising their hand in the back. And
Oh,
IL-2.
hello.
So
Oh,
just
hello.
I didn't want you to feel alone.
Wow.
So, yeah, stage 4, here we are. Here we are. So I actually, because of what you were just saying, I am curious in the room here. I'm out of remission. So I'm back in treatment. Opdualag though. No side effects. Opdualag, big fan. Can I just see how many people here have been dealt a stage 4 diagnosis? Yeah, I'm just curious. Okay. Just really wanted to know because, well, yeah, Debbie did. Right. Thank you.
I have a question.
Yeah.
You mentioned itching, and I think although you've had amazing results in being free from cancer for such a long time, immunotherapy has impacted you, and you mentioned the diabetes as well. Could you talk a little bit about things you experienced that you think might still be the sequelae of treatment that was delivered 5 to 6, 7 years ago?
Well, I'm so happy to be here that I obviously I don't hold any grudges against the immunotherapy drugs. You know, I mentioned to I'm sorry, I forgot her name, the counselor, the psychiatrist.
Dr. Bates.
Yeah, Dr. Bates. I recently had some conversations with one of her colleagues because I'm dealing with the frustration of the diabetes, which drives me nuts. I mean, when my pump and my monitor go off, I sound like R2D2. I only had one emergency room visit because of the cancer. I've had 4 because of the diabetes. It's a real pain in the ass, excuse me. But as a doctor first described to me when I was diagnosed, it's a terrific trade-off on stage 4. And, you know, I still have such vivid memories, as I'm sure many of you do, of being, you know, treated in a room full of 40 people, you know, some with ports and some with lines, and people in a great deal of pain, people experiencing levels of horror that I mostly avoided. You know, I've always, you will remember that the first conversation we ever had is a conversation I've had with every oncologist. Along the way, from day one, I've been absolutely determined not to die of cancer because I I guess I don't have the courage to go through that process to the very end. I've seen it. And I won't live in a state that doesn't have assisted suicide. Because if I ever get to the point where there's no other off-ramp, I'm taking my own path. Everybody else has to choose for themselves on that. But I want to go out while I'm still me. And that's always in my mind from the days when I would sit in the infusion centers and look around the room and think, wow.
So to build on that a bit, maybe ask about it in a different way. It sounds like even in the present state where things couldn't have predicted or asked for, 9 years to go by and this to have been the result.
Yeah.
But you still think about, it sounds like, the possibility of the melanoma coming back, or at least that it's something that there's an awareness of for you. You just mentioned that thought has crossed your mind. What is your relationship to melanoma now? Is it something that you think about a lot on an average day, infrequently? Just how does your cancer history affect your day-to-day life now?
It's funny you should ask that, because I just had a really sharp alteration of that. My relationship to melanoma over the past 5-6 years has been about survivorship, of being so happy and grateful that I'm here and experiencing the life that I'm experiencing, that I haven't gotten tangled up in the cancer aspect of it till just a couple of weeks ago, when Dr. Rasmussen found a little spot on my leg, more or less assumed it was something that shouldn't be there. And the next morning, the nurse calls me, leaves a voicemail with a, we do have malignancy there, and, please discuss, please call us to discuss, coming in and getting it dealt with as soon as possible. Fine. At that point, I figured probably a basal cell. I couldn't reach her the rest of the day. And the monster started to circulate. And even if it had been melanoma, a little spot, it's nothing, but it triggered something. And I didn't sleep that night. My glucose went up to almost 400. My pump was giving off steam. And that was really the first direct realization that I still have somewhere way down deep there, that little ticking time bomb of fear. And it's, I'm 7 years into remission now. But it was totally unexpected, totally unexpected.
Thank you for sharing that. I mean, that I think that's important to share, that, you remain on the cutting edge. So I think that one of the questions that came up earlier was around the word cure and what that even means and how that applies. And the answer is, we don't entirely know. We don't have a great way to classify you.
Are you guys using that word yet? Just out of curiosity.
It's very doctor specific, I think, who likes to use that word. I like no evidence of disease, which was a term that was referenced earlier.
I want the C word, okay? I want to hear it, because I remember hearing remission for the first time. Did you just say that? And yeah, I would reach for that word.
All right.
We want it.
Any other questions for Mike? Here in the middle.
Hi, Mike. That's an
Hi.
amazing story. I can't help but think your attitude in dealing with all of this has been what's helped you so much. I call it survive to thrive. I've survived melanoma and a heart transplant.
Wow.
And it's all about quality of life. My question is, how has this affected your relationship with your wife, your mother-in-law, your close family? How have you seen them deal with this, what you've gone through? We don't have a choice.
Yeah.
But, it's something that has concerned me, and I think most patients that are, chronically ill, it definitely affects relationships, and I just want to hear a little bit about yours.
I would love to hear a little bit about yours at some point, because I know dealing with transplant anxiety has got to be something similar to dealing with cancer anxiety. It's amazing. It's an amazing story. Actually, I saw both sides of the coin, because my last remaining immediate family member was a brother who blew me off when I hit stage 4. My wife's family, my wife's Chinese family is my family at this point, basically. And I feel cherished. I feel coddled almost. Mom is 81, and dingy is a strong word, but she's a little butterfly-ish, but she checks on me every morning. First thing she gets up, she comes to wherever I am and gives me a look over and gives me a little pat on the shoulder just to make sure I'm fine. That's the kind of thing used to drive me crazy when I was younger. I hated people, checking up on me, poking me. Yeah, how you doing? How you doing? Oh, leave me alone. I'm fine. I sort of like it now. I really do. And, when mom's not looking, I'll blubber up, as you've seen me do 20 times today, because it feels that good. And I don't know about you, but if I checked out suddenly tomorrow, I'd be doing it from a good place.
Well, I think that perhaps that's a natural place to wrap up.
Okay.
As we queue up for the second story, I just want to thank you for sharing your story, and with everyone, truly a remarkable story. And like I said, we will send out a link to the special that you were a part of for those that are interested in watching. So thank you very much.
So we have our closer. You know what a closer is? First of all, it's not a competition. Everybody's story is their story. I love when people come with villages, but I like it even more that they have a village. I've had some patients who have been diagnosed and come in with pretty serious cancer. And I say, well, is there anybody in the waiting room for you? No, it's okay. How about anybody you want to get on the phone or make a tape to them? How about friends, community, church group? No, that's okay. And it just breaks my heart to go through this alone. Hard to imagine. So I acknowledge the village that's come with you and the fact that you have earned a village, because that's why they came with you. So Rachel Pritchett, you can stand at the podium and I can just.
Does this one work? Oh. Thank you. I'm Rachel Pritchett. I come from Bainbridge Island, home of the pickleball, birthplace of pickleball. As we discussed this morning, they're crazy about it over there. I'm dedicate my remarks to Debbie, and we walk with you in your journey in grief. I'm a double-barreled cancer survivor, having had melanoma and thyroid cancer. It's my hope with all the work that we've done that we've tamed these two beasts. Thanks to Dr. Bird and Fred Hutch for these gatherings. I'm grateful for my care, and so I'm sharing my story with you today. My hope is that we'll find something in common and we can connect. I have found in talking to a few people already today that there is a community here. So perhaps we can continue this conversation in the future. My husband Lloyd is here, and our 3 daughters are here, Geneva and her brand new husband, Tommy, Sonia. Our daughter Hillary is listening from Atlanta. My brother Jeff is listening from Bremerton, And my good friend Jim is listening from Wilmette, Illinois. 7 years ago, I was watching an unusual spot on my leg. My doctor said not to worry, but it was growing. It was resembling some of the images that we saw, a crusty mole, risen a little, maybe a little tender. Being the mature person I am, I put bandages on it, bigger and bigger ones, and whiled away many months that way. But inside, my inner voice said something was very, very wrong. I'd bring it up again. On a Friday night in January 2016, I was the last appointment at Virginia Mason Medical Clinic on Bainbridge. It was the winter solstice, and it was the longest night of the year. It was pitch black, cold, and rainy outside. In my appointment, my doctor was chatting away about the books he read, not unusual. I tried to look interested, but I needed to jump in. Finally, I rolled up my sock and showed him my sore. He turned white. I had a commitment that night. Lloyd and I were going to meet up on the ferry with some of our church friends. We were headed to a homeless shelter on the Seattle waterfront. On the longest night of the year, there's a service there where we light candles in memory of homeless people who have died. I couldn't get warm that night. I was frozen in my mind. It really was, for me, the longest night. A new chapter in my life had begun. First thing Monday morning, the surgeon at Virginia Mason Medical Center in Seattle cut out the growth. A few days later, she cut a 4-inch square site. I don't know what all this talk is about centimeters. We were talking inches here, and nearly an inch deep. The cancer was advanced and very deep, at level 4, not stage 4, level 4. My leg looked like a great white shark had taken a giant bite. As she grafted skin from my thigh onto the hole, in another surgery, they removed lymph nodes in my groin to see if it had spread, and they dug deep into my back to remove some precancerous growth. I recuperated in the hospital for a week. During that time, I had a large machine attached to my leg that was slung over the end of the bed. It was a vacuum that somehow sealed the wound together, and it worked really well, but infection spread throughout my body. There were lots of invasive tests. They stuck a foot-long needle through my side to do a biopsy of my liver, more biopsy scans, ferry trips, trying to not get trampled by the charging hordes of ferry pedestrians, struggling to catch the number 12 bus up the hill, wearing this big boot on my leg. You'd think I'd be depressed. They all said it was real serious, but I wasn't. I was just fine in my head. My inner voice told me that this isn't going to kill you. Here's the thing, as much as they were expecting to find spread at that point, they couldn't. But I knew I needed a plan. I would consolidate my future care into one place, Hutch, had cutting-edge providers who specialize in cancer and world leader for research. I'd have a strong team in place should things go south. The great Spanish tenor Jose Carreras, who has always inspired me, was treated here and survived in 1987. He was so grateful that he set up a foundation that raised money for research. One of the researchers earned a Nobel Prize. So if the Hutch was good enough for Jose, it was good enough for me. I transferred my records here, which was difficult because since the Hutch and Virginia Mason don't share the same electronic records system, some tests do not transfer and were simply lost. My medical oncologist at the Hutch, Dr. Bhatia, put me on a 5-year plan where every so often I'd come in for all the tests. 5 years passed, nothing had spread to my knowledge. That said, during that time, I declined to have some of the more comprehensive scans. I feared that the accumulated radiation might be harmful later. I'm not sure that that was the right decision. As for participating in trials, I initially said no, At that early point, they seemed to divert attention to the trials and away from me at precisely the time I was looking for basic answers. Now, of course, I'd say yes. After 5 years, the statistical probability that the cancer will spread decreases and you rejoin the general population. I said goodbye to Dr. Bhatia, but very soon in early 2022, I noticed a faint dot on my leg near the same place about the size of a small nail head. My melanoma was back. Dr. Bhatia said we couldn't keep addressing this with surgery. I was getting pretty cut up. So we agreed on a year of immunotherapy, monthly half-hour infusions of nivolumab in one arm or the other, 480 milligrams. Thanks to these symposiums, I had a clue what that was. It helps, I don't have to explain that. Now here's where it gets complicated. In the midst of all these tests leading up to the immunotherapy, I was undergoing an ultrasound. The doctor stopped a probe on my left neck. I got a call. It was thyroid cancer. Dr. Roth, my endocrinologist, suggested it could have been something in my past that caused this. I'm a retired newspaper journalist. Back in 1981, I was a young and probably pretty stupid reporter in the heartland of America. A crop dusting plane hit a utility wire and crashed. Clouds of chemicals rose up over the fields, and I was in it for hours. Maybe that was it. In any event, thyroid cancer is pretty easy to get rid of, so the outlook was pretty bright. So a year ago, just after I started my immunotherapy, Dr. Bird and his team removed my thyroid and several adjacent lymph nodes at the UW Medical Center. It was absolutely fascinating, a fast-paced pre-operating room where they give you a wonderful warm blow-up plastic blanket and you lay comfortably with several other people just like you, amid nurses and doctors carrying out tasks, talking to each other, to you. It's all new to me. The recuperation from the surgery was long and arduous, but again, I was in good shape in my head. I took a radioactive pill to clear out any residual cancer and isolated for several days. After some months and with physical therapy, I was back in the saddle and my neck feels good. Having melanoma and thyroid cancer simultaneously poses challenges for my doctors who must determine their correct level of levothyroxine to substitute for hormone loss from the thyroid removal in context with the nivolumab. We settled on 175 micrograms of levodopa daily. I just completed my year of immunotherapy for melanoma. I had a pretty mild standard reaction to the therapy. There were periods at the beginning where I would become tired. That passed. Midway through the year, I took a few minor falls. My tongue got dry, still is right now. So now the melanoma is not presenting itself. I get regular blood test imaging, in-person dermatology scans, which is the most important thing that I am told that I can do for myself. I declined to get the new whole body mapping form of dermatology that's available now at the UW. I did this because I'm 67 years old. If I were 27, of course, I would have paid the extra few $100 for that. I'm keeping a very close eye on my leg. On the thyroid side, I'm doing all the tests. There are a couple of lymph nodes we're watching on both fronts, but by far the melanoma, we are watching and waiting. We are watching and waiting. So how did I get into this mess? Two things. First of all, I stayed out in the sun too much when I was a child. I lived in my swimming suit. The culture was different. It was good to get a real dark tan, and it was a source of pride to get peeled and blisters. And you remember the copper tone ads and all that. That was me. As an adult, I had a way of life that I suspect may have weakened my immune defenses, perhaps inviting cancer to set up shop. For many decades, I was in the trenches, deep in the trenches of a newsroom at a busy newspaper. Well, there are big rewards for living this life, interesting people, important stories. There's also a lot of stress. Lloyd's also a journalist under similar demands. We had 3 young daughters at home. Somehow we made it all work well. But I might have allowed the stress of those busy, exhausting, and yes, happy years to chip away at my health. I was heavier than I should have been. I have never had the time to exercise. I drank too much alcohol for relief. I smoked. I never got enough sleep, and I was chronically, deeply exhausted. During those decades, I had pneumonia 3 times. My intestines tied themselves into a knot, and I had to have that cut out, something called an intussusception. I was in a state of what I call being life tired. I wasn't tired of life, I was tired in my life. I believe my life, as I chose to live it, no regrets, allowed for the melanoma. So how do I cope? First and foremost, I have my faith. Wherever my cancer takes me, I'm okay. I have a caring family. Lloyd has driven me to the ferry and waited outside the operating rooms. He's helped me tackle the financial assistance forms. And then we have our daughters. Texts, phone calls, visits, and their presence today is life affirming. I have a ton of gratitude. It just kind of buoys me along. With cancer, my gratitude keeps growing, believe it or not. Look at this place, look at these people. I didn't think someone like me would be allowed to receive care in a place like this, or that I could afford it. I've been in third world hospitals and this. Which brings me to another way I'm coping. I'm learning all sorts of cool stuff. I'm fascinated to learn how a big and busy cancer center operates, how all the bright young professionals juggle the many pieces of my care. I'm fascinated at the delicate work my surgeons do. I've learned a little about how imaging machines work. I've walked around and I've acquainted myself with this beautiful campus, and I've toured the new building. I've discovered that the cafe on the 2nd floor of the clinic has the best lunches for a special treat, although I usually just bring my lunch and enjoy it down at South Lake Union Park. I wouldn't have known any of this stuff if this hadn't happened. I walk to and from my appointments from the ferry dock, and I've learned a lot more than I previously knew about downtown Seattle. I interact with all the people, the drug addicts, the homeless, the Amazon workers, the tourists. I enjoy the architecture, the smells and the sounds. I stop at Whole Foods and get the ingredients I need for dinner. My walks are fun. Appointment days are not wasted days by any means. Another way I cope is having friends who know more about life-threatening diseases than I do. One is a breast cancer survivor. I asked her about the uncertainty. She said cancer becomes a part of you, whether it's active or not. It's not something outside, it's intrinsic. This helps me know who I am, and it helps me plan better. Another friend has given me courage. He's a caretaker at my mother's nursing home. He lost his career as an architect due to a degenerative disease that one day will end his life. He uses a walker and struggles to feed the residents and clear their dishes. Every day is harder, but this guy is such an affirming person. I was tending to my mother one day. I was sad. I had just received word that my melanoma was back. He asked me, "What's wrong, Rachel? You don't seem your usual self." What's wrong, Rachel? From him? You have to have courage. If you don't have enough of it, just borrow some from somebody who might have a little more. How else am I coping? Exercise. Before I get too self-righteous here, know that Lloyd and I spend just about every night watching old film noir movies on TV. Now that I'm retired and have time, I swim and I go to the gym. Bainbridge has a lot of trails, so I walk a lot. I'm trying to get myself in good shape to ward up future occurrences of cancer. I eat and I sleep well. I have zero stress. All this too late? Maybe, maybe not. I feel great. Lastly, I got financial aid. We were worried that we wouldn't be able to swing this as we transition from paychecks to fixed incomes. So I'll conclude now. A New York medical center has one of those ads on TV going about a cancer program. In the ad, a middle-aged woman dramatically gets the bad news from her doctor. Grief-stricken, she parades through the next 2 minutes, tearfully sharing her news with all of her loved ones. The message in the ad is, you're going to lose everything and everyone and endure a terrible death. So sign up for our program. I find this ad gratuitous and misogynistic. Yes, the news does hit hard initially, but I think most of us quickly take the bull by the horns, develop a plan, and live it out with grace and dignity, calmness. My particular plan includes faith, gratitude, family and friends, learning new stuff, finding courage when I don't have enough, and living a zero stress, healthy lifestyle through exercise, diet, and sleep. There are two narratives in my cancer journey. One is the one that takes place here, science. The other is my inner voice, soul. So science and soul. I listen to both. These have shaped the decisions I've made. I'm preparing my family for more good years, but also for grief. When our daughters were growing up, we gave them the tools of faith so that they know how to call on that faith should they ever choose to, and I know they'll take care of Lloyd. The Apostle Paul describes our going from a really bad place in our head to a really good place in our heads. First, our suffering produces endurance, and endurance produces character, and character produces hope. Hope doesn't disappoint. Suffering was the endless tests, biopsy, surgery, uncertainty. Endurance came from just putting one foot in front of the other. Character, I'm a bigger and wider person today than I was before any of this happened. And lastly, hope. I'm enjoying this hope right now, and I always will be. So what's your story? I hope we connect afterwards. Perhaps we can share emails and maybe get the conversation going. Thank you.
Oh, wait, don't go anywhere. We might have some questions for you, if you're okay with that. I think it's pretty obvious she's a writer. When you say hearing that, that was a wonderfully delivered story, and the content was fabulous. You said a couple of things in there. You indicated that you're kind of prepared for a recurrence.
Yep.
Right after that, you said you had no stress.
That's right.
In this almost the same sentence. Based on what you heard this morning, how do you reconcile those two
Boy, that's
things
a
in the
tough one,
same?
isn't it? It's just the way it naturally occurred. I guess my answer to you, Dr. Brewer, would be, what is the use of stress? I've come to realize it's a wasted emotion. It doesn't get me anywhere, and it does me all kinds of harm. So why not be happy? Can you imagine if I had let stress and anxiety rule since 2015, all those years of happiness and that I've had would be compromised. So it's something that I've pretty much taken to the curb and waited for the garbage truck out there. It's just not worth it.
Another question I have for you, as you got these diagnoses, your kids were probably young adults at that time. How did you, you seem like a caregiver. You're the one, again, you were tired because you were taking care of this whole family. How did you communicate to them what you had and what you were feeling, or be prepared for their responses?
I don't remember.
It's not meant to be a quiz.
I think you can chime in here. I think I just there was no secrecy. We're a close family. We just talked about it. I'm going in for this test. This was the result. I didn't include them. They have busy lives, teenagers, and and people in their 20s. I didn't want to bring every test and every result to them, but the major stuff I brought to them just face to face, one-on-one, and so they were all, so that they could be with me on my journey, and that so they could also be prepared. Is that how it was? That's how I remember it. Yeah, I kept it.
Well, I think you can see why patient stories make the symposium. I don't think there's any question, but thank you so much.
Thanks for the
Both of
opportunity.
you so much. I'll invite Dr. Hall to come up. And we don't have we don't have much to say. I think in closing, the stories kind of close for themselves. I think we'd love you to fill out the survey for how they went. We'd love you to either identify yourselves or others who might be potentially storytellers, and topics that you want to hear. We'd love to hear those as well.
Yeah, I'd just like to thank everyone for spending what seems like a beautiful Saturday listening to this. I think it's been a remarkable program. I think every year it's like, I don't know about y'all, but it's chicken soup for me coming here and being a part of this. So I know we're already looking forward to having it again next year. And like Dr. Bird said, please let us know what you want to see and how we can make it as useful and interesting and relevant as possible. So thanks to all of our speakers and to the Melanoma Research Foundation for their sponsorship and support of the event as well.
And the last person to thank, Ritu Shriyan, who organized this whole thing for months and months and made us look like we were organized. And she and her team are the reason we could pull this off. Thank you so much.
I co-sign that times 10. It would really not have happened without Ritu's
That
incredible
clock says 3:30 on the button. Have a great rest of your weekend.